foreign bodies at SMS Medical College, Jaipur. I am a senior professor and former head of the department ENT SMS Medical College, and I have an interest in pediatric airway foreign body. So this is a hospital where I am working. This is SMS Medical College Hospital, one of the very large institutions in the country. We have a 6,100 bed strength. This is our medical college. This is our OPD block, and this is ENT block. We almost see 60 lakh patients every year. Instructional course would cover theoretical aspects, the practical aspects, videos of the instrumentation, procedure, ventilation, and then some interesting foreign body cases videos. So now coming to the indications, Jackson's dictum says, in suspected case of foreign body, bronchoscopy must be done, as to failure to do so is more disastrous than the complications of bronchoscopy. So whenever you suspect a case of foreign body, don't hesitate to do it, because that's a dictum by the Jackson, who is the father of bronchoscopy. Now in ENT practice, the most common indication is airway foreign body removal. The second one is difficult biopsies. Difficult biopsies which flexible people are not able to do it because of the some or the other reason, that tumor is friable, it's bleeding, they don't have any control on the ventilation. So in difficult cases, we get cases from the pulmonary department for adequate biopsy. And then there are various flexible indications like malignancy, mediastinal mass, unexplained chronic cough, etc., etc. Now, contraindication of rigid bronchoscopy is ankylosed or unstable cervical spine, non-availability of appropriate equipment and facilities, lack of adequately trained personnel, trauma and trismus. If you compare rigid, your question I am answering, the rigid and the flexible one. The advantages of the rigid for the foreign body removal is that airway control is very good, the working channels are very wide, the extraction instruments are sturdy and wide range, then chances of losing the foreign body into the subglottis while taking it out are very less in rigid in comparison to flexible one. Then there is no airway compromise once you put in a rigid in scope, which is have a ventilation channel. If you put a flexible one in a pediatric patient with a foreign body, that means patient already has a compromised airway, and a solid lumen tube of the flexible one is further compromising the reduced airway. That is why it is not a good choice in pediatric age group, the flexible one, for extraction purpose. Diagnosis, it is all right, but for foreign body extraction, no chance of flexible over the rigid one. So rigid one is the answer for pediatric airway foreign body removal, and that's what our domain is. Now coming to the epidemiology, 74% of the foreign bodies are present below 3 years and 84% below 5 years. The death toll from foreign body among all has remained about 3,000 per year in last 20 years in US. There has been a bimodal pattern of death with peak at extremes of age. So less than 1 year and more than 75 years are risky patients. Now why this instructional course? Airway foreign body falls into the domain of many specialists, the pediatric surgeon, the thoracic surgeon, the pulmonologist. What I say is that use it or lose it. If ENT people are not going to do bronchoscopy, then it is other specialists which are going to take away from this. And I have worked with all these people, and what I found is that ENT guy is the most suitable to do rigid bronchoscopy, because we are trained to do tracheostomy as and when needed, whereas the other people cannot do or achieve the airway in difficult situations. So the most suitable is ENT surgeon for rigid bronchoscopy. Now airway foreign bodies remain a diagnostic and therapeutic challenge even today. Incidence of foreign body has not changed significantly over the years as children use their mouth to explore their surroundings. Early diagnosis and prompt removal of foreign body remains key to successful and uncomplicated outcome. Now why it is common in children? Because they put objects in mouth to explore their surroundings. They often laugh, talk, cry or play while eating. Then posterior dentition is not fully developed. So these are the reasons by which you can say that children have more chances of foreign body inhalation. Now this is very important, the history part. A positive history must never be ignored. A positive history must never be ignored, while negative history does not carry any meaning. It is a misleading thing. So what I have come across 30 years of experience, किसी प्राइमरी फिजिशियन के पास गया, पीडियाट्रिशियन के पास गया, पेरेंट्स को पूछा आपने देखा बच्चे को, you would say that no, there is no history of foreign body. But that does not mean anything, because child is playing outside, nobody watched him what he is doing. So negative history does not carry any meaning. Then foreign body causes sudden coughing, choking, gagging and wheezing. So any child who did not have an asthma kind of a picture earlier and develops these kind of features, the first suspicion should be foreign body inhalation. So the story starts from that point, that suspicion of the foreign body by the primary physician, pediatrician or ENT guy should be there. And in large number, positive history is absent. Repeated or persistent pneumonia demands investigation for foreign body. Now, what are the causes of delayed diagnosis? If the incidence was not witnessed or suspected at the time of initial presentation, very important. The cough reflex fatigued and the airway become tolerant without any significant sign or symptom. Practice of treating asthmatic or croupy children with antibiotics and steroids, temporarily obscuring the sign and symptoms, and failure to elicit the correct history. Many times when we say that there is no history of foreign body, but if you keep on asking the parents that आपके घर में कोई सुपारी खाता है क्या, और कोई nuts घर में पड़े रहते हैं क्या, if that is the situation, then you start suspecting that any family member who is eating a supari, betel nut, then there is a chance that child might have taken that. So eliciting the correct history would convert that negative history to positive history at some point of time. You all know about the types of obstruction depending on the size of the foreign body. Now, clinical presentation depends on the type, size and site of the infection foreign body. If it is a laryngeal foreign body, either the complete obstruction is there and sometimes death. Or if it is a thin foreign body, then hoarseness, croupy cough and stridor. In case of a tracheal foreign body, the same features as laryngeal. In addition, there would be audible slap, palpatory thud. That means if you put your fingers onto the trachea, you can feel the foreign body moving in the respiration. So that is called as palpatory thud. And bronchial is simplest, choking, coughing, wheezing and decreased air entry. Your ear should be trained to auscultate and see the difference between the two sides. Any pediatric patient with decreased hearing entry on one side is a suspicion of foreign body should be there. So your ear should be trained to auscultate the chest, which are normal and abnormal. And you will never miss foreign body if your ears are trained to auscultate correctly. Up to 40% of the cases, there is no positive finding in the X-ray, which is a common misconception amongst treating physicians, that X-ray normal, there is no shadow, there is no collapse. So 40% would not have any positive finding in the X-ray. So that does not rule out the chances of foreign body. The commonest finding imaging is obstructive emphysema. Suppose foreign body has got into the right main bronchus. So air is going in but not coming out, giving rise to expansion or obstructive emphysema and mediastinal shift to the opposite side. This is the commonest finding. Then if you are not able to diagnose or you see that there is some doubt, then this modality would almost 99% will diagnose the foreign body. That is HRCT chest with virtual bronchoscopy. It's a good modality in case of doubts, but not a routine modality to diagnose foreign body. Now our experience at SMS Medical College, we are doing almost more than 200 cases per year for last 30 years. And the common foreign bodies are groundnut, betel nut, gram seeds, whistle, etc. Now coming to these different sizes of the bronchoscope which are used, the common ones which we use is 3, 3.5, 3.7 and 4. These are the four common bronchoscopes. If somebody wants to start bronchoscopy practice, probably out of all, you can have these four and you can start. And even if you want to omit something, then 3.5 can be omitted over the 3.7, because 3.7 would cater most of the pediatric population by and large. So if given a choice to purchase one, I would say 3.7. But it is better to have one size up and one size down. Now, how would you choose the correct size? So choosing a bronchoscope somewhat smaller than the child's little finger would always give you a correct size of the bronchoscope. This is a rough idea that what size of the bronchoscope should be used. So just compare with the size diameter of the little finger of the child and you would be able to select the correct size. Never use an oversize because that is going to give rise to subglottic edema and patient would require a tracheostomy. So tight fitting should not be advisable. If it is going tight, go back and take a smaller size bronchoscope. This you all know, the anatomy of the tracheobronchial tree. Now these are various rigid instruments which are required for starting a bronchoscopy. As I suggested, you can start with couple of bronchoscopes and couple of forceps. So I will stress upon how it is to be used. This is a rigid bronchoscope. It has a 4 ports, 1, 2, 3 and 4. So this is for the light carrier. I'll show you the live also. This is for the light carrier. This is for the ventilation by connecting the Bain circuit. This is another port for jet ventilation or venturi connection. And this is a operating channel by which the surgeon is seeing and removing the foreign body. Now amongst these all forceps, ideally everyone should have all. But if you consider the capital cost involved, then probably I would say the peanut forceps and the alligator forceps are the two commonest forceps which are required, and that would cover 90% of your foreign bodies. So have at least 2 forceps working of alligator nature and the peanut size. Now I am showing a video to understand how it is to be taken up. So I recorded this just few days ago at my OT. This is a treatment unit which you use for endoscopic sinus surgery or anything. And then preparation of the trolley is extremely important, and surgeon has to see all instruments working personally. Do not depend on your juniors, because that is the most important aspect, to see that all instruments are there which may probably be used during the procedure. Maybe only 4 instruments are used, but then you see the complete set of the bronchoscope is there, this camera is there, Macintosh laryngoscope, endotracheal tube, this jet ventilation needle, flu-vog adapter, telescope, suctions, and different types of forceps. Everything you need to check personally. I am stressing upon so much because what happens in medical colleges, the residents are there, and if you depend on them, probably something or the other is always missing. And at the last moment, when the time is money, when the child is apneic and you are struggling for instruments, it's going to give you a disaster. So preparation ensures your 50% success. 50% success is there on the trolley making itself. Now coming to the anatomy, endoscopic anatomy, you can see the vocal cords, which you would see in the direct laryngoscopy every day. And you should differentiate the esophagus from the trachea by seeing the tracheal rings. And as you go in, there would be a carina or a keel-like structure which gives rise to 2 partition, that is right and left main bronchus. Now different parts and attachment of the rigid bronchoscope. I'll demonstrate and then show you the live also. So this is a rigid bronchoscope which has a holes at the distal end for the ventilation of the opposite lung. And there are 4 openings, 1 for the light, 2 for the ventilation, and 1 for the operating channels. And here are the markings, the size of the bronchoscope, the inner diameter, the outer diameter, the length, and everything is mentioned on the each bronchoscope. Now how it is to be connected? This is a prismatic light deflector which is connected. Now here I would like to say there are two slots on the light carrier, one medial and one the lateral one, the outer one. So if you push to the medial one, then the light is going into the lumen of the rigid bronchoscope. But while you're taking out the foreign body, it comes into your way, so you have to take out onto the outer side once the foreign body is coming out. So the assistant has to take out into the outer slot once foreign body is coming out. So this is how it is connected. You have a snap sound and the cable is connected. And this is a jet ventilation needle which is fitted into this port. And this is a side arm ventilation port, where if you are using a venturi ventilation, then you completely close it so that air is not leaked. And this is called as flue walk adapter, which is fitted onto the operating channel. And there are multiple openings over to this. Like there is a complete glass closure when you want a ventilation. If you want to operate upon, then you can switch the different options which are present on the flue walk adapter. You don't have to take out the complete adapter. Now coming to the ventilation issue, this is the side arm where you connect this connector, and an endotracheal tube can be fitted, which can ultimately be connected to your regular Bain circuit on the Boyle's machine. So this is a stopgap arrangement, but you can directly attach this Bain circuit onto the rigid bronchoscope. There is no need of this connection. You can directly connect the pediatric Bain circuit directly onto the bronchoscope. It's a simpler way of attaching the ventilation channel. So this is most commonly used ventilation channel, and this is a jet ventilation port. You put in a needle into this jet ventilation, and there is a switch here which can be pressed time and again to give jet of the oxygen inside. So as and when required, you can give jet ventilation, and once the saturation is 100%, you can take out in an apnea way, you can do it. Now coming to various forceps, this is a single action jaw where only one jaw is moving, and alligator forceps. The alligator forceps has a very strong grip because the teeth are backbiting. So like an alligator's grip, you will not lose the foreign body. This is a double action jaw, same forceps. This is a peanut forceps which has a space to accommodate the foreign body, which will not allow it to crush. This is a plain forceps. So now this is the optical forceps. Somebody was asking whether it is necessary to do optical forceps. It is not necessary, but if you have it, it is an advantage. So this can be fitted onto the this forceps, like I am showing you. There is a marking here which can be aligned, and then it can be locked. You can see the jaw movements. At the same time, you can see onto the monitor also that, and it's a very good teaching and training tool also, that anybody can watch what's happening inside. The only problem with these forceps are they are slightly bulkier for smaller children, where if you want to use a 3-size bronchoscope, probably it will not go in. Now, how it is to be introduced? In the left hand, you catch hold the Macintosh laryngoscope and lift up the larynx, and you would see the laryngeal inlet, as I showed you in the anatomy. Hold the bronchoscope in such a fashion, and then the beveled edge of the bronchoscope should be parallel to the vocal cords, so that and then once you enter into the trachea, you rotate 90 degree. So, just a second. So the vocal cords are like this. So beveled edge should go parallel to the vocal cord, and once it is in, then you rotate 90 degree. It's important so that you don't traumatize the vocal cords. And the cable faces the roof or the ceiling. Then you go into the tracheobronchial tree, and locate the foreign body. Now one more point, when you are locating a foreign body, what happens is a uniocular vision. So depth perception is not there. So how to do about it? You go inside, do not open the jaw of the forceps. Just feel the foreign body by touching it so that you have idea that you are at the accurate level. And then open up the jaw and catch hold of the foreign body. So because depth perception is not there because of the uniocular vision. So this is how you go and just touch the foreign body first and then catch hold of the foreign body. Now this is a cotton ball as a foreign body I am showing you. So there are two ways of extracting the foreign body. If the foreign body size is small, it is always better to take it through the lumen of the scope and take it out and keep the bronchoscope there for ventilation. If foreign body is too big, which is not coming into the lumen, then you can take out as a trailing foreign body. Like I will show you. Trailing foreign body, that means it is not taken into the lumen, but the whole assembly comes out along with the foreign body. So this is the actual procedure being performed. A pediatric patient with the right angle laryngoscope, Macintosh. The assistant has to be experienced one. He is ready with the scope and the light carrier. You see the laryngeal inlet, and then, as I told you, beveled edge should be parallel to the vocal cords. And once you enter in, then you rotate 90 degree and the cable facing the roof and take out the laryngoscope. So you would be able to see the tracheobronchial tree. The first instrument generally is required is a suction to take out these secretions in the tracheobronchial tree, and then you can visualize the foreign body. This is the suction which is going in. So I'll skip this. Now showing you a couple of interesting cases which are uncommon. You can see a crepe bandage clip in the larynx, which is very, very rare, but this is two flanges there and they were stuck up in between the two vocal cords. So radio-opaque foreign bodies are easy to diagnose for that purpose, but majority of the time the foreign bodies are vegetable foreign bodies which cannot be picked up on X-rays. The piece of locket, broken piece of the locket in the larynx. It's a vegetative laryngeal foreign body. It's common in the desert state of Rajasthan, and it typically person is going on a bike and is talking and suddenly he inhales this foreign body and it gets typically at the anterior one of the vocal cords, it gets stuck up and patient presents with hoarseness. A bell at the laryngeal inlet, you can see a radio-opaque shadow at the laryngeal inlet, such a big foreign body, and the mother has a tendency to swipe it out with the finger. It's a dangerous thing because you can push the foreign body into the laryngeal inlet and patient will die. So never attempt fingering these things. Whistles are common in subglottis, and sometimes child comes with whistling. You can have a sound of whistling, child is coming whistling to you because the air is flowing through the whistle. Coins are common in food passage, but here you can see coin between the vocal cords. Safety pin in the larynx. Once it is an open forceps, then it is difficult because you have to close it so that you don't traumatize the airway. Simple soft tissue nag lateral view can pick up subglottic foreign body if it is dense like a stone. So no need of doing a CT scan in these cases. Can you see the glass piece in the trachea? So just simple soft tissue nag lateral would give you a foreign body clue. Now this patient came to us in a respiratory distress situation. This video was taken just outside the emergency operation room. There was a history of tamarind seed inhalation. It's a notorious foreign body because of its large size and hygroscopic in nature. It's quite big and you cannot take it out through normal passage because of the hygroscopic nature and large size. So this was the foreign body, and the patient required a temporary tracheostomy to remove this large foreign body. And again, large size foreign body, particularly hygroscopic in nature, you should be prepared for doing a tracheostomy. Now, electrical fitting in the left main bronchus, a small video of this. It's very easy to dislodge the foreign body. You know, once you see the foreign body, there is a tempting tendency to catch hold as early as possible. That is wrong, because complete lumen is glistening, and just by small touch you would push it distally. So when you are seeing the foreign body, first take out the suction tape and suck around the foreign body, not touching the foreign body, and then go into and feel the foreign body and then catch hold. As you would see, the grip has to be strong so that you do not lose while removing the foreign body from the subglottis area, because inexperienced person can lose this foreign body, but in case you lose it, push it back with the scope. Don't allow anesthetist to ventilate, because he will not be able to ventilate if it is stuck up in the between the vocal cords or the subglottis. Earrings in the airways, another interesting foreign body. A remote bulb with wire, a small video of that. I am giving you an idea that what different kinds of foreign body could be there in the airways, and many people are not doing it. My point is that ENT people should be doing it, because they are the most suitable to do it. So you can see this remote bulb. Sometimes child comes with situation like bilateral lung foreign body. It's a very, very difficult situation. The saturation was just 80%. The surgeon has to be quick to at least remove foreign body from one side so that child can be ventilated. So this requires extra skill dealing with the bilateral foreign body, but fortunately the incidence of bilateral foreign body is very less. A groundnut is a very, very common foreign body, and you can see the foreign body here. Oh, sorry. Here I would like to stress the commonest foreign body is groundnut. When you try to catch hold this foreign body, because of the hygroscopic and soft nature, you tend to crush the foreign body if your grip is tight. And once you crush the foreign body and jet ventilation is going on, you disperse the foreign body throughout the lung fields. So the point is that grip should be optimum, not too tight or not too loose. Too tight, you will break the foreign body. If it is too loose, you are going to lose the foreign body in the subglottis. So it has to be an optimal grip for these vegetable foreign bodies, and that comes by tactile feedback, that how much grip is required. You can practice outside, keeping a foreign body for some time in the water, and then catch hold that how much force is required to crush or hold. So I'll skip this. Figure of 6 from the airways. A nail paint brush component. You can see this foreign body here in the left lung. A broken piece of jib into the lungs on the right side. A piece of nail on the right main bronchus. Chiku sheds. These are part of the chiku which went to and given rise to a collapse because of the chemical reactions taking place because of this foreign body. Betel nut, again a very common foreign body in India. A spring coil in the right main bronchus. Now this was a very challenging foreign body. Because pearl has all smooth edges, and it is very difficult to catch hold such smooth foreign body. So child required a tracheostomy in this case, and I prepared taking out this case. I went to the cardiothoracic people for giving me the catheters which they use for the stenting purpose. I went to the urology people to collect different instruments they use for the stone removal. And we tried all means of taking out this foreign body. It was a very difficult foreign body. So we tried to pass the Dormia basket into the lumen, outside the lumen, and then we tried to pass in a proline thread to thread this. You would see that it is such a slippery nature. You can imagine how it is difficult to catch hold a pearl. So we were trying to thread with the proline thread inside the lumen, and then you can pull out the thread from the side. It's a difficult, but then you have to practice this. So ultimately we succeeded removing this foreign body. A wheat barley in the lungs in pediatric age group, particularly in farmers' family. A gold socket. Now, can you imagine a 6 months baby with having such a big foreign body of hair clip? Now, you would imagine the child has not started even weaning. And how come the foreign body went into the lungs? So, I elicited the history the way I asked parents, is there any sibling in the family? So, asking family history that is there any sibling? It's a very common thing that sibling, when he is eating a peanut, he'll push the same thing into the child, the smaller child. So that is what happened, that this elder sibling pushed this foreign body into the lumen. And see the openings are facing the surgeon. So while I was taking out the this foreign body, this open end stuck up into the base of the tongue. And since airway was not secured because it was a rigid bronchoscope there, so child started having bleeding inside. So I had to immediately do a tracheostomy, push it back, and then again take it out. So just age is not the criteria that too small a child cannot have a foreign body. Sibling can always push the foreign bodies which are unusual. This was a video of a pan cap, again not an uncommon foreign body. I have removed several of these. So you have to suck out the secretions without touching the foreign body, because it's very easy to push it distally. Visualize it with the optical forceps. If the open end of the pen cap is facing the surgeon, it is easy to grip. But if the closed end is facing the surgeon, then it is difficult to grip. It has to be a very gentle touch, otherwise it's very easy to slip this distally and then it becomes difficult. So the principle is that once the foreign body is out, you have to go in again to see the patency of the distal lumen, and there are chances that there could be a second foreign body distally. So always do a check bronchoscopy after the foreign body removal. Now you see this is long-standing vegetable foreign body with empyema chest. I was assistant professor at that time. They were doing a pneumonectomy in this case because empyema thoracis was there, chest tube is there. So I suggested to go for bronchoscopy before doing that, and this was the foreign body which was lying there for a couple of months. That is how the child developed the empyema thoracis. A piece of chalk in the left bronchus. Now the spontaneous hydropneumothorax is not uncommon because of the sharp edges of the betel nut or something. If the child is coughing vigorously, patient can present with a spontaneous hydropneumothorax. Now the catch is when you are doing a bronchoscopy in a hydropneumothorax situation, you cannot use jet ventilation because of the further damage. So use the Bain circuit normal ventilation in this group of patients. This was an iatrogenic foreign body. We used to use this spinal needle for jet ventilation for stopgap arrangement, and this piece got broken down and went into the airways. A toy wheel at the oropharynx. Now, long-standing foreign glottal vessel with stenosis. This is a virtual bronchoscopy picture where you can see the stenosis, and the lung condition is very much compromised because of the long-standing nature of the foreign body. A piece of mirror, you can see a radiopaque shadow in the trachea. Now coming to this was about the pediatric population. Now coming to the adult population, we think that adults cannot aspirate. We have seen so many adult population, elderly, which have come up with the foreign body inhalation. Now this was whistle in the bronchus for 5 years duration, showing a stenosis on the flexible bronchoscopy. Here you can see the whistle. Now this is a case of 5-year-long forgotten betel nut present in this child of 15 years girl. You can see the lung condition, and even after removal of the foreign body, sometimes the alveoli do not function because of the lot of fibrosis has taken place. But still, patient is out of the infection and avoid pneumonectomy in these cases. This was a case referred to us from a medical college tertiary care hospital where this patient had a history of betel nut inhalation. They could not remove it, and in the post-operative period, patient developed some cardiac event, and she was intubated and shifted to cardiac ICU. And after 1 month of that event, she came to us and we did a bronchoscopy, and this was the foreign body for 3 months in adult population, where the patient is knowing that she is carrying a foreign body. But still she was not coming to the secondary center because of the first bad experience. A torch LED bulb we recently removed in a 15-year-old child. He was not giving any history. Can you imagine a 15-year boy is not giving any history of inhalation? And when I removed this foreign body, then he could recollect that I was playing with this, doing some repair work of the torch, and he inhaled this foreign body. Now, this was a very interesting case of endotracheal tube. The patient was a destitute patient. He met with some accident, and the neurosurgery people did a craniotomy into this case. And you can see that cranial bone lying in here. So the patient was admitted into medical ward with intubation and ventilation. So after the residents and the faculty completed the round, and suddenly the resident showed that there was no tube. So tube was missing. Probably the patient was irritable. Probably he got pulled out something, and then somebody probably pushed it into the wrong passage. And you can see the endotracheal tube going into the stomach. Though he was being ventilated initially, but some accident happened. Nobody observed that what happened, and somebody pushed the endotracheal tube. And this is the endotracheal tube which is coming out. We have removed the broken endotracheal tube from the airways also. This was from the food passage. A 77-year-old man with betel nut. We have done more than around 50 cases of such age group, because they have a tendency of keeping betel nut and reading the newspaper in the night, and they suddenly forget that what is inside, and they accidentally inhale. It's very common in the western part of the Rajasthan to eat this betel nut. So never ignore these cases. A root canal treatment was going on, and the patient inhaled this particular thing into the lung. So we published this also. So these are various foreign bodies we have come across during our 3-decade experience. Now, team approach to foreign body removal by rigid bronchoscopies cannot be overemphasized. It includes endoscopist, anesthesiologist, trained technician, and a trained nurse. Endoscopic planning is of utmost importance for the successful, uncomplicated outcome. You require a parental consultation, explain the risk, ask for replica of the foreign body if possible. First attempt gives the best opportunity to remove the foreign body. The prompt endoscopic removal under condition of maximum safety and minimum trauma is the treatment of choice. Now, coming to the first aid, it is only indicated in a child with complete obstruction. The first aid delivered to a partially obstructed child is unnecessary and potentially dangerous. Coughing, gagging, throat clearing are the features of partial obstruction, and they do not require any first aid. The complete obstruction is recognized in a conscious child by sudden respiratory distress followed by inability to speak or cough. Only this group of patient requires first aid. So in an infant, you do a maneuver like this, and in a child, you do a Heimlich's maneuver like this. The coordination between anesthetist and surgeon is extremely important. You have to have a good conversation that what is your plan of action. Any misunderstanding between the two can lead to disaster. Now, some general rules and pearls of wisdom. It's a high-risk procedure. A small compromised airway is shared by surgeon and the anesthesiologist. The complications occur when performed for unclear or the wrong regions. The preparation ensures 50% success. I stress this too much to my residents, that preparation is extremely important before doing this procedure. Don't rush for these procedures. Bronchoscopy is called as three-handed procedure. What is the third hand? Third hand is of the experienced assistant who is assisting you. He should himself be doing a bronchoscopy at some point of time. He would understand the sequence of events or the instruments required next. So he has to have the concept of what sequence of event is going on and what next instrument is required, because time is money. A good bronchoscopist has excellent skills, but an excellent bronchoscopist is surrounded by excellent support and backup. All possible instruments should be present on the trolley itself. then you should know your limitation and teach. The complications: immediate hypoxemia, tracheoesophageal perforation, laryngeal edema, vocal cord injury, laryngo or bronchospasm. But I can assure you, if you do regularly, hardly you see any of these complications. Then delayed complications, we have seen all sorts of possible complications: recurrent pneumonia, bronchiectasis, empyema, pleural effusion, pneumothorax, fistulae, stenosis, and irreversible damage. All of them we have seen. Now, to summarize, despite significant advances in endoscopic and anesthesia technologies, pediatric foreign body removal remains a diagnostic and therapeutic challenge. Rigid bronchoscopy with the advantage of side-arm controlled ventilation continues to be a useful technique for foreign body removal in children more than 100 years after inception by Killian. Flexible bronchoscopy is the initial choice in adult, but not in pediatric age group. And that is true for the diagnosis purposes. For removal, again, a rigid bronchoscopy scores much more over the flexible one. Foreign body in most common cause of death in children below 6 years of age at home in US. Continued training and mastery of these skills are needed for interventional bronchoscopists to carry on the therapeutic tradition into this new millennium. High index of suspicion of foreign body in children coming with history of choking, coughing and wheezing with no past history of asthma. History and physical examination and not the radiography should determine the indication of bronchoscopy. Prevention is better than cure. Avoidance of the objects that are easily aspirated in pediatric airway is the ultimate prevention. Continued education through child advocates is required to reduce such accidents. There should be some consumer product safety guidelines regarding the size of the parts of the toys as used in the children, as in the US. Now, public awareness should be there about these possibilities, so we get a good coverage from the press as and when we require their help. Thank you very much for the patient listening. Now, I'll demonstrate the live instruments onto this. My whole purpose of this instructional course is that ENT people should understand that it is our domain to do it. Otherwise, there are people to hijack this, especially like pulmonologists, thoracic surgeons, and the pediatric surgeon. When I joined SMS institution, say 27 years ago, the whole spectrum was going to pediatric surgeon. And now, no one case is going there. We are going and doing in their hospital, if the child is on a ventilator or something like that. But exclusively, the ENT people in the city of Jaipur are doing the rigid bronchoscopies. And the failed bronchoscopy attempt by the pulmonologist, and they all come to us ultimately. So I stress upon, let us take a message from this that ENT people are the most suitable guys to do this because of the extra ability to do tracheostomy as and when required in seconds. So, yeah, any questions, please?
Patient positioning?
Like we do in the direct laryngoscopy, there is nothing special about it. Slight extension of the neck, and then the larynx should be in the line, which is very easy in pediatric age group. You would see the laryngeal inlet immediately. You don't require anything else. But sometimes, if you are not able to see, then you can put a small shoulder bag underneath. Any other questions, please? I told in my lecture, the common sizes which we use is 3, 3.5, 3.7, and 4. If given a choice to purchase one, I would say 3.7 would cover most of the children. But it is always advisable to have one size up and down on your trolley. So because tightly fitting bronchoscope is a disaster, because even after removal of the foreign body, the child is going to develop respiratory distress and you have to do a tracheostomy. The procedure should not last more than 20 to 30 minutes. And the size of the bronchoscope, it should be easily going into the subglottis without any pressure. So just pen holding method of pushing the bronchoscope, not like this. Sure, please.
This is some diagnostic dilemma that patients, when you for the flexible scoping diagnosis.
As I said, the modality HRCT with virtual is one option in pediatric age group to diagnose difficult cases or attempted cases. Flexible could be a choice for diagnostic purpose, but people tend to remove and try to remove the foreign body, and that gives rise to disaster. because invariably the large foreign bodies get lost into subglottis and patient is not able to be ventilated. So flexible is not a good choice for pediatric age group for the extraction purpose. For diagnosis, it is all right.
How you select when you go for the optical forceps, when you go for the simple forceps?
So most of the time I do not use optical forceps, but now teaching and training purposes we use the optical forceps because the size of the forceps is slightly bigger than your comfort level. Because if you are using a smaller size bronchoscope, it would not go in. Say 3.5 and 3.7 hours, you can use the optical forceps. So for beginner, I would say one should be comfortable, should be having all these instruments on the table itself. It's not a difficult. You have to watch couple of procedures being done in your city, and then you can start and ask somebody to come and help you in initial cases. It's it's a safe procedure. After doing couple of cases, you would realize that it is not that difficult. At the most, what is going to happen? You are not able to remove the foreign body. So push it in the right or left main bronchus and send it to the higher center. As simple as that. But the tracheal foreign bodies are difficult. So we have a series of tracheal foreign bodies also. In those situations, I would not suggest the tracheal foreign body requires. In tracheal foreign body situation, I would suggest that you expose the trachea, do not cut the trachea, and start doing the bronchoscopy. As and when required, in a second you can enter into the trachea. So exposure of trachea in difficult situation without tracheotomy. And as and when required, you can immediately do it. Because in a couple of seconds, the child deteriorates to zero saturation in bradycardian arrest. So you don't have to struggle if the trachea is already exposed. So it's a good technique to be on safer side in difficult situations. But 99% we do not require tracheostomy. Yeah, please. So it is always a good. Yeah, that's right. So first thing is you ask the patient to get a replica of the foreign body if possible. The peanut, groundnut are easily available. You can really see outside how much pressure is required to catch hold and make a practice before doing that. So once you have broken the pieces and venturi ventilation is going on, and if you disperse, you put in a saline and suck out. Most of the small pieces would come out with this, or in the post-operative period, child is going to cough and that would come out. Bigger pieces cannot come out, but smaller pieces cannot come out. No, we did not require any time. Though it's a modality described, but pulmonologists try to do it. It's a cumbersome procedure. We don't require mostly. Nothing. Keep a patient into your post-operative recovery in the OT setup for half an hour or 1 hour, and nothing is special. Because once you are sure that you have taken out the foreign body, where is the risk? But you have to be watchful for a couple of minutes, because what happens in the OT, once the foreign body is out, everybody, right from technician to anesthetist to residents, everybody gets relaxed. And sometimes patient goes into spasm. So you have to be careful for 5-10 minutes even after removal of the foreign body. And a check bronchoscopy to see for another foreign body on patency of the lumen. Yeah, sure, please. So I told you, we used Dormia masks from the urology people, we used cardiac catheters, then ultimately we passed in a proline thread into the lumen, and we can catch hold the thread from the other side. It's a difficult foreign body. So that is what I am telling you. With a small forceps, we could see the end of the that pearl and we could take it out. It was a very difficult foreign body.
What are the anesthetic challenges that one faces?
Only ventilation. I described the video that you have 2 ports of ventilation. One is directly vein circuit is getting attached to the scope. I will show you just now. And the other is jet ventilation in case the airway is compromised. But it is not essential to have a jet ventilation. You can manage with the vein circuit, because most of the time the foreign bodies are unilateral. So the other lung is being ventilated by the distal ports on the bronchoscope. So it's not a big challenge. Only thing is, when patient is getting desaturated while the surgeon is doing it, there should be a complete understanding and your eye should be onto the monitor that when to ask anesthetic to give ventilation. So sometimes when the saturation is say 85 or so, you switched things to the anesthetist to give a ventilation by either mask ventilation or if the scope is inside, the jet ventilation, the apnea technique. So couple of puffs of jet ventilation would immediately saturate the patient. But in bilateral foreign bodies, the desaturation is very fast. Those are real challenges because within seconds, you get a fast desaturation. So surgeon has to be very efficient to take out at least one foreign body in bilateral cases, which is fortunately not common. So if there are no questions, we can see directly the scopes. Please.
लैपटॉप लगा रहे थे ना सर आप अपने या वहाँ पे?
हाँ वहाँ पे दे दिया, थोड़ा टाइम लग रहा था ओपन होने के लिए।
To take it out.
You couldn't see anything while removing the foreign body once
No,
you...
once you are in, you are able to see the foreign body. Then you catch hold the foreign body.
removing it, while removing it.
I'll show you. So too big a foreign body. So thoda sa.
But when you put the forceps in this, because I'm doing bronchoscopy
Yes,
in
yes.
Amritsar,
Okay.
you can't see the foreign body
Yeah.
because the
But-
lumen is so small.
Yeah.
You
So-
have to think about it,
Blindly.
feel, and then pick it.
It's not bodies. Then you plan how it is to be taken out. So once you go there, you just first feel the foreign body. Do not pluck the foreign body, so that your unilateral vision compensates for the depth perception, that you are at the correct level. So once you diagnose that you are at the correct level, then gradually open and catch hold this. So here comes the tactile feedback that your hold is good. If peanut comes into that, आप eyes close कीजिए और peanut को पकड़ के देखिए बाहर रखिए आप replica before doing one of the patient, and you will feel that some field difference has come here. So that ensures that your grip is vertical. Then you can take it out. So that is about. If you are not able to be confident about this thing, then you can use the optical forceps in the same one. इसमें इसका बड़ा size का नहीं है, stores people.
सर
Camera, and this is a telescope. And how it is to be removed? This comes in different parts like this. So this is the forceps. Here you pass, you can see a marking. Show me the light, please. You can see the marking here and marking onto the telescope. Okay? ये दोनों मार्किंग आ गया पैरेलल आपका यहाँ पे इसमें आएगा उसके बाद इसको हुआ ना Why it is not camera. So there are two ways of doing it. One is that you directly see through the telescope, and if you want, because this is slightly weight, so sometimes holding this assembly becomes a little cumbersome. So it's quite heavy now. So you go in again, go with the closed forceps, feel the foreign body, and then catch hold the foreign body. Now there are two ways of removing it. One is, as I told you, if the bronchoscopes इससे बड़ा रहा नहीं है
Those people must be knowing what is the smallest bronchoscope size which can accommodate this.
this is
optical
3.5
forceps.
onwards.
So 3.5. 3 will not.
3 will not allow.
3.5.
So you catch all the foreign body, and if it is a small one, you can pull it into the lumen and take it out and keep the bronchoscope there in situ for ventilation and check bronchoscopy. But many times the foreign body is quite large. So what you do is just and come out at this level. Don't keep it at this level. If you keep it this level, then feedback is not adequate. So come out at this level and then take out the whole assembly together. Now when you are coming just below the subglottic region, there is a very bright possibility in initial time that you will lose this foreign body here. And once you lose this foreign body here, the saturation gets very fastly desaturated, and the anesthetic is in panic mode. Give patient to us, give patient to us. That is the mistake which surgeons, inexperienced surgeons make to give them, because they are not going to be ventilating that subglottic foreign body. So what you have to do is, once foreign body is there in the subglottis, you always have a rigid scope with you. You just enter in and push it blindly. 90% time it will go into the right side or left side. And then you can ventilate and buy time. Do not allow anesthetic. This is a common mistake in inexperienced surgeon, the anesthetists, that they struggle to ventilate the child and you lose the child. So never allow anesthetists to take over in those situations. Subclotic, lost foreign body, push it, ventilate, then buy time, saturate the child, and then do procedure again.
Excuse me, sir.
Yes.
Sir, we are running a
Just 5 minutes.
So can we just start the introduction of the next?
Sure, go ahead. So this is about the use of the optical forceps. Now coming to the ventilation issue. So as I told you in the video, this is a I think right part is over. So there are two ways by which you can ventilate. One is this Venturi needle. You can put in a needle into this and jet ventilation, which gets attached to the Boyle's machine. Anesthetists generally have it. You can buy otherwise 2,000 or 3,000 rupees, that Venturi thing. The other way, which is available all over, pediatric brain circuits can directly be connected onto this port. If you are using this port, then it has to be closed with a occluder. There is a occluder which has a complete closure like this, so that air is not leaking. If you are using Venturi, if you are not Venturi, then you can brain circuit can be no air is going to come out. This is a one-way valve.
Which is better?
For initial, I think one should go with the Bain circuit because anesthetist is comfortable in their routine job, and too much of jet ventilation can give rise to a rupture of somewhere. So the frequency should be with some pause. You should allow few seconds to air to come out also. Sometimes when desaturation takes place, they push like this, tuck, 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 and that gives rise to complications.
So is there any preference for you when you use an optical forceps? Which one you would prefer? The initial preference
Bain circuit.
with the
Bain circuit.
optical forceps.
You should have an optical forceps to begin with, but if you are using a 3-size bronchoscope, this delicate forceps of this nature, like there are two forceps which are commonly used, are the peanut and the cereal.
Meenakshi NT Specialty Hospital, Bangalore. So, unlike the routine, we've always been having this idea that esophagoscopy is the domain of a gastroenterologist, and generally we don't venture into doing flexible esophagoscopy. But this is a relatively new scope which has been introduced, and now ENT surgeons can also enter into the esophagus and do our routine examination of the esophagus. We are already acquainted with doing esophagoscopy, removing foreign bodies from the esophagus, but when it comes to doing a flexible scope, we always send it to the gastroenterologist, and we are the ones who probably see more number of cases of GERD these days. GERD is a very common problem. And considering that, we are probably eligible to do a transnasal esophagoscopy better than, or at least in par with the gastroenterologist. Of course, I'm not trying to say that we should venture into others' territory, but this is a common territory, I would put it as. So, transnasal esophagoscope is a flexible scope. It is passed through the nose. It is a chip-on-tip scope, so it gives a very brilliant illumination, magnification. It has facility for recording of the video and also has a good inbuilt light source. So, just like a bronchoscope, it has a single wheel, and this wheel will help maneuver the instrument. There is only an up and down movement of this particular scope. So it is very easy to maneuver and pass the instrument till the esophagus. The difference between the bronchoscope and this is only the channel for air insufflation. So this is coming to the specifications, this is a 60 centimeter long scope having a diameter of 5.4 mm, so it can easily pass through the nasal cavity. It has only one working channel, so the same working channel acts as a common channel for biopsy, for doing your suction, for insufflation of the air, and also channel for irrigation. So as we all know, esophagus is a collapsed structure. So as we enter the esophagus, unlike a bronchoscope, we need an air insufflator. So this is provided with the same, and yeah, it helps us in the esophagoscopy. there are other features just like narrowband imaging, which uses a special band of light to enhance certain lesions. So eye scan is another feature which has been introduced by Pentax system, and it is a patented technology where there are 3 algorithms, which is surface enhancement, tone enhancement, and contrast enhancement, which allows us to see certain lesions with better clarity. So the main advantage is that the nasal intubation of the scope is possible, so the mouth is left free. The patient's tolerance is much better. The patient is able to phonate, he's able to speak, he's able to even sing with the scope in situ. It is done as an outpatient procedure under topical anesthesia, and no sedation is required. People generally go back after the procedure immediately. Unlike in esophagoscopy, sometimes there's a need for admission or keeping the patient for maybe a couple of hours following the procedure. Coming to the indications, there is a varied set of indications. The most commonest, I would say, is GERD in our practice, because almost all ENT surgeons either patients come with a heartburn, sometimes patients come with irritation, chronic cough. So dysphagia is another indication. So diagnosis of dysphagia by performing a FEES, function endoscopic evaluation of swallowing, for locating radiolucent foreign bodies and confirming our diagnosis many a times for diagnostics of chronic cough. It can be also used for diagnosis of vocal cord lesions and paralysis. It helps us in evaluation of snoring with a Muller's maneuver. I'll be showing some of these things. I have short videos of this. So we can also diagnose velopharyngeal insufficiency. It can be nowadays used for a triple endoscopy. Of course, now it is a concept of the past, but still, if required, it can be done, because it's the same scope entering the nose, doing a hypopharyngoscopy and a laryngoscopy. It can also be used for secondary TEP puncture and prosthesis placement. Coming to the therapeutic uses of it, since it has a biopsy channel, we are able to take a biopsy for the rapid urease test, and we can also take small biopsies from the larynx or the esophagus. We can remove foreign body if we have the appropriate forceps. It can be used for the larynx, it can be used for foreign body bronchus or foreign bodies in the esophagus. So we can couple it with lasers and use it to perform certain procedures on the larynx and the esophagus. I have certain videos of this. I'll be showing you. Unfortunately, for the paucity of time, I'm unable to explain. And functional endoscopic evaluation of swallowing is another procedure which can be performed with this. Feeding tube placement can be done, swallowing maneuvers can be evaluated, and awake intubations can be performed with the same scope. The patient preparation is very simple. If you are performing an esophagoscopy, we tend to keep the patient nil per oral for approximately about 6 hours. Patient is put in a comfortable sitting position. We normally spray a topical solution in the oropharynx. A 4% lignocaine with adrenaline pack is generally placed 5 minutes before the procedure in both nasal cavities to decongest the nose for easy permeability of the scope. And nebulization with 4% lignocaine is done maybe 2 minutes before the procedure in cases of bronchoscopy only. Coming to the procedure, so the patient is actually put in a sitting position. The patient is sitting on the left side and the monitor is placed to the patient's right side. We are passing the scope through the nasal cavity. It is a handheld scope, so we're using the wheel to maneuver the scope up and down. It's very simple, just like the use of a bronchoscope. The only extra feature in this is the addition of an air insufflator. So at this step, we can perform a Muller's maneuver, so to assess the level of the snoring and the level of obstruction in patients with obstructive sleep apnea. After the assessment of the larynx, we pass the scope through the vallecula on either side, and we ask the patient to swallow at this point of time, so the cricopharynx opens and permits the scope inside. So from this point on, intermittent air insufflation will keep the esophagus patent. There are two ways of doing this. We can either once for all go up till the stomach and look at the structures on the way out, or we can actually anterograde, proceed and keep looking at the structures as we go. The scope is long enough to take a look or at least a peek into the stomach. We may not be able to enter the pylorus from this area, but the pylorus will be visible. We were able to see some bile juice in the stomach. We perform a J maneuver routinely just to see the tightness of the lower esophageal sphincter. This is a J maneuver where the scope is turned in a J-shaped fashion, and this is the more proximal end of the scope being visible, and that's the lower esophageal sphincter. So we're able to change the settings, put it into eye scan modes like I described. So if there are certain lesions, like we see an area of aberration in the stomach, mucosal aberrations can be located much better with the eye scan. On the way back, we take a look at the lower esophageal sphincter. At this point, we can also take a biopsy for the test of the Helicobacter pylori. It's a simple rapid urease test. We have to take a small piece, representative tissue from the gastric mucosa, and place it on the rapid urease test slips which are available. So there's a demonstration of the biopsy being taken. We normally never take it over the ulcer, but around the ulcer. So two assistants are normally necessary. One assistant helping the patient, the other assistant helping the surgeon maneuver the instrument. So that's the lower esophageal sphincter. We can very nicely appreciate the gastroesophageal junction. So we take a look at if there are any varices in the esophagus, any dilated veins, Schatzki's rings. Yeah. So this is a Muller's maneuver being performed. We actually ask the patient to, by keeping the scope in the nasopharynx, we ask the patient to simulate a snore. After this, we actually pinch the nose of the patient and ask the patient to inhale. When the patient does that, if there is a collapse of the either the oropharynx, we actually do this by keeping the scope in two different positions. One is in the nasopharynx, one is keeping the scope a little lower down at the oropharynx level. At the nasopharynx, we are assessing the lateral collapse, anterocollapse, or a concentric collapse at the level of the soft palate. And when we do it at the level of the oropharynx, we are assessing a tongue-based collapse. So this is the transesophageoscopy used for assessment of dysphagia. So we had a patient who came with head injury, and following a head injury, he had right vocal cord palsy. Post a neurosurgical procedure basically. So we were doing a dysphagia assessment for him, looking at any aspiration, if any. So the advantage of this scope is that since we have passed it through the nasal cavity, we are able to assess and do the fees with the same scope. So we can see that the right vocal cord is not functioning, it's only the left vocal cord functioning on phonation. Patient is slowly swallowing the bolus. We see that there was no penetration in this particular case. So we can also couple the transnasal esophagoscope with a laser and perform certain procedures, but of course selection of a particular case is very important in transnasal in a patient where we're doing a laser procedure. Not everybody may be a good candidate. Somebody who is very scared of needles, somebody who's very scared of something being done, apprehensive patients may not be good candidates. And also the kind of lesion we are choosing is very important. Not to choose large bulky lesions, not to choose any lesions which can bleed and cause a risk to the airway. So we had a case of contact granuloma in the posterior part of the cords. I'm unable to fast forward the video.
2 minutes, yes.
So here we have used a diode laser, so which we have passed through the working channel of the transnasal esophagoscope, and keeping the setting in maybe 3 or 4 units, so we can ablate small lesions. So I'll fast forward my. We can also perform a bronchoscopy with the same instrument. So since we've anesthetized the larynx well, after this procedure we also did a bronchoscopy in this particular patient. We specially included this video just to show that these are the available options, the available procedures which can be performed with a single scope. So that's the trachea. The rings can be very well appreciated. The carina is becoming visible. The right and left main bronchus can be seen from there. So the benefits of transnasal esophagoscope over a transoral scope is that there is no sedation required. There is a diminished gag reflex, very minimal discomfort for the patient. It's a simple and a quick office-based procedure. Additional anatomy can be viewed and examined. There is less clinical personnel required. Patient generally can go back to the work on the same day, and there is no reported perforations or any complications which have been caused reported in literature so far. And repeat D&E, if asked a patient if you want to go for a repeat upper GI endoscopy, and if we ask a patient if they want to go for a repeat transnasal esophagoscope, patients always want to say that they don't mind doing a transnasal esophagoscopy again. And 98% of our patients have actually completed the examination. We have had one or two patients who have feared and who have not been able to get their procedure done fully. So the future in this particular this thing is that with more number of instruments being added in the armamentarium, we may be able to do banding of esophageal varices and ligation, dilatations, balloon dilatations, injection of sclerosing agents. We've also injected Botox to the cricopharyngeal area using this particular scope. Thank you. T&E is a magic wand in ENT surgeon's hand. Thank you.
Thank you, Dr. Shreyas Pradeep. We next have Dr. Y.N. Mehra Neuro-Otology session, and the chairpersons for our session are Dr. Sundaraj sir and Dr. Senthil Vadivu sir. Do we have Dr. Sundar sir here with us? Yes. Our first.
I just want to thank Dr. Sunil Samdani for being very considerate. He did cut short his instructional session to accommodate us. I appreciate that. And Shreyas Pradeep. Shreyas, dear friends, is the second generation ENT surgeon from Bangalore. His father is a very renowned ENT surgeon in that part of the world, Dr. Pradeep Kumar, married to an anesthetist. Shreyas is again married to an anesthetist, and you can see why innovations like these are possible in a family like that. And they also have an audiologist. He has an audiologist sister. Absolutely fabulous team, all well within the family. Well done, Shreyas. Very well done. Sorry, I digress.
Our first talk is by Dr. Mohan Kameshwaram sir on understanding the auditory brain stem implants. Do we have Dr. Mohan sir with us?
Good morning, Ananda. Good morning, Ananda. I feel very much honored to chair this session, and I thank AOI for this opportunity. Professor Mohan Kameshwaran doesn't need any introduction at all. The whole crowd knows about him. He was the pioneer in auditory implant surgeries. He has one of the largest series of pediatric ABA in Asia and second largest in the world. He has done a lot of research work in auditory brainstem implants. We welcome you, sir.
Good morning all, and most respected Madam Chairman, Chairperson, and both Chairpersons. It's really a pleasure and privilege to be here with all of you today. And at the very outset, let me tell you that the topic that I'm going to talk is actually a very freakish topic. I do apologize. Understanding the brain, the most complex of organs, which sets it apart from the rest of the animal kingdom, and how we have come to understand the brain thanks to the implants. So understanding the auditory brain, or in fact understanding the brain through implants, is what I'm going to talk about. Of course, we all know about the silent malady, the hearing impairment. Deafness is definitely the most poignant of all handicaps. It's silent, literally silent. And as we all know, it elicits no sympathy. It's the only handicap which does not elicit sympathy. But at extremes of age, it has profound implications. In the elderly, it leads to cognitive decline. In the very young, it leads to deprivation of communication, of speech and language. And in children particularly, it has profound effects. It's, as we know, it's the most profound of, most terrible handicap, I would say, because it's a double handicap. It's not only hearing, but also speech. But fortunately, the silver lining in the cloud is that it's the most correctable handicap today. And we all know that, it has, the burden is tremendous worldwide. We estimate about 630 million people are living with disabling hearing loss, and about 10% of them, 63 million, live in India alone. And 7% of our school children have a significant hearing loss. So it's a huge, huge burden. I'm coming to implants. It was Bernard Stiegler, who was a French philosopher. Some of you may have heard of him. He suggested that human beings are essentially prosthetic creatures. And it's due to our propensity to create tools. And, because of these tools, we are eager to restore lost physiological functions of the body using prosthetic devices. And auditory neural prosthesis can help deafened individuals living in a world of silence once again get back to the normal world of sound. Not that it's a great thing, but it's possible. I think one of the biggest revolutions in this 21st century has been the successful integration of auditory neural prosthesis. If you think about it, it has profound implications. It's a first human attempt to integrate an external electronic circuit to the complex neuronal circuits of the brain. And this is not a mean task. It's a first step in the robotic or the prosthetic and the bionic human being. Now, the brain as a whole, if you look at how it functions, the best way to describe it is that it's an organized chaos. It's an oxymoron. So, on one side it's organized, the other side is chaotic. So, what do I mean? If you go into the neuronal level, it's chaotic. There's no sense to it. But if you go on to the areas of the brain, if you are looking at the lobes, then it becomes more organized. So at a cellular level, it is chaotic, but at a macro level, it is organized. So it is an organized chaos. The one exception to this rule is the auditory brain, which is beautifully and impeccably organized throughout, right from the peripheral organ all the way to the auditory cortex. It is beautifully streamlined and organized. And this is a gift, I would say, of nature and God to the ENT surgeon, which is why we have been able to be so successful in integrating the auditory processes. So if you look at I like to look at the auditory system as a cascade with several levels. Each level is an opportunity for us. So at every level, if there is an interruption, it is possible for us to go to a level higher. Because it's a sensory system, we can go a level higher. And once again, if you're able to stimulate there, we can establish the circuit is complete and re-establish hearing. So it is an opportunity for us. There are several levels, and this is like a cascade. Now, if you look at the whole advent of neural prosthesis, and now there are many. We although the most successful was the cochlear implant, but it spawned off a whole genre of prosthesis now. We have, for example, deep brain stimulation, DBS, which is very, very successful for Parkinsonism. We have implants in the offing for dementia, and a whole lot of things. But the neural processes as a whole are devices which help restore a lost or a deficient neural function. And it does so by integrating an electronic circuit externally with a complex neuronal circuits. It's a fundamental change in philosophy. As surgeons, we are used to tinkering and repairing damaged organs. But now we are looking at bypassing these organs altogether, or even replacing them. So it's a fundamental shift in philosophy as far as we surgeons are concerned. Now, this neural processes, and particularly the auditory neural processes, has also, incidentally, apart from restoring hearing, helped us also to understand how the brain functions, a much better understanding of the complex way the brain functions. So that's what I'm going to be emphasizing on today. Let me start with two fundamental concepts. One is the concept of neural plasticity, and the other is the concept of neural scavenging. What is neural plasticity? It's very simple. If you really want to teach someone, teach them young. In this auditorium, you see a lot of young faces. You see a lot of old people like me too. It's very difficult to teach us things. It's very difficult. We live in past glory, but people who are very young and looking and smiling at me now are the ones who are going to be learning, taking home messages, and that's because the brain is still plastic. It is still able to learn. It is able to understand new concepts and new functions. And as far as the different parts of the brain, the plasticity varies from the parts of the brain, from one area to the other. For example, the vestibular system has a tremendous amount of plasticity even into the old age. Even at the age of 60 or 70, you could still compensate. So you have plasticity. But that's not so in the case of the auditory brain. The auditory brain plasticity stops by the age of about 5 or 6. It's very good at the age of below 1, but gradually tapers down. And after the age of 5 or 6, the brain is no longer able to learn new concepts. So what does it mean? Now, if you're born deaf and you're going to restore the function, then the ability of the auditory cortex to understand the signals and to make sense out of them goes away after the age of 6. So you may restore function after the age of 6. Let's say a congenitally, deafened or deaf child is implanted at the age of 14 or 15. Now, what happens is you can stimulate the cochlea, and the sound is implanted, and you can actually send the signals to the auditory brain, but the auditory brain won't be able to make any sense out of it. So that is the loss of plasticity. Even more interesting is the concept of neural scavenging. Now, if you have a part of the brain which is not used, some of us have large parts of the brain, but let's take a specific example. In somebody who's born profoundly deaf, the auditory brain is not being stimulated. So the entire auditory cortex is silent. Now, this is not acceptable to the brain. So what happens is the adjacent parts of the brain slowly starts creeping into that area and claiming the territory. So it's like, you have a property, you leave the house and you go away for years, your neighbor takes over. So that's what happens here. And here the neighbor who's very greedily taking over is the visual cortex. So you can see this happening in functional MRI or in O2 PET CT. So if you follow them up, you can see that the visual cortex is slowly expanding at the expense of the auditory cortex. And initially, if you restore the function, that is, you have once again stimulated the auditory cortex, there is a fight. You can see the fight happening, and slowly the lost territory is taken back. But if you do this after a long time, then what is lost, which is why this explains why you have limited neural plasticity in the auditory cortex. Now, interestingly, the neural plasticity, there are two aspects to it. One is the cross-modal plasticity, which is what I told you about. That is, the auditory brain is not functioning, so the visual brain takes over. It's another modality, the vision versus hearing, and the visual cortex takes over the auditory cortex. So this is the most common type of cross-modal plasticity which happens in the brain. And there is, of course, as I said, there's a critical period. So early implantation becomes very important, and the rule in the brain is use it or lose it. Use the brain or lose the brain. But there is also another very interesting aspect of modality, plasticity, and that is known as the intramodal plasticity. Now let's look at a good example. You have the auditory brain, and your cochlea is an exquisite organ which does beautiful analysis of the sound which comes. The processing of the speech which happens in the cochlea is known as fine structure processing. It can look at so many aspects of your sound that you make and give all this information to the auditory brain. Now you've lost the hearing and you put in an implant, or you're not born with hearing and you put in an implant. Now this implant also does processing, but let me tell you, I hope there are no cochlear implant company people here. It is pathetic. The signals that you get from the cochlea, and if you look at the signals you get from the implant, it is not just a poor cousin, it is a pathetic cousin. So your information that you're getting from the implants is very, very poor. The processing strategies we use today are primitive compared to the actual cochlea. But still, we are able to make sense out of it. You have all star candidates. I have a cochlear implantee child who is now studying in Harvard. He speaks 6 languages: Spanish, French, 6 languages, and Harvard Law School, the best school in the world. So we all have candidates like that, but still, for him, the signal that he's getting from the cochlear implant is primitive compared to what another child would get from a normal cochlea. But yet he is able to make sense out of it. Why is it? It's because the auditory brain has adjusted itself to the kind of signals that it is getting. In other words, there is an intramodal plasticity. The modality is the same. It's just signals from the audition. But even though the quality of signal is very poor, the brain is able to adapt and get information, maximum information out of it, and make sense out of it. So there's also an intramodal plasticity, which is why auditory implants have become so successful. So in looking at hearing loss, we're investigating, we all know about this list, I'm not going to go into it, but I want you to see the bottom, the 2 I have highlighted with yellow. One is P300 and the other is CAEP, or cortical auditory evoked potentials. I just talked briefly about them. P300 is an extremely fascinating response which you get from around 250 to 450 milliseconds. This is why it's called P300. It is an endogenous response. Endogenous response, is my time over? Okay. Thank you so much. An endogenous response is a response which is independent of the stimulus. Okay, so we're not worried about the stimulus. Whatever the stimulus, you still produce it, and it depends on the intention or the response of the individual to the signal. Okay, so how you intend to deal with it. And it depends on the attention of the individual and ability to discriminate. And it's actually produced from multiple subcortical levels, including the limbic system. And it is a correlate of the sequential processing of the information. P300 abnormalities have been linked to attention disorders, particularly it's of very great help in Down syndrome, psychiatric disorders, and it is very, very helpful in the ability to look into the mind of the person. So for the first time, we have a test which not just tests the hearing, but is able to look into the limbic system, the so-called emotion aspect of the brain, so the soul of the human being, the mind of the human being. Cortical potentials are again another fascinating potential. Now, this is a potential which is elicited in the cortex in response to sound. It is not present at birth, even if you're hearing perfectly well. But as your experience with sound progresses, then the potential starts developing. You have a positive, negative, and a positive. And this is forming, or the morphology is changing with auditory experience. In other words, it's a biomarker of auditory experience, not just hearing. So by looking at the wave, you can just not only say this person is hearing, you can say that he's actually heard for some time, and he's actually used auditory cortex for some time. So this is again fascinating because you are able to see the changes in the auditory cortex with auditory experience over a period of time. I'll go fast. Now, the auditory piano, is in other words, the cochlea is tonotopic. It has a place for a pitch, and with that you can actually, literally stimulate the cochlea in different areas to produce different pitches. And you can also, as I said, in the auditory cascade, you can have the placement of implants at different levels. We all know how cochlear implant works, and it works because of the tonotopic arrangement. And the brain function, as I said, is very important. It's not the implant which is important, it is the intramodal plasticity in the brain which is being responsible. And we can study this with various tests. The O2 PET is a very good way of studying the brain, and functional near-infrared spectroscopy, or what is known as FNIRS. With this, we can actually see the functioning of the brain in response to sound. Now, next question is, can the brain integrate the electronic signal with acoustic signal? So it is, when we started cochlear implants in '96, we used to tell patients, look, if you have a cochlear implant, you cannot use a hearing aid. There are two different signals, and they won't brain. But that's stupid. We now know that all that we said is wrong. And we can actually integrate anything with anything. You can give in one ear, you can give electronic signals, and in the other ear you can have normal hearing. In a single-sided deafness, you can restore hearing with a cochlear implant, and the brain will take the normal hearing from the normal side and from the deafened side, take cochlear implant and put them together and get binaural hearing. So it's possible. So we know that the brain is much cleverer than we thought it was. So a good example of this is electroacoustic stimulation, where you have some hearing in the low frequency, but mid and high frequencies are lost. You can have a short electrode to augment the mid and high frequencies and integrate it with the residual hearing in the low frequencies, provided you're able to preserve the structure, ultrastructure of the cochlea. Okay, so in case you have no, cochlea at all, let's have a Michel deformity or a cochlear nerve is absent, then of course we go for auditory brainstem implants. And this is one of the great triumphs, I think, because we know that we can actually give hearing to somebody who has no cochlea at all or no cochlear nerve. And auditory, as I said, not only the cochlea, but the entire auditory cortex is organized. So the brainstem cochlear nucleus is also tonotopically organized, although it's a much more difficult organization. And does it work? If you put an implant into the child, can I have sound for this, please? Can I have sound? Let's just give a little example of this. Some children with ABI. These are the link sounds. Different frequencies. Okay, so the other aspect is the cortical evoked potentials are also, like we said in cochlear implant, can also be picked up in the brainstem implant. So to conclude, we have today imaging techniques and audiological tools that has helped us to understand the auditory system much better, and a very important contribution has been from the implants. And as a fallout of research in cognitive neurosciences and auditory neural processes, we have developed interesting insights into the way the functioning of the brain happens, especially in the auditory system, and from that also the rest of the brain. Now, this has given us a new insight into the way the brain functions. And for implications for neuroscience, we have learned that with sensory systems, the powerful neural networks of the brain is trained over many, many years and millions of repetitions to recognize complex pattern of sound and speech. And it is by matching with these complex patterns that we are able to make sense out of sound And in deaf children, with congenitally deaf children, with cochlear implants and brainstem implants, even the distorted patterns produced by the prosthesis are highly intelligible and sufficient for a previously untrained brain to learn speech and language. And research in auditory processes has shown how the ear and brain work together for pattern recognition. And these insights help design better prostheses for the future. Thank you very much indeed. I'm sorry I exceeded my time. Thank you.
Thank you, sir, for the wonderful talk. One of the speciality of Mohan sir is he'll start from basics and will go far beyond. Thank you, sir.
Used is very difficult, and in life I have been trying to do that, and I don't know how far I've got. I think I'm there 60-70%. Thank you. I was his founder secretary, and without further ado, you can time me, guys. I think I've got 15 to 20 minutes. Is Dr. Anjana Vishwanathan here? If she's not here, we have another 5 minutes for Q&A. I've just titled this talk, New Frontiers in Implantation Otology. I'm just going to do a whirlwind tour or a roller coaster ride, so to speak, of what's there in implantation otology, some basics and some advanced perspectives. Paying respects to the teachers again. And that's roughly the plan, and I don't think I have time to dwell into each of these, but let's see how far we go. Implantation otology is that branch of otology where hearing implants are surgically implanted for hearing habilitation or rehabilitation. So we're not talking about hearing restoration surgeries that we do in terms of tympanoplasties, ossculoplasties, and stepidotomies. So that doesn't come into implantation otology. So we have a huge range of possibilities here: cochlear implants, bone conduction implants, middle-ear implantable hearing devices, auditory brainstem implants, and possibly midbrain implants, and today, what's in clinical trial, vestibular implants as well. Cochlear implantation has really come up in leaps and bounds across the globe because the impact of profound deafness is humongous, and I think a lot of R&D has gone into this area. And globally, about almost 1 million children have received cochlear implants, and in India, the guesstimate is we have about 40,000 children in the past 2.5 decades who received cochlear implants. And like Dr. Mohan said, this is the first man-made device that has completely replaced a special sense organ. I think we should take kudos and accolades for that possibility. With cochlear implants, again, this is a 3-day conference if we go into cochlear implants, and we just recently did one in Delhi, the CGCon. Just summarizing cochlear implants in just this slide. With electrode design, there's a lot that is happening. We're still not there, like Dr. Mohan said. Soft and atraumatic electrodes have been designed to make it as atraumatic and hence preserve residual hearing in these patients. As far as the package is concerned, it's getting thinner and thinner so it doesn't jut out and there is no trauma and damage. MRI compatibility is a big thing with all the companies, and I think they're all getting in line there. They're looking at self-aligning magnets. And with processors, they're getting smaller and smaller and less cumbersome. So there are no more cables, no more microphones behind the ear. So there's a what we call a off-the-ear processor that has come with a single unit microphone, battery pack, and the transmitter coil with its magnet. As far as coding is concerned, again, I don't think we have tapped even 20-30% of the God-given hearing. But then I think they're getting there with speech and noise, with music perception, and with multilingualism. We would all be very happy if our implantees go to Harvard and learn 6 languages. Totally implantable cochlear implants are happening. I just have a slide about it. And robotic CI surgery is also happening. That's a lot of information in one slide. This was a recent picture that I picked from the social media. The Envoy Acclaim implant that's undergoing clinical trials in the US at the moment. This was at the Mayo Clinic. This is a totally implantable cochlear implant. Dr. Mohan has some experience with the Envoy Esteem implant, which was a totally implantable middle ear hearing implant. It is a complex surgery, takes time. You've got to get every step in order. You use the eardrum itself as the natural microphone, and then make sure every energy is collected, electrically converted, and then transmit that to the cochlea. And that's the whole idea of this totally implantable cochlear implant. I think we'll get there eventually. I think that's enough about cochlear implants. My focus is more on partial deafness because that was what I was told to speak on. And what is the impact of partial deafness? I don't think it's not as much as profound deafness. We know that. It's a smaller handicap. And a lot of technology today, the costs, I think, outweigh the benefits, especially for a country like India. The incidence of the indications for these bone conduction devices, for example, is something none of us know. God only knows. So let's look at bone conduction devices very quickly. There are non-surgical BCDs and surgical BCDs. And surgical, you can have percutaneous or transcutaneous bone conduction devices. A lot of them have come in and gone out of the market because there were no takers, or their marketing strategies were good, or simply the science was pretty bad. So non-surgical BCDs, there are quite a few around now. The Baha soft band with the sound arc is definitely available. Medel's Adhere is getting very popular more recently. I think these are something we are definitely using. Now, with transcutaneous BCDs, we have both passive and active BCDs, the surgically implantable ones, and those are some examples of that. So we'll get into some of these. This is the Baha. The Baha today, you have fitting as early as 4 to 6 weeks. It used to be 3 months or even 6 months for osseointegration to occur. But they have changed all that now. They've gotten better and better with fixing the screw, so to speak, and integrating that with the thioblast interface, titanium oxide interface. And so the integration is much faster and the activation is much faster. That's the Baha 5 Connect system, the percutaneous system. There's a better processor available today called the Baha 6 Max. I think that's giving fantastic sound quality to the patients. The Baha Track system has these components, the implant, which is the screw, that titanium screw that integrates, and then there is an internal implant with a magnet. There's an external processor with a magnet, and this is exactly how it looks. And that again is the latest system is called the Baha 5 system. Aoicon Ponto is pretty similar to this. Somehow it didn't take off in India, but there are some centers in Europe working on it. Sofono Alpha didn't do well at all because it has, as you can see, 4 magnets, 2 inside and 2 outside. And so I think that added to the number of issues and complications that you can have. There's also an Aoicon Sensio system, pretty similar to the Ossia system that's available today from Cochlear. So that's how it looks. Cochlear's Ossia has definitely taken off with the US FDA clearance, which I think was a good move on their part. And with that, they've come into India also, and I think some of us have all performed this surgery. Again, very expensive. I think can I play this? Does that play? Yes. So this was the first Baha implantee in the country, in Murph. I had gone down to Dr. Mohan's center, who wanted to, after 14 years now? After 14 years, he's now employed in Amazon, and he wanted to shift to newer technology, and he said, I will shift to Ossia. So this is him asking for a change, and I don't think I have time to go through the various surgical steps, but essentially it is the same screw that goes with the same principle about 4 millimeters into the cortex, and that has a magnet over it, and a vibrating surface is inside now. So this is what it makes this system an active system. The vibrating surface is inside, and unlike the Baha tract, which is outside, and you fix that. There are specific techniques to do that, very strict adherence to the surgical principles, and then you have to torque adjust the screw. This is basically plumbing by the doctors, and you torque adjust the screw to 25 Newton centimeters. A competitor to that is the Medal bone bridge, which has had better R&D and penetration across the world. They started earlier, and bone bridge is done extremely well also. You can place it in the sinodural angle placement, the mastoid placement, the retrosigmoid or occipital placement, and the middle fossa temporal placement. Bone bridge is done really well. It's much simpler than when we started with the 402. Now it's the 602 BCI. I've performed a few of these also. The patients are doing extremely well. Again, some strict adherence to the surgical techniques and steps. I think we should all follow that. There's that cylindrical kettle pot that you have to drill for the whole BCFMT, the bone conduction floating mass transducer, to be introduced like that. I think I just have a 1 minute video on that. Pretty much similar to what you saw with the Ossia, but in this we have the vibrating surface, all of the vibrating surface introduced into the mastoid. So we need a little more bone than we would need just for a screw. So that's bone bridge surgery. Again, a lot of templates to go with it. It seems complex and complicated. It isn't. It's just that you need to stick to those steps very strictly, adhere to the steps. There's always surgical support from the companies, whichever company you're dealing with. Again, this is also fixed with screws on either side that you can see. These are self-tapping screws. Again, also integrating screws very quickly. All these patients can be activated as early as 2 weeks post-surgery. Again, this is an active bone conduction device, and the difference between an active and a passive is that in an active BC device, the vibrating surface is all inside. In a passive device such as the Baha tract, the vibrating surface is outside. So there are obvious audiological advantages of making it active over passive. Middle ear implantable devices, again, there's a classification system. The one that did work well in principle was the Envoy Esteem fully implantable device. But again, it was too complex, and I don't think they marketed well. I think that was the difficulty. Otherwise, it was, I think the 7 patients you had have all done well, right? Yeah. There's also the cochlear Tika, again, didn't take off. I've talked about Envoy Esteem. The electromagnetic devices, quite a few, but the one that has really stood the test of time is the Vibrant sound bridge system. That has done extremely well. Autotronics Maxim from Glasscock didn't take off. Again, a brilliant idea. Again, not carried properly to fruition is what I believe that was. Vibrant sound bridge. There are 4 types vibroplasties possible. 1, 2, 3, 4. Whether you put it on the long process of incus, the short process of incus, or on the stapes with the coupler, or on the round window with the coupler. Again, they do very well. and then the company gives you where you would choose a bone bridge as against the sound bridge. We can go through that. How are we doing with bone conduction implants in India? First of all, we don't even know what's the incidence for congenital oral deformities, for example. And what about single-sided deafness? We don't know. So there are lots of issues about finding candidates, and partial deafness is not as impactful as profound deafness. I think that summarizes the indications. We do use the Yardsdorfer staging system. I think that stood the test of time. 10 possible score. If the score is worse than 6, less than 6, you would consider a, yeah, I'll take a minute, please. If the score is worse than 6, you would not consider middle ear reconstruction. Indian Baha, I think we've had a pretty decent experience. Again, skin issues, scarring issues, tropical climate, some hygiene issues. We've had issues around the abutment. Indian sound bridge experience has been good. Indian bone bridge experience more recently has been very good. Auditory brainstem implants, Dr. Mohan's already alluded to. Midbrain implants are still in the research level. Vestibular implants, this video is not going to work. This is of a bilateral vestibulopathy patient. Basically, that video, if it worked, would show you how he's just going like that all his life. So bilateral Meniere's disease, bilateral ototoxicity cases, and I think there are quite a few across the globe who would benefit with such vestibular implants. Vestibular implant, there are 2-3 prototypes that are undergoing clinical trials both in Europe and in the US, and that's one of the MEDAL vestibular implants. Essentially, you want to put electrodes into the ampullae of all 3 semicircular canals, the superior and the lateral there, and then the posterior in that middle picture, and then there is a cochlear implant also, because these patients can be deafened following the vestibular implant procedure. Initial clinical trials have done extremely well, but let me say that the vestibular system is much more complex than the hearing system, as we know. 2 or 3 take-home messages. Hearing implants has to be team work, and this is the team concept that we keep talking about in CG. We say the leader of your hearing implant team should be your audiologist, and those are all smiling audiologists there. The second take-home message I would like to give is that awareness, especially for the partial deafness candidates, needs to improve. Patients, surgeons, and audiologists, the penetration is better, and the volumes are higher only then, and the cost will automatically go down. We are looking at indigenous cochlear implants and indigenous BCIs as well. And we would like the likes of Dr. Mohan to push for bone conduction implants also in the next level. Auditory brainstem implants have been approved by the Tamil Nadu government. I think the next step forward is to impress upon them the benefits of BCIs, and I think we will get there. And I talked about indigenous research. Thank you very much.
Thank you, sir, for explaining recent developments and new frontiers in implantation otology in a very understandable way.
I would like to call Dr. Sundaraj sir to please present a memento to Dr. Sunil Narayan Dutt sir.
Deepa, come forward. I leave that.
Good morning, ladies and gentlemen. Today I'm going to talk to you on the surgical management of dizziness. The surgical causes that are treatable can be classified into common, uncommon, and rare causes. Common would be Meniere's, BPPV, acoustic neuromas, labyrinthitis secondary to surgery, like stepidotomies, tympanoplasties, or fenestration procedures. Uncommon would be superior canal dehiscence, posterior canal dehiscence, perilimb fistulas, vestibular neuritis, labyrinthine trauma with or without fractures, vascular hearing loss with persistent vertigo. Rare causes would be stenosis of the internal aortic canal and cervical vertigo. The criteria for surgical intervention would be only in the presence of incapacitating vertigo, with failure of medical management, which has been tried for a minimum of 6 months, preferably in unilateral disease. The factors for selection of surgery would be the pathology. For example, only if you have the pathology of endolymphatic hydrops, you are going to opt for a sac decompression. Hearing in the affected ear, of course, is an important factor, whether the patient has serviceable or non-serviceable hearing, if the hearing is above 70 dB or not. Age, of course. If it is a very elderly patient, then you would be hesitant to opt for nerve sections because of the delay and also inadequate central compensation mechanisms. Occupation, if it is a housewife who has Meniere's, then she would be able to manage the episodes by just resting for a while and taking some medication. Whereas my threshold for intervention would be a little lower in case of, say, a truck driver or a person working in a factory operating heavy machinery, etc., where I would be interested in intervening a little more. Then the surgery can be classified into hearing preservation procedures and hearing destructive procedures. Hearing preservation procedures are the sac decompressions, endolymphatic duct clipping, and I have introduced more recently laser duct plugging, vestibular nerve sections, which can be carried out by various approaches like the MIRA, that is the minimally invasive retrosigmoid, originally popularized by Professor Brahma, then retrolabyrinthine, and mid-fossa can also be done through a translab in cases where the hearing is already not serviceable. And in selecting these procedures, if it is an extensively pneumatized mastoid, I would prefer to go with a retrolabyrinthine rather than retrosig because of the increased risk for CSF leak from the cells in the periphery of the craniotomy. And destructive procedures, of course, you have the gold standard, which is the labyrinthectomy. This is a sac decompression being carried out. Here, I'm just delineating the short process of the incus always by curating close to the bone ossicles, and then you're thinning out the posterior canal wall, identifying the facial descending part, which is another landmark, and then the bone block of the labyrinth, which is yellowish, and you use Donaldson's line, which is a line passing through the horizontal canal, bisecting the posterior canal. Just inferior to that, you see the sac, which is a double layer of the dura, and here the sac is being incised, and then that's the lumen of the sac. I'm just forwarding the videos for paucity of time, and that's a piece of stylistic being introduced. And the results with this procedure are at about 80%. Hearing preservation, about 65%. There is a 2% risk of CSF leaks and meningitis. Then we come to the duct clipping. This, again, you have to, the basic steps are, again, a wide mastectomy, and you identify the labyrinthine block, but you have to go further anteriorly, and you have to identify the delicate duct that tends into the vestibule area, and this is a vascular clip being identified after delineation of the duct all around. This is an edited video, and here you can see the duct clipped, and the complications in this procedure are a CSF leak, possibility of associated meningitis, bleeding, and duct avulsion is again something that I have seen because the duct dimensions are very slender. It's about 0.09 to 0.2 millimeters, far lesser than a stepidotomy fenestra. So the results of duct clipping compared to sac decompression are far better. The efficiency is at about 95%. Then coming to vestibular nerve section, again the indications are disabling vertigo in the presence of good hearing. And in bilateral disease, this is a good option. And so this is being done retrosigmoid, and the craniotomy being extended further anteriorly. And this is a anteriorly based flap, dural flap being taken. And before you start this, you ask the anesthetist to hyperventilate in order to cause the cerebellum to fall back so that you get adequate space to do the procedure without retracting the cerebellum. Here I'm going along the posterior surface of the temple bone. And in this particular case, the vestibulocochlear bundle is surrounded by a lot of vessels, dissecting out the arachnoid slowly. Yeah, here you can see Bremon's vessel running linearly along the long axis, which is again a landmark to differentiate between the vestibular fibers and the cochlear fibers. Also, these fibers are more yellowish, those fibers are a little bit grayer. And so this is the completed nerve section. The results with this procedure are at about 98%. And now we come to labyrinthectomies. This is indicated in intractable vertigo in the presence of unserviceable hearing. Other indications would be in patients who have severe pressure or severe tinnitus, sound distortion, or efferent suppression of the other ear. Types of labyrinthectomy: you can go transcanal and carry out the procedure, and you can also do it post-auricular. You can go post-auricular and also combine it with a scarpous ganglion excision. So here you do an extended mastodectomy, and that's the vertical facial being identified there, and that's the yellow block of the dense labyrinthine bone. And then you just identify the three canals. You can see the lateral, the superior canal with the subaquate artery running through, and that's the posterior canal there. And that's the endolymphatic duct entering the crus area. And slowly I have opened the vestibule, and that's the neuroepithelium. And one important factor is that you have to ensure complete removal of the neuroepithelium in order to get good results in this procedure. This, again, gold standard. Any patient, any other treatment for vertigo, patient not responding to it, this gives 99% of vertigo control. And it can be combined nowadays with the cochlear implant at the same sitting to restore the hearing of the patient. So you do the labyrinthectomy and simultaneously you implant the patient. This is an acoustic neuromer post-gamma knife where it was causing severe vertigo. She was a saint from Mathura. She had come with severe vertigo. She couldn't travel abroad to deliver her satsangs, and so they had brought her, and I'm just going to forward all this because this is not exactly vertigo surgery. It's all other causes of vertigo. So, okay, coming to SSED. This has an incidence of about 10%. Patients present with Tullius phenomenon, and on testing, you will find conductive hearing loss and VEMPs at low thresholds. And this can be treated either with resurfacing or occlusion. And this is a patient from Mauritius. He was a media person. He didn't want an intracranial procedure, so I didn't opt for the middle fossa in this case. So I went transcanal, and I have delineated the round window, and you have to cut the cartilage to the exact size to fit the round window. That takes a bit of trial and error. You have to keep sizing it and get a good fit on that. And that is followed by some bone wax. And shush. And I followed that up with some fascia as well. Then this is a child, 10-year-old child from the east coast of Tamil Nadu, brought with severe injuries all over his face and scalp, sutured, and was on anti-epileptics for several years, at least for 8 years of his life. And he was falling 30 times a day. And on imaging, it showed posterior canal dehiscence, which was bilateral. And so in this child, I opted to do a canal occlusion with resurfacing. Here I have identified the posterior canal, and that is the canal occlusion being done. And this gives a result of about 93 to 97%. This is a perilymph fistula with CSF leak. On tympanotomy, you can see the leak coming from the footplate area. I'm just using the KTP to remove the suprastructure of the stapes atraumatically. You can see the upper margin of the oval window from where the leak is happening. And I use a piece of fascia initially. And of course, since the leak was a little bit more, it was floating up. And so I also augmented it with a really thick piece of cartilage, which I wedged between the incus and the promontory. And the patient did well following the procedure. Now, this is my modification of the duct clipping. For the duct clipping, you have to dissect the duct, which is a really delicate structure. It's only about 0.09 to 0.2 millimeters. That is, like I mentioned earlier, far lesser than a stepidotomy fenestra. So removing the bone all around that is far more difficult than removing bone around the internal aortic canal. That is without causing complications. You can injure the dura and cause a leak. You can cause bleeding from the veins there, and also you can have meningitis. And I have seen the duct being avulsed also in a case. So for that, I came up with the solution of doing the same thing from within instead of from without, because going all around the duct is more cumbersome. So I just used the laser and created a raw area in the region of the duct and used some subcutaneous tissue and plugged the area. So the advantages of my modification of this is a shorter duration of the procedure, and also junior consultants who are working in corporate hospitals, for them this is a good technique because the dissection is not as delicate and difficult as it is for duct plugging with the ligature clips. That is a little bit more complicated. So thank you one and all for a patient listen.
Thank you, Anjana ma'am, for a wonderful talk.
Thank you, everybody. Share my experience of revision cochlear implant surgery. As you know, the first cochlear implant surgery was done in 1961, whereas the first revision cochlear implant surgery was done in 1985. It took almost 15 years for first revision. The incidence of revision surgeries in cochlear implantation varies from 3% to 15%. It is less common in adults compared to the children. Almost it is double in children. The indications for revision surgeries are divided mainly into non-device related indications and device related indications. So non-device related indications contribute 25%, whereas the device related contribute almost 3 times. So in our program, we've done about 835 cochlear implants till date, out of which more than 95% are pediatric and less than 5% are adults. In our revisions, we had mainly the pediatric patients whom we had to revise in 25 cases, adults were nil. So we had non-device related indications in 44%, whereas the device related indications in 56%. So the indications what we had in our thing, as for the non-device related, we had infections like scalp infection in 3, cholesteatoma formation in 2, post-implantation, where we didn't have any case where there was an allergic reaction developed to the silicone, which is used for encasing the implant body. The extracochlear electrodes placement, like misplacement of the electrode, was in 5 cases. These are the cases which were done mainly in my mentorship centers, because I mentored more than about 40 cochlear implant surgeons. So when these cases had happened, I had gone and revised them. There was one case of extrusion of the electrode array, partial extrusion, which we had to revise and do the reinsertion. So regarding the device-related indications, we didn't have any patients where we had to revise CI because of the facial nerve stimulation, which I'll just come how it happens. The confirmed device hard failures where we had 12, and whereas the soft failures we had 2 cases. This was a patient of these patients like infection where there is a bacterial biofilm formation and wound dehiscence and exposure of the implant. had to be revised. So initially, when there is only a partial exposure, trying to save these implants with antibiotics and revision surgeries, flap rotations and all, majority of the time they fail, and ultimately they land up with explantation of the implant and reimplantation. So this bacterial biofilm formation, the major etiopathogenesis of any infection surrounding the implant is because of the biofilm production. So the implant being a foreign material, the body cannot develop microcirculation surrounding the implant, hence the antibiotics are unable to reach it. So any source of infection surrounding the foreign material will multiply and adhere to the implant surface and later on produce exopolysaccharides, which leads to biofilm production. So the body also forms a foreign body reaction, forming granulation tissues surrounding the implant, which also hampers the recovery from infection. These are the patients. This is a chart showing where we had to revise because of the scalp infection and cholesteatoma formation. As you can see here, the 3 patients, 1 with scalp and 2 cholesteatomas, who were reimplanted after the explantation at a later date, not on the immediately. We had used both cochleostomy as well as one case we had to implant on the other side, whereas in one case we had done an inside-out mastectomy with lateral aortic wall reconstruction and preserved the implant initially. But this patient, as you see later in the last case, came back with a recurrent cholesteatoma when we had to do a subtotal petrosectomy with explantation and reimplantation. And all these cases had a complete insertion of the electrodes, and these are the outcomes what we had: good NRTs in 2 cases and no responses. This patient, cholesteatoma patient, also had a thin cochlear nerve. So even on the initial stage, we didn't have responses on the table, but later on during the switch-on times, we observed responses to some of the electrodes, and the child was doing well, and even now she's studying in normal mainstream education. The other 2 patients who have been explanted recently, they are waiting for the reimplantation. This is one of the small video where we had done the explantation because of the infection, flap necrosis, where, so as you can see, the implant has been removed earlier, but we had left the electrode array, which the mastoid cavity was clean, middle ear was clean, so we had left the electrode array inside the cochlea, that part, and cut the electrode array at the mastoid and removed the implant. So where we are now dissecting at the second stage all the granulation tissue surrounding the electrode array. One has to be very careful because you had to perform this mastectomy also again and thin the posterior canal wall. And while dissecting the electrode array, one has to be careful not to accidentally pull out in the initial stage itself, because that leads to collapse of the intracochlear tract, what you had created earlier. So even in the posterior tympanotomy was completely occluded by the granulations, which we dissected nicely, and then later on the electrode array was completely freed till the area of the cochleostomy. So once we did that, we had to recreate the bed for the implant. So we did make the bed again along with the electrode tunnel array, tunnel for the electrode array. And also we created the tie holes because we wanted to anchor this implant again. This is one of my initial cases. So after the bed is made, then we did the final dissection around the cochleostomy, and this was a Freedom Contour Advanced implant. So then we housed the new implant into the bed first and then anchored it. After anchoring, then with one hand, as you can see now, so I am going to pull out the electrode array with the left hand, and immediately after pulling it out, we are inserting the new electrode array using the same intracochlear duct, slow and gently, and we were able to do a complete insertion in this case. So earlier it was a contour advanced electrode, but for the revision surgery, we used the straight array of the cochlear. So the idea is either you should have a similar type of electrode array, same size, or one can have a little thinner electrodes when doing the revision surgery. So in cases of cholesteatoma, ultimately, in an implanted ear, one can do either an intact canal wall mastectomy with preserving the implant whenever possible, because in our country, no majority of the patients are paid for the implant. It is not easy to make them to pay for another implant. Because it is an infection, the company also will not give a free implant. So if the electrode array is not involved, one can preserve it. If the electrode array is involved, then explantation can be done with the stenting of the cochlea and revision cochlear implantation after 6 to 12 months. Modified radical mastectomy with explantation and cochlear implantation on the contralateral side, like what we did in one of our cases. And of course, ultimately it will be a subtotal petrosectomy with complete clearance of the disease and blind sac closure with explantation of the device and reimplantation at the same sitting can be done on the same site. The silicone allergy is device extrusion due to liquid silicone rubber allergy. As you see here, the different companies use a different grade liquid silicone rubbers, and everyone has got that allergic kits to do the patch test or a prick test. And we did use one of the allergic kits for the nucleus, where we had suspected one of our patients who was getting repeated exposures. So, but it came as negative. But if it is positive, one can do an explantation and revision cochlear implantation 6 weeks later with either a custom-made CI or a ceramic receiver stimulator, where we don't need to use the liquid silicone rubber. So this extracochlear electrode placements, which happened, as I mentioned earlier, in our mentorship centers, where it's different. So one may wonder why vestibule, but one of these patients, surgeons had, because he was not able to find the round window and do the cochleostomy or something, he had, somebody advised him, I don't know, who he opened the oval window, had put the electrode into the vestibule thinking that it will function, like what we do when we do a vestibular, scala vestibular insertion, but it didn't. So ultimately we had to revise that. One was semicircular canal through the vestibule that had gone, and another in the carotid area, because he had mistaken the hypotympanic cell and pushed it through the hypotympanum and gone there. One was in the internal aortic canal. And another one very interesting, basal turn was opened and then it had gone into the crotch area, as you can see in this picture. So as you can see, initially it has entered the basal turn, then come out of the basal turn, and then gone into the tip, had gone into the crotch area, as you can see. So I revised this after 1 month of the initial surgery. See, as you can see, it has gone into this. This is a carotid area. It had come out of the basal turn. So we cut the electrode array first. I removed the receiver stimulator, and then I pulled out this was a cochlear implant, nucleus implant. We pulled out the ground electrode array, and again, even though it was just 1 month, you could see already the cortical bone had grown a little bit. It had narrowed down the cortical mastectomy cavity, and lot of granulations around the electrode array. Again, similarly, with the help of iris scissors and sickle knife, we just dissected out all the granulation and separated the electrode array from the granulations. I had to extend the mastectomy and thin the posterior canal wall. Even the posterior tympanotomy had to be widened, especially inferiorly, to expose more area of the middle ear. And we were able to see the cochleostomy through which the electrode array was going. Then my idea was to identify the round window. So we opened up the granulations, and there was a bone covering the upper round window. Then I had to remove the, this is showing low battery. Is it working? It's connected now. Can you just check? Yeah. Thank you. So after dissecting out all the granulations, I was able to open up and identify the round window. Just now I'm drilling the upper lip of the round window. The round window membrane was exposed, then which I checked with the ossicular mobility. I could see the movement of the round window very clearly. The cochleostomy was just in front of that, through which the insertion was done, earlier insertion. So after decongesting the middle ear and the mastoid, then we had decided, I just pulled out that electrode array. You could see the electrode array had kinked so much at multiple levels, so there was no chance that I could use the same array again. So in which we used the new implant. So just now you can see I am puncturing the round window membrane with a 23 number hypodermic needle to make sure that I am going into the cochlea only. And now I am inserting a dummy electrode first because the basal turn was transgressed through. I didn't want my electrode, a radio electrode, to go through the false passage outside. So once we put the dummy electrode and then checked with the CM picture on the table, I could see the electrode array nicely curling into the cochlea. Then I opened the new implant, housed it in the bed, and then I pulled out the dummy electrode and then used the actual electrode. It was again a straight array, slowly and gently through the round window insertion, and we were able to do a complete insertion and got good neural responses in this case. So as you can see again, the Chuck X-ray is showing the electrode array inside the cochlea, and we checked the impedances except 6 and 7 were open circuit, rest of the impedances were fine, and even the neural responses we got from beyond 8th electrode but the basal electrode we didn't get. So this was one of the cases partial extrusion. As you could see, majority of the electrodes are outside here, so this was revised and reinsertion of the electrode array was done. Coming to the facial nerve stimulation, the incidence is about 1 to 15%. Usually this happens because of the stimulation of the facial nerve in the outer wall of the cochlea. Hence, this is common with full band electrodes. So it's more common with malformed cochleas and ossified cochleas. So hence, in these cases, one would like to select a perimodular electrodes, that is a half band modular hugging electrodes, so that the stimulation in the lateral wall will not happen. Anyway, we didn't have any patient where we need to revise the implant, because majority of these patients, which we had about 4 or 5 patients, were managed with relocation of the allocation of the frequency things and switching off those particular 4 electrodes which were causing facial nerve stimulation. From device failures, we had both hard failures as well as soft failures. These are the features for the hard failures, and these are again the features for the soft failures. One should see these non-auditory symptoms in a soft failure is one of the important points, because that will act as a good prognostic indicator after revision. So we had 5 nucleus 5 series implants, which were because of the hermetic seal problem, where the company had to recall these implants. For 4 cases, 1 nucleus straight array soft failure was there. And in advanced bionics, again, there was 1G electrodes which were soft failures, plus also 1 because of a child, a mentally retarded child having injury to the blunt injury to the head, and then the receiver stimulator exit point, the electrode array had broken. So, and there were again another 6 advanced bionics ultra V1 series implants, which were again because of the hermetic seal issues, they had to call back. These had failed. So these were revised with the new implant. So as you can see in this chart, device failures, we had nucleus 5 in 4 cases, Iris 1K, advanced bionics, and nucleus straight array, and nucleus helix soft failures, 2 soft failures and 1 trauma and other hermetic seal issues. All were with the cochleostomies which were done, and the second insertion was done with the implantation was done, and we had a complete insertion in all these cases, and these were the implants which were used, so the second time in each individual case. These are the cases where there was a V1 failure. So these are the findings which made us to think about the failure and then go ahead, like open electrodes or absent responses, and where the dropping of the impedances in different electrodes, especially the basal electrodes which had stopped functioning. So all these were ABA ultra high-res ultra electrodes, V1 series. And the second time, they gave the all latest implant, like AB high-res ultra 3D implant, which was 3 Tesla compatible. And as you can see, most of them were the round window insertions or the extended round window insertions, and cochleostomy in 1 case. We used the same intracochlear tracts in these cases, as I showed in my first video. So removing with one hand and insertion with the other hand at the same, immediately after the explantation. So in almost all the cases, we could get the NRIs again, and in some cases even we got the electrically evoked stapedius reflex also. So outcomes of revision surgery in non-device related causes, usually it is almost 90 to 100% improvement in speech perception, whereas in soft failures it is a little less, maybe 67 to 83%. And non-auditory symptoms in the soft failures gives a good positive prognostic factor. Just a small video just show. Oh, sound. Can you give the sound? Sound. Hi. ಬರ್ತಾ ಇಲ್ಲ. Not coming, man. Sound नहीं आ रहा है. मैं play करूँ.
My name is Tanvay. I am 10 years old. Studying in 4th standard. At Shivani School, I play many different games with my friends. After school hours.
ಸ್ಕೂಲ್ ಇತ್ತು 2 ಮನೆಯಿಂದ ಒಂದು ಸ್ವಲ್ಪ ಲೇಟ್ ಆಯಿತು. ಹೌದಾ? ಸ್ಕೂಲಲ್ಲಿ ಏನು ಯಾವ್ಯಾವ ಲೆಸನ್ ಮಾಡಿದ್ರೆ ಇಂಟ್ರೊಡಕ್ಷನ್ ಲೆಸನ್ ಮಾಡಿದ್ರು, ಕನ್ನಡ ಕ್ಲಾಸಲ್ಲಿ ಬರ್ಸಿದ್ರು, ಹಿಂದಿ ಮಾಡಿದ್ರು.
As you could see, they had a very good speech, which they had done immediately after the first implant also. So the tips for the reimplantation is always use a bipolar cautery, and the electrode array should be dissected out surrounding the fibrous tissue carefully, avoiding accidental pull-out in the initial part of the surgery. And the new electrode array should be of the same size or the smaller size in diameter. So in the device failure cases, the same intracochlear part of the electrode array is left in place and use the same intracochlear tract for reimplantation. So extracochlear electrode, in cases of extracochlear electrodes, preferably to use a round window or an extended round window cochleostomy. And so in these cases, either use a dummy electrode first to check the position of the C-arm, as you saw in one of the videos, before doing a reimplantation. So one should remember that improper technique leads to incomplete insertion or a traumatic electrode insertions, which will affect the performance of the child. So one has to be very careful. So in conclusion, I would like to say that revision surgeries have become an inherent part of a CI program and are expected to increase as the number of CIs in the centers increase. Patients and parents should be counseled that performance is expected to equal or surpass the child's best level of performance before surgery, although this may take some time and exceptions do exist once in a while. The revision cochlear implantation should be considered when longitudinal clinical assessment reveals an unfavorable trajectory in the development of the receptive communication skills. A delay to act can have lasting negative consequences because benefits seem to diminish with age. So we strongly emphasize the need for close monitoring and special attention regarding follow-up of babies and young children, especially during their initial years of implant use. Thank you very much. This is our conference.
Thank you, sir, for this enlightening talk. I think that the average...
More sometimes, I think so. We have to change our counseling strategies now. Thank you.
Speaker is Dr. Abhishek Vaidya. Sir, is he here? He will be speaking on NBI.
I invite Dr. Abhishek Vaidya. He is in Department National Cancer Institute, Nagpur. He done fellowship in oncology from Tata Memorial Hospital.
Today is to speak about locally advanced thyroid cancers and how best we can manage them. So to begin, we know that the incidence of thyroid cancers is on the rise the world over. However, the good thing is that most of these will be differentiated thyroid cancers and they have excellent prognosis. However, there exists a smaller subset which are locally invasive and these portend a slightly worse prognosis. Further, there are medullary cancers, most of which have either extrathyroidal extension or nodal metastasis. Worse still, there are anaplastic carcinomas which are very rare, but almost all of them are locoregionally very advanced. So how do we tackle them? That's the agenda today. So in short, locally advanced thyroid cancers are in the form of a crouching hidden tiger who are there to attack you at any time. So in this talk, we'll know about the definition of locally advanced thyroid cancer. How do we do a preoperative evaluation completely? We'll speak about the management itself, regionally advanced disease as well as locally advanced disease, and a few new paradigms which have come into play in the past 5 years or so. So definition, there is no exact definition, but some of the features which can be considered for locally advanced thyroid cancers are extrathyroidal extension into the recurrent laryngeal nerve, trachea, esophagus, straps, and so on, heavy nodal burden, attachment to the vessels or to the carotid sheath, and finally a huge thyroid with a lateral or retrosternal extension. Once again, there is no clear-cut definitions. Extrathyroidal extension, in fact, is better defined. This is divided into minor and major. Minor includes invasion of the strap muscles, soft tissues, and recurrent laryngeal nerve, whereas major involves invasion of trachea, larynx, or esophagus. So coming to preoperative evaluation, remember that thyroid nodules come in all sizes and shapes. And some of them, this here looks very innocuous, but it can be invasive. So what are your indices of suspicion clinically? So long-standing goiter with a sudden increase in size, a rapidly growing nodule, extremes of age, compressive symptoms in the form of dysphonia, dyspnea, and dysphagia, something which is abnormally hard in consistency or fixed to the adjacent structures, vocal cord palsy, needless to say that, and associated lymph nodes. So preoperative workup, the most basic is laryngoscopy. This is mandatory for all thyroid cases because preoperative vocal cord palsy is one of the most important clinical predictive factors of local invasion. Moreover, 1/3 of the patients who have a vocal cord palsy may be completely asymptomatic. So a normal voice need not mean that your vocal cord, your recurrent laryngeal nerve is not involved. Ideally, more and more, this should be done with flexible laryngoscopy. What imaging? Ultrasonography is basic, but in the slightest of doubt, do a contrast CT scan, especially when you want to know the relation of this nodule to the surrounding structures. My disclaimer here is that I personally prefer a cross-sectional imaging whenever I get a diagnosis of carcinoma thyroid. And this is the case in point. Young girl, seemingly simple thyroid, solitary thyroid nodule, but when I did a CCT, it gave incremental information in the form of this node here in the pretracheal region. There was no tracheal invasion per se, but there was some irregularity which can be seen here, so SHINS 1. Other investigations, MRI is complementary to CT, especially for laryngeal invasion. PET CT scan only to pick up distant metastasis and rule out dedifferentiation in very advanced thyroid cancers. Upper GI when you suspect esophageal involvement. Tracheal assessment is critical. You should do a CCT with thin cuts at the larynx, 1 millimeter cuts at the larynx, and then do a multiplanar recon and also ask for a virtual bronchoscopy. Flexible tracheobronchoscopy, most important. You can see here that there is an intratracheal extension of the thyroid. This was a case that we operated and did a tracheal resection for. Coming to locally advanced disease, and the most common of these is recurrent laryngeal involvement. In fact, 1/3 to half of all locally advanced disease is due to recurrent laryngeal nerve involvement, and as I said previously, 1/3 of these may be asymptomatic. So the important factors when you take into consideration regarding management are pre-op symptoms and laryngeal function, the degree of nerve invasion, where exactly in the course of the nerve the involvement is there, whether there is contralateral disease either in the central compartment or in the nerve itself. What does a patient want? Is the patient okay with having a tracheostomy, or is he okay with having some disease left behind? What are the treatment options adjuvant, radioiodine or EBRT? And finally, you should use an intraoperative nerve monitoring analysis, and I'll show you that. So as I said, recurrent laryngeal nerve can be treacherous. Here you can see that we've lifted the complete thyroid lobule off, and yet at the posterolateral aspect there was adherence. Here this was a worse adherence because before lifting off there is involvement right at the TE groove. So what do we do about this? This is very well reflected in the American Head Neck Society consensus statement. Whenever the recurrent laryngeal nerve is encased by the tumor, once again, encased by the tumor, there might be 3 scenarios. Is the ipsilateral cord paretic or paralyzed on your preoperative examination? Yes, resect the nerve. If bilateral cords are mobile, spare the nerve. Even if the RLN is encased, spare the nerve. And I'll give you the reason why. And if contralateral cord is paretic or paralyzed, once again, needless to say, you go ahead and spare the nerve. When recurrent laryngeal nerve is minimally adherent, preserve the nerve. Remove all the crummy tissue around it and preserve the nerve. Now, this might sound a bit counterintuitive, but remember that the center, this part, is reserved only for well-differentiated thyroid cancers. In medullary thyroid cancers, you should resect the nerve whenever there is encasement, because in well-differentiated thyroid cancers, there is a good fallback option in the form of radioactive iodine. Intraoperative monitoring is something which is coming into the fore in the past decade. There are several meta-analysis and guidelines, but this comes from India. And the basics of this is that it is useful in revision surgery, and it is useful in malignancies, locally advanced, and whenever there is bilobal disease. It has a trend of decreasing permanent and temporary vocal cord palsies both. How do you do it? I'm going to need audio in this. Audio laega. So this I'm stimulating the external branch of the superior laryngeal nerve. Yeah.
And
so you can hear the impulses. That's the recurrent laryngeal nerve. And you corroborate that with the amplitude of voltages you get on your screen. Typically the stimulating current is about 0.5.
Stimulating.
So how do you manage a resected nerve? Let's say you have to resect a nerve. As far as possible, you do an immediate reconstruction. This will be in the form of end-to-end anastomosis whenever the two ends can be brought together. If the two stumps cannot be brought together, then you put in a cable graft, usually from the great auricular nerve. More advanced options are anastomosis to the ansa or vagus or a muscle transfer. One more thing, especially in the elderly, always consider a medialization procedure on table, which may in the form of thyroplasty or injection laryngoplasty, but you want to do it so that until there is some compensation, there is no aspiration. So especially in the elderly, do a medialization procedure on table. So to summarize how we manage the recurrent laryngeal nerve involvement, can be divided into two: if there is preoperative vocal cord palsy and if there is no preoperative vocal cord palsy. If there is preoperative vocal cord palsy, sacrifice the nerve in the involved part. Nerve repair has always to be attempted. If there is no preoperative vocal cord palsy, leave that side. If you think that the nerve's at danger, leave that side. Go to the opposite side, save the contralateral nerve. This approach, I call it money in the bank. Put your money in the bank and then go to the risk situation. Use magnification. You can use microscope. I prefer to use loops because they give a broader field of vision. Then try to dissect the tumor away from the nerve. Small amount of unhealthy tissue may be left on the nerve, but not gross residual. If there is gross residual, you will have to do a segmental sacrifice and then once again a nerve repair. So this is a video of shaving off the trachea. I'm standing at the head end. This is a locally advanced case. You can see that that is the vagus. This is the carotid. The internal jugular vein has already been sacrificed. And I'm using magnification in the form of loops. I'm using a micro scissors. That's a central compartment node. I'm using it to dissect it away from the nerve. I'm holding the nerve up with micro hooks. And despite this, at the end of 3 months, this patient had a post-op vocal cord paralysis. At the end of 3 months, her vocal cord has returned back to normal. That is the importance of carefully dissecting the nerve using micro dissection. We move on to the next part, tracheal involvement. Tracheal involvement occurs in about 1/3 of the patients of invasive thyroid cancers. However, intraluminal tracheal involvement is rare, occurring in only about less than 2%. Tracheal invasion, as opposed to recurrent laryngeal nerve involvement, has a gross impact on survival. How do we manage that? Before we understand how do we manage that, let's understand what are the grades. This has been given by Shin and Grillo. So these are divided into 1, 2, 3, and 4. 1 is when the tumor is approaching the outer perichondrium and it is stuck to the outer perichondrium. It is not invaded the inner perichondrium of the trachea. 2 is when the tumor has crossed the outer perichondrium and just short of the inner perichondrium. 3 is when the tumor has lifted the mucosa, but it has not yet become intraluminal. 4th is what I showed you the video about. The tumor is now intraluminal into the trachea. So how do we approach a tracheal involvement depends upon what is your Shin's classification. And what are the surgical options? Surgical options are shaving for extraluminal tangential excision. This is an extraluminal tangential excision. Wedge resection or partial resection with a primary repair with or without a flap reconstruction, and circumferential resection with primary end-to-end anastomosis. So this is shaving, this is a wedge repair or a sleeve resection, and this is a circumferential resection. When do we use what? So according to Shin's classification, Shin's 1, when there is adherence to external perichondrium only, just do a shave off. Shin's 2 and 3, when there is infiltration of the perichondrium, do a sleeve resection of the trachea. You don't need to do a complete resection of the trachea. Shin's 4, when there is disease extending to the tracheal lumen, do a segmental resection of the trachea and end-to-end anastomosis with tracheal mobilization procedures. So this here is a case of Shin's 2/3. After resecting, we found that there is some amount of unhealthy crummy tissue here left behind on the trachea. So a sleeve resection of the trachea was done with a primary repair. Now, this is a video of tracheal resection. I'll try to go quickly through this. This video is an old video. It's courtesy of Dr. Shah. We joined surgery where total thyroidectomy has been done. You can see bilateral central compartment has also been cleared. The first point then is to isolate the trachea from the esophagus. You want a good plane of isolation because you want to take that part of the trachea off. You can see that the esophagus is bulging there. I'm sorry, I went a little too ahead. Once you isolated, you pass a surgical glove between the trachea and the esophagus and then resect the involved part of trachea under vision. Once the lower part of the trachea has been cut, you take a tagging suture there so that it doesn't retract into the mediastinum. You then bring out the airway. So this is completion of the posterior cut. Correct. So you then isolate the segment of the trachea, bring it out, and then reinsert the airway. Now, when the amount of tracheal resection is small, for example, in this about 2 to 3 rings, what you can do is simply a laryngeal drop. This is known as the Montgomery or the suprahyoid laryngeal drop, and this will allow you a mobilization of about 2 centimeters. Tracheal closure is usual. You do parachuting sutures for the posterior aspect, and then come on to the anterior aspect. Start from 3 o'clock, 6 o'clock first, and then bring it out anteriorly. At the end of it, always do a puncture test. What about laryngeal involvement? Laryngeal involvement is less common still. Management has to be individualized depending upon where exactly the larynx is involved. If perichondrium is intact, do a shave or a peel off. If there is cartilage invasion, most often partial laryngectomy is possible because you don't need so much margins in thyroid cancer as you need in a squamous cell carcinoma. Total laryngectomy is reserved for situations wherever there is airway obstruction, luminal hemorrhage, or intraluminal invasion. So once again, to recapitulate, larynx, these are the stepwise manipulations you can do. If there is only partial adherence, peel off the tumor. If there is more adherence, you can do a partial laryngectomy, usually anterolateral partial laryngectomy because where the thyroid is involved. Total laryngectomy is rare. Laryngopharyngectomy, very, very rare. And I'll tell you the reason why. So this again is a case of laryngeal involvement, and what you can see is has been a shave off has been done of the thyroid cartilage. Locally advanced extending into the esophagus. Now, fortunately, whenever esophagus is involved, it is only the muscular. Usually, it's only the muscularis which is involved. So the options are between excision of the muscular wall, only when the muscularis is involved. Partial esophagectomy, as I said previously, is very, very rare because intraluminal involvement of the esophagus, fortunately, is very rare. So this is an example of excision of the muscular wall. You can see an entire large window of the muscularis has been removed. This is another case which we've done recently. A central compartment node was invading into the esophagus, so we've done a segmental part of resection of the muscularis wall. So to summarize, involvement of the esophagus and the larynx, when there is focal superficial involvement of the esophagus to an excision of the muscular wall, when there is intraluminal extension, a partial or segmental esophagectomy is done. But when there is involvement of the cricopharynx and extension to the larynx, you will have to do a partial laryngectomy with a pharyngectomy. Now, regionally advanced disease. Often you have to do central compartment dissection, and these are the steps which I follow. Complete total laryngectomy and, okay. So before I finish, I think I have a minute. I'm going to show you a video of local adherence to the carotid sheath. Once again, this is how you dissect it off using micro scissors. And this is the final result that you get. Before I end, these are some of the situations where you have a large involvement, and what you're required to do in such situations is approach it laterally and finish a total thyroidectomy.
Abhishek, last 2 minutes.
Yes, I'll take less than a minute. And this shows the operative bed. You can see that we have completely mobilized we are holding the vagus, the carotid, and the vein. A newer paradigm is the use of pre-op lenvatinib, which we have used in 3 cases until now. These are the remarkable decrease in size that we get, only 11 cases reported so far. So to conclude, advanced thyroid cancers are a challenging part of thyroid cancer. Optimum pre-op evaluation is must. Surgery still is the mainstay. Preserve the recurrent laryngeal nerve when possible. Resected recurrent laryngeal nerve must be reconstructed. Intratracheal invasion is rare but demands segmental resection. Esophagus usually requires only muscular extension. Use intraoperative nerve monitoring. Practice, you can do it, and use lenvatinib as a pre-op when possible. Thank you so much.
Sunil sir giving a talk on completion adenotectomy.
Coblation in huge amount.
Good morning, Jai Shri Krishna. It's a really great pleasure and a privilege to talk in front of such an august gathering. And respected chairpersons, respected teachers, and all delegates present here. After highest surgeries in the ENT like cochlear implant and thyroid cancers, I'll again come to the basics of ENT. As we all know, adenoid is bread and butter of ENT. We all get multiple patients of adenoids day-to-day practice. So I will start my talk on my experience on a coblation adenoidectomy. First, I always thank God. Because of him, I am here. So he always says, Ananyas chintayanto mamya jana paryupasate tesham nityabhyuktanam yogakshemam mahamyam. He will always take care of you, not to worry. So, this is one of the commonest surgery done worldwide. There is always a concern to improve the outcomes and make post-operative experience more pleasant for childs and adults. Chronic adenoiditis and adenoid hypertrophy affects pediatric population significantly, but we are now seeing younger adults also coming with the adenoid problems in snoring and sleep apnea. And we all know that chronic otitis media with effusion, recurrent sinusitis, obstructive sleep apnea, craniofacial and dental developmental problems are some of the sequelae of adenoid hypertrophy. So this is the most basic and compulsory investigations, X-ray nasopharynx to see the size of the adenoids, nowadays replaced by flexible laryngoscopy, but still patient needs a cooperation with that. Okay, so what are the available techniques we are having? Various surgical techniques and day-by-day improvement in the techniques for adenoidectomy. We have got a conventional curettage technique which is still done. Again, with endoscope, conventional curettage. That was the one step ahead. Now, powered instruments like microdebrider, and the latest technique I feel is the endoscopic assisted coblation adenoidectomy. So, curettage adenoidectomy, it is the oldest method, very old traditional method. We were taught in our PG days. It is still practiced all over. It is really fast method, but with a lot of disadvantages. So we all know that excessive bleeding intraoperative is the major factor with the curettage technique. Another problem is incomplete removal, as it is totally blind procedure. Damage to the surrounding tissues like a stretch tube orifice, pharyngeal mucosa. Trauma to the pharyngeal mucosa leads to the severe pain after the surgery. So another technique, as I told, like previously we were doing blindly curettage, but with the advent of endoscope, we used endoscope with curette. That was a little better. But again, it was, once the bleeding started, we start packing the nose, we put the gauze, again we remove, we put the gauze, and finally we finish it fast and leads to trauma to the surrounding structures. So now with a powered instrument like a microdebrider, this is also new technique available nowadays, much better than conventional curettage. In this also, clearance is almost 90%. It is under vision with endoscope, no doubt. But again, the intraoperative bleeding is a problem with the microdebrider. Collateral damage to the stretching orifice and palate and uvula is noted in this. So in my view, coblation adenoidectomy is the best available technique for the removal of adenoids with help of endoscope. So in short, I'll just go through what is coblation. It is not heat-driven process. It does not char or burn the healthy tissue like conventional electrosurgery and laser surgeries. It is the term, coblation is the term derived from controlled ablation. It combines radiofrequency energy with the natural saline solution to gently and precisely remove tissue, leading to fast and easier recovery. So what are the principles? It is a technology based on non-heat-driven process of soft tissue dissolution, which makes use of bipolar radiofrequency energy. This energy is made to flow through a conductive medium like a normal saline. When current from radiofrequency probe passes through the saline, it breaks saline into sodium and chloride ions. These highly energized ions form a plasma field strong enough to break organic molecular bonds within soft tissue, causing its dissolution. So since 1950s, high-frequency electrosurgical apparatus have been in use. In conventional high-frequency apparatus, heat is made use of to cause the tissue ablation and coagulation. The heat generated happens to be double-edged weapon, causing collateral damage to the normal tissues. So coagulation is actually a beneficial offshoot of high-frequency radiofrequency energy. The excellent conductivity of saline is made use in this technology. This conductivity is responsible for energy plasma generation. So this is a pic of coagulation adenoidectomy. The mirror is still used in Western countries to see how the coagulation is working in old days. Okay, these are the components: radio frequency generator, foot pedal control, irrigation system, and wand. And this is a precise max wand. It's having active electrodes in front. There is a suction port, saline delivery, and return electrodes. So we need only two instruments, only mouth gag, endoscope, and a coagulation wand. That's it. This is the best thing of a coagulation, everything in a one probe. Now, what are the advantages? See, the main advantage is very, very less bleeding because it is having ablation and coagulation mode together. So as we start the surgery, any bleeding point is taken care immediately. With the help of endoscope, no doubt we have a direct view of adenoids in all the directions, and we have ability to reach all the areas of rhinopharynx up to the stretch tube orifice, superiorly, inferiorly, and laterally, as the wand is malleable. Pharyngeal mucosa is carefully preserved, as in a blind adenoid curate adenoidectomy, we were rubbing the pharyngeal mucosa and it was traumatized and the patient was having severe pain post-operatively. There is a lower risk of residual adenoid tissue and very less complication. The main thing, it is suitable for all ages As we are getting younger patients with adenoids like 15, 16 years old and maybe 20 years old patients are seen having adenoid hypertrophy. Previously, we were avoiding, like, no, you are now older, you are above the 12 years age, it will subside, and we were avoiding because there was high risk of bleeding in blind adenoidectomy. But with the help of coagulation, it has made very easy, and even in adult patient, it is more easier to use because we get a lot of space in the nose and intraorally. So, and the reduction in the usage of, it is suitable for patients of all ages, and that's why reduction in the usage of post-operative drugs, like to reduce the use of painkillers and all. Again, significant less pain post-operatively, no post-operative bleeding. We have seen few, I have not seen a single patient coming post-operative bleeding post-adenoidectomy. Surgical time is less and complete and safe removal of adenoid tissue. And the main thing, ability to use single instrument to ablate and coagulate tissue with significant improvement to patient recovery compared to the cold curettage. This is a small video I'll share with you because all adenoidectomy video, thanks to Smith and Nephew. So for coagulation adenoidectomy, we need little training. We have to use the nasal catheters to elevate the palate, and we have to decongest the nose preoperatively very meticulously. Even a single injury to the turbinate and the nasal mucosa will lead to bleeding, and your field will be disturbed. So we are using this Precise Max band. Both the coagulation and ablation. This is totally ablation mode. As we can see, we are reaching superiorly over the roof of the nasopharynx. We can go to the lowest margin to the passivans ridge. The adenoid tissue in the near the stretching orifice and fossa of Rosenmuller very clearly removed without traumatizing the stretching tube. If at all we get any bleeder, immediately it is coagulated. And we can see the mucosa behind over the adenoid bed, but it is not necessary to expose the complete mucosa. Complete debulking and creating a space in the nasopharynx and avoiding the trauma to the surrounding structure is the main aim of our surgery. See, we are clearing slowly all the adenoid tissue, and there is hardly any bleeding. Usually it is sufficient from only one nostril, but if adenoid size is very huge, then separately we have to do from the two nostrils. Sometimes gross deviation is a problem for putting the endoscope. In that case, we have to lateralize the mid turbinates. Like by out fracturing the turbinate, we can create a little space for approach to the adenoids. See, it's slowly, all the tissues is getting cleared. This is the same in the another nostril. The only thing is you need a little training for using the coagulation wand in tonsil especially, because wrongly touching the ablation wand in the tonsil will lead to severe bleeding. and it will make a big hole in the tonsil. Likewise, it's in adenoid also. Previously, even I had taken this coagulation method, but I took a training at Hyderabad, and I seen many surgeons in India doing good surgeries. So it's basically learning procedure. So these are the intra-op pictures, nice clearance and no bleeding. The most important endpoint of endoscopic assisted coagulation adenoidectomy is the reduced adenoid grade after surgery. That's why it becomes a technique has become standard approach for all the adenoid surgeries. Of course, having little disadvantages that, as I mentioned earlier, even after good pre-op preparation of the nose, mucosa keeps on oozing, which obstructs the vision. Cost is a major factor, as in each surgery of adenoid, it is advisable to use a new wand costing around 15 to 20,000 rupees. So sometimes we need 2 wands also. Proper training and learning in must to handle the wand gently. And why it is a gold standard method? Because it facilitates complete removal. Bleeding is minimal, every area is accessible to the wand tip, lower incidence of residual tissue to avoid recurrence, and lower risk of complications. Thank you so much. Thank you for.
Dr. P. Lakshmi, Bangalore. And
it is divided into external ear, middle ear, and the inner ear. And the inner ear is located inside the petrous temporal bone. A thorough knowledge of the surgical anatomy, physiology, its various etiopathogenesis is very essential before embarking on any of the diseases. From the patient's perspective of view, any hearing loss and everything they attribute it to wax. Any sudden hearing loss is really an emergency, and a thorough knowledge of why a hearing loss happens is very important, and we have to explain it to the patient thoroughly. From point number 1, that is spina, to the point number 4, that's the oval window membrane, any pathology or obstruction in this area results in a conductive hearing loss. Involvement of the cochlea at level 5 results in a cochlear hearing loss, and involvement of the auditory nerve and the pathways beyond that results in a retrocochlear or a neural hearing loss. From tympanic tremors to dancing ossicles, it is straight to the inner ear. That's what we hear. The organ of Corti is located in the scala media, wedged between the scala vestibuli and the scala tympani. It is here that the action takes place. The mechanical energy of the sound waves is converted into the electrical energy at the level of the hair cells, and the shearing of the stectorial membrane initiates the impulses in the first organ neurons of the cochlear nerve. The hair cells scream from decibel to decibel to shoot off signals to the brain. So what is hearing loss? Any impairment in the ability to perceive a sound is called a hearing loss. Basically, there are 3 types: the conductive, sensory neural, or the mixed type. In sensory neural hearing loss, the external ear and the drum are perfectly normal. A basic tuning fork test is mandatory, where AC is better than BC, V-bus is lateralized to the normal ear, and ABC is reduced on the affected side. Pure tone audiometry reveals the typical hearing loss. What are the causes of this sensory neural hearing loss? It can be congenital or acquired. Congenital causes occur at birth due to either pre or perinatal factors. Acquired hearing loss happens due to age, which is the commonest. That's called presbyacusis. Trauma to the inner ear in the form of various temporal bone fractures, infections, noise exposure, Meniere's disease, acoustic neuroma, systemic diseases such as diabetes and multiple sclerosis, and idiopathic causes, or the various causes of sensory neural hearing loss. It's very important to know what is a sudden sensory neural hearing loss. Wilson et al. Described the term sensory neural hearing loss whenever an individual loses 30 decibel or more of hearing in nerve frequency, in 3 contiguous frequencies, at least within a matter of 3 days. Then it is called sudden sensory neural hearing loss. It's an otologic emergency. It can affect one or both the ears, but majority of the time it affects one ear. Here the outer and the middle ears are normal. It is accompanied by tinnitus in 70% of the individuals and vertigo in 40% of the individuals. The condition was first described by D. Clevin. You can see in this audiogram a classical sloping low frequency SN loss. What causes this sudden hearing loss? There could be again cochlear causes, retrocochlear causes, and idiopathic. Coming to the cochlear causes, viral infections play a major role for an individual to lose his hearing. Whenever we think of viral infections, we have to think about Helen Keller, who became both blind and deaf at a tender age of 2 years, and she described that later on that her hearing handicap was much more significant to lead a normal life than her blindness. Unfortunately, our faculty is receiving less importance than the ophthalmologists in the management of various causes of deafness. Coming to the bacterial infections, various causes of CSOM caused by various bacteria, especially the Pseudomonas, Haemophilus influenzae, etc., can cause complications of CSOM leading to labyrinthine fistula, and a sudden deafness can happen. Vascular causes are very important because labyrinthine artery is an end artery. It's a branch of the anterior inferior cerebellar artery, and any affection of this vessel can lead to severe hearing loss. Autoimmune diseases, ototoxicity. Coming to ototoxicity, in earlier era of streptomycin, we used to see many patients who would come with a hearing loss sudden in onset during their streptomycin therapy. Traumatic causes, people are indulging more and more in very scary activities like skydiving, scuba diving, etc. We often see patients after these activities coming with a sudden hearing loss. Meniere's disease, when there is an acute Meniere's crisis, they can have a hearing loss. Certain hematological conditions, metabolic causes, barotrauma, and otosclerosis, cochlear type can cause sudden hearing loss. Coming to the retrocochlear causes, meningitis, multiple sclerosis, tumors such as vestibular schwannoma, meningioma, etc., miscellaneous factors and central causes can cause the hearing loss. Coming to the vascular causes, as I already mentioned, the labyrinthine artery or the internal artery is very susceptible to vasospasm, either due to cold wave or due to thromboembolic phenomena, such as also due to vertebrobasilar insufficiency, and hematological deposits like the leukemic deposits, etc., can block this vessel and cause sudden hearing loss. Following a cardiopulmonary bypass, an individual can develop a sudden hearing loss. Coming to the traumatic causes, a blow to the head during fights, in boxers, etc., fracture of the inner ear due to inner ear concussion, and surgical trauma in a novice surgeon can accidentally touch the lateral semicircular canal, any iatrogenic cause in such as injury to the lateral semicircular canal, or a perilymph gusher during stapes surgery can result in sudden deafness. Coming to sneezing and forceful bending, lifting of heavy weights in weightlifters, etc., they pose a risk of developing a sudden deafness. Exposure to sudden changes in the barometric pressure, such as flying or scuba diving, can result in sudden hearing loss. Noise is really dangerous. When a person is exposed to a loud noise above 140 decibels, such as a blast injury or in minors, etc., they can develop a sudden hearing loss. Here there is rupture of the Reisner's membrane, there is damage to the sensory organ of Carti, the hair cells, and there is mixing of endolymph and perilymph, and the patient can experience a sudden popping in his ear. It can be accompanied by vertigo, and the patient can land up with severe sudden hearing loss. Hypoxia is detrimental to the inner ear hair cells, just as it is dangerous to the brain cells. Hypercapnia is also dangerous. It can cause sudden SNHL. Metabolic causes are frequently encountered. A patient can remain oblivious to the pre-existing conditions such as diabetes, dyslipidemia, and hypertension, chronic renal failure, etc. In Meniere's disease, the hallmark symptoms are oral fullness, tinnitus, fluctuating hearing loss, and severe episodic vertigo. When there is an acute Meniere's crisis, there can be rupture of the Reisner's membrane and mixing of endolymph and perilymph, and diagnosis by all these measures. Vestibular schwannoma is also known as acoustic neuroma, but it generally originates from the inferior vestibular nerve. It's a slow-growing tumor in the internal auditory canal, and once slowly occupies the labyrinthine, once it comes out of the labyrinthine portion of the internal auditory canal, it slowly expands at the level of the CP angle. A gadolinium-enhanced MRI with contrast clinches the diagnosis. What is this idiopathic sudden sensory neural hearing loss? It's a diagnosis by exclusion. Sudden deafness is termed as idiopathic when all the other possible causes are ruled out. How do you approach a patient with a sudden hearing loss? A detailed history is of paramount importance. Take a history of auditory trauma, recent infections, history of systemic diseases, previous ear surgery, and associated other ailment histories of paramount importance. Do a thorough audiological examination, a general examination, otological examination, do a neurological examination, and a vestibular system examination, because you can clinch possibility of an acoustic schwannoma. These are some of the basic investigations that you do: a complete blood count, lipid profile, renal function test, VDRL, because syphilis can cause sudden deafness, blood sugars, thyroid function tests, etc. HRCT of the temporal bone with contrast is very useful when you are suspecting a case of labyrinthine fistula or any other space-occupying lesion. MRI with contrast clinches the diagnosis when there is an acoustic schwannoma. Coming to the hearing tests, pure tone audiometry, CC and BERA tests, impedance audiometry, OAE in children, and BERA, they help in arriving at a correct diagnosis. Various treatment options are advocated in literature. Most cases of the sudden sensory neural hearing loss are idiopathic. Treatment should be tailor-made, and it is based on the patient's condition. Strict bed rest and head end elevation in traumatic cases is useful. Vitamins, vasodilators, corticosteroids, diuretics, hyperbaric oxygen, carbogen, and anti-herpetic medications like acyclovir, they're all described in the literature. However, steroid treatment forms the gold standard in the management of sudden sensory neural hearing loss. Methylprednisolone is given in a dose of 1 milligram per kg body weight, spread over 2 to 3 weeks. Along with that, you can add an intratympanic injection, which is shown to penetrate the inner ear very effectively. Along with the oral or the systemic steroids, you have to give proton pump inhibitors to prevent any gastric side effects. Here I am giving intratympanic injection in my office. Either you can give it through the operating microscope or with the help of an endoscope. You can give a transient local anesthetic injection, or you can fill the ear canal with a local anesthetic cream such as a top lap cream, which when left in place for about 20 minutes gives an excellent local anesthesia. And immediately after that, you can wash the ear and give the transtympanic injection. 0.5 ml, that is 2 mg of dexamethasone is instilled into the middle ear. A controlled puncture is made in the anterosuperior or anteroinferior compartment of the tympanic membrane, and the injection is given in the posterior inferior compartment. Battaglia et al. Has shown that combined intratympanic and oral steroid therapy was far superior to oral steroids alone in terms of word recognition score. What are the advantages of this intratympanic injection? It has no risk of systemic side effects. It has a rapid onset of action and the ease of administration in an office setting. It can be used alone or along with the steroids when the steroids are, oral steroids are contraindicated. It gets absorbed where the action is required. What's the prognosis? Those who receive treatment within first 7 to 14 days show excellent recovery. Patients with profound hearing loss and in advanced age group do not show excellent recovery. So this is my comprehensive approach to a patient. My study based on my experience in the last 3.5 years. To define an ideal, the aim of the study was to define an ideal course of management in an office-based setting. Material and methods were entered into a pro forma sheet, which included patient demographics, contributing factors, clinical findings, pure tone audiograms, serial audiograms on day 3, 5, and 7, and all the blood investigation parameters. MRI scan with contrast was done whenever indicated. And this is how my proforma looks. And at the end of treatment, you have to write a conclusion as to what was the possible cause of a sudden hearing loss and how much audiometric improvement has happened. These were the patient demographics. I saw nearly 30 patients in the last 3.5 years. 18 were male and 12 were females. Only 2 children were there below 18 years of age. 20 to 60 were categorized as adults and above 60 as elderly. Majority of the patients, that is at least 25%, had moderate hearing loss, another 25% had severe hearing loss, 30% had very severe to profound hearing loss, and 5% had profound hearing loss. 40% of the patients also had tinnitus, and 15% had giddiness. So when I looked at these individuals, 65% of my patients had undetected comorbidities, which was picked up during this treatment. They were hypertensives or type 2 diabetics, or they had uncontrolled cholesterol levels, thyroid disorders were picked up, and other cardiac conditions were picked up. Although these conditions are not the standard etiological factors, they can act as contributory factors. 5% were idiopathic, and upon drug exposure, 2 more minutes, no? So upon drug exposure, one of the patients had received antimalarials and had a hearing loss. Recent infections post-viremia, though I didn't do any particular study, there was a spurt in the number of cases during the COVID era, and noise exposure and blast injury. One patient was an Indian Air Force pilot who, after scuba diving, developed a sudden hearing loss along with vertigo, and he was managed very successfully. These were the comparative audiograms. The pre-treatment pure tone threshold was 60.5 decibel, and the post-treatment, the hearing threshold was 21.65 decibel. These are some of the examples of my successfully treated patients' audiograms. The first one was an engineer who traveled from in a very cold country, Germany, to India without wearing any protective device, and on landing in India, he had a severe hearing loss, which was successfully treated. The second audiogram is of a patient who had a parotid tumor, operated 10 years ago. We did an MRI scan to rule out any intracranial or any extension, and he was successfully treated. However, he continued to have some residual loss. And the third patient had a profound hearing loss. He was my neighbor. He was oblivious of the pre-existing conditions, and he was happily sitting at home doing nothing, no exercise, no activities. He had diabetes type 2 and dyslipidemia. Along with the intratympanic injections, all those comorbidities were corrected. He had a complete recovery was noted. These are the audiograms in 3 other individuals. There was a statistically significant difference found between pre and post treatment of the audiograms of the individuals to the tune of 61.2%. Is it possible to prevent sudden deafness? It's not, because we cannot predict who or when a person can develop sudden deafness. However, it's important to lead a healthy lifestyle, avoid exposure to very loud noise, take good care of your general health, and before embarking on very strenuous physical activities like weightlifting, scuba diving, etc., better take proper training and then do it. So to conclude, sudden sensory neural hearing loss is an otologic emergency. 90% of the cases are idiopathic. Early recognition, detailed evaluation, and prompt early treatment are mandatory. Intratympanic injection given in the office-based setting is convenient. Combination of IT injection along with oral steroids gives guaranteed results. It is cost-effective, convenient for the patient, and avoids hospitalization. These are my references. And to conclude, success is not final and failure is not fatal. It's the courage to continue that counts, says Winston Churchill. So this is my son, Suhas, who summited the treacherous mountain, Mount Shasta, recently. It's a vision of immensity. Thank you very much.
One question, ma'am.
Yeah.
Post-COVID, sudden sensory...
Do any specific tests to pick up COVID. They didn't have any symptoms suggestive of COVID. So no specific tests for RT-PCR and all was not done.
And second question.
Yes, ma'am. Hello. Yes, ma'am. Some of the patients, they come back again after say a few months months or a year or so? How do you explain that?
In my series, all successfully treated patients have maintained on that level of hearing. However, in old individuals, if the hearing loss progresses due to presbyacusis, that is altogether a different entity. Okay?
Good afternoon, ma'am.
Yeah.
Ma'am, there are certain patients who are on long-standing aspirin therapy, years altogether.
Aspirin?
Aspirin, long-standing aspirin, clopidogrel, rosuvastatin, these medicines they are taking. And I have seen that these patients, after 10 years of therapy, they do develop presbyacusis. I have seen in many patients, since 15 years I am watching, and in these patients, we can't even stop the aspirin, and NSAIDs, they do cause otologic problem.
They are developing sudden SN loss?
Sudden not, I'm not talking sudden. I am talking about pure sensory hearing loss.
Yeah, that can happen in diabetics because of the neuronal factor.
Diabetes is common.
Aspirin directly is not related to causing any sensory neural hearing loss as
and
far as
those
I know.
who are aspirin from years together.
Aspirin is actually protective, isn't it? It prevents thromboembolic phenomena, it thins the blood.
But
it is actually a protective in nature.
But it causes early onset of presbyacusis.
Early onset, again, it relates to the genetic factors, how they have, what type of genes they have inherited, if there is a strong family history of early SNHL, or if their lifestyle, what nature of job they are doing, if they are exposed to loud noise, and if they are long-standing diabetics, definitely they can develop an early onset sensory neural hearing
What
loss.
is the most commonest cause of sensory neural hearing loss? In all at all ages, the most commonest one.
Age-related presbyacusis.
Diabetics?
Then that comes under comorbidity category. We cannot prove that diabetes only has caused their hearing loss.
Okay.
It will act as a contributory factor.
I've seen that maximum patients who are...
Due to paucity of time, may I request you to carry on the discussion over a cup of tea? Okay, we already have a AOI presidential oration.
Thanks a lot.
I would request...
Is there any role for these vasodilators or ginkgo biloba?
Yes, they can act as add-on therapies. Though steroid is the gold standard, definitely vasodilators, ginkgo biloba, and neurovitamins, they do have a certain role, though it has not been proven in the literature.
May I request the session to be closed because we already have an AOI presidential oration which is started. Okay.
I would like to call Dr. Gajanan sir to please felicitate Dr. P. Lakshmi ma'am. I would like
good afternoon, friends, and a few of you are very much interested in difficult airways. I mean, good afternoon to all of you. I'll be going through few conditions where we encounter difficult airways. This is basically in children that I would be going into today, and most of them, of course, are from Wadia Children's Hospital, where over the last 3 decades we have done more than 10,000 airway cases. And basically, as you're aware, that in the adult and in a child, the conditions are very much different. The tongue is much larger in a child, the neck is very small, the larynx is higher up, and so on. So basically, as an emergency, we do encounter the children who require treatment absolutely in emergency, and these are neonates. The neonates where the nose has not been formed, they lost the child even before we could reach within 15 minutes also. At the same time, if it's a unilateral stenosis, it can be done at a much later time. So even neonates have a problem of acute respiratory issues, and that you see whether it may be agenesis of the pyriform fossa stenosis, it may even occur because of certain syndromes, it may occur and most commonly because of choanal atresia. If it is a bilateral choanal atresia, it's a surgical emergency, and if it's unilateral, we wait for the child to grow up at a later date. So this is, you can find, we put a stent in place. The stent is there for about 6 weeks, and after 6 weeks, the passage is open. Recently, in fact, we had 3 patients of Apert syndrome where there was mid-nasal stenosis, and classically there's hypoplasia of the middle third of the maxilla, and that requires opening and again stenting for 6 weeks as earlier. Again, I mean, this was in December where there was a complete nasal obstruction, and on endoscopic we removed a mass and it came out as a nasal teratoma. So these are acute problems as far as neonates are concerned, and they may present as an acute respiratory distress where this nasal obstruction may feature. Now, in case of obstructions, what you have to be worried about is if the obstruction is in the upper airway. Typically, you find children putting anything into the oral cavity, and you just first put in a laryngoscope and you find things like, pile and all inside. So foreign bodies which are there at the laryngeal inlet are really a task where you rush against time and you have to do it at the earliest. Sorry, I have 1 minute. Then we find children who again come with respiratory issues, very common, you find hemangiomas. So typically when you see the face, you see the parotid, submandibular, you may find an hemangioma. You find a hemangioma even in the oral cavity. Typically, these children have hemangiomas in the respiratory tract also, either on the epiglottis or somewhere in the larynx, and they require to be treated. So as you know, surgically we cannot excise this hemangioma. So what we do, our protocol is giving them bleomycin over 3 months, 6 months, repeating the scopies, and with these injections, they regress in size. Again, this is a child with respiratory distress. We found out it was a thyroid, of course, assuming the normal thyroid is there, and surgical excision, of course, with a diode laser. So you can find thyroid inside. So as I said, we have hemangiomas at different sites, and they all come with respiratory distresses. You can find even in the epiglottis, there's a hemangioma, and these children unfortunately are labeled as laryngomalacia, but they land up with something else, and the treatment is where we use, for these children, we use propranolol basically. So the problem with airway in these children is that even a 1 millimeter reduction in the airway on account of edema, which occurs very fast in these children, the reduction of the airway becomes 70%. So the drastic fall is so fast. So you can imagine why it is an emergency to be treated. And again, the cone, the airway cone is so narrow, and the cricoid is the narrowest part of the whole airway, which causes this obstruction. So small children, even with two-month-old, we find commonly cysts inside, and typically what we do is we use the laser, marsupialize it, de-roof it, and we treat the cysts. Of course, obviously the results are very good for these. Again, this child referred as a laryngomalacia, which is a very overrated condition where we found there's a glottic web over there, and again it was simple, just excising the web with laser. So you find this cystic lesion, so radiological imaging plays a very big part as far as airway is concerned, and a good scan would definitely give us a lot of information as far as this is concerned. Excuse me, you can just keep the phone down. Sorry. So you have these valvular cysts, and this is how the excision is done with laser, where you can see we just make an opening, clear the mucosa, and it's something like a de-roofing or marsupialization of the, this is done, and keep them under observation for 24 hours, and they of course get dramatic results as far as the respiratory distress is concerned. So these are difficult conditions which we find. You can see small cysts above the epiglottis, in the valvula. So again, children coming with acute episodes, again, as I said, if they are at the laryngeal inlet, it becomes a surgical time where you rush against the time, and you find children swallowing anything inside, and just below the cords, you can see this was a piece of cement. I mean, a child moving on the floor, keep taking anything into the mouth, and once it is there at the upper end, it is really an emergency, and you have to basically manage it as fast as possible. Congenital laryngeal stridor, which is basically diagnosed as laryngomalacia, is really an overrated condition. They label it as laryngomalacia because they have not seen inside, but more than half of them turn out to be something else inside as you go. This is again all these children with cardiac problems, you find very common, they have a vocal cord paralysis, and 50% of these cardiac patients, we found them having vocal cord paralysis, typically the left side vocal cord paralysis. This is a very rare condition which we recently saw. Again, the child was intubated, admitted in the ICU for 3-4 times, but then when we did a scopy and took a biopsy, it came as rhabdomyosarcoma. Laryngeal cleft. This is, of course, release of the stenosis. I mean, since we don't have time, I would not dwell into all this. What I want to tell you, the commonest cause of stenosis of the larynx is iatrogenic. Putting in a tube, not visualizing inside, putting a right size tube is wrong. Always put a tube which is smaller in size, which is adequate or enough for ventilation. So you can see the amount of trauma which is inflicted on the larynx by the intensivist or so on. You know, this is how bad you can see the trauma inside. This is a road traffic accident. Then another thing is when children come with respiratory distress, it is important to do a scan. When you do a scan, you can visualize a vascular ring which is compressing on it, and that was Comerel's diverticulum. So if you refer it to a chest physician, they just remove the diverticulum and the child becomes fine. This is typically when we got a child in the nursing home. Totally done in the nursing home, a child came, one of our ENT colleagues had called us, and when we put in the scope inside, we found the larynx totally blocked. Imagine they come at this level. They come with respiratory distress at this level, so immediately a tracheostomy was done. Did a bronchoscopy. The airway was totally clear. And when you see, we did a retrograde bronchoscopy because we could not see it from top. I'll go ahead. 1 minute. You can see the whole subglottis totally closed. So obviously on the same sitting, since we had a CO2 there, with CO2 we cleared up the polyps and removed it. So even with papillomas, they may come at such a stage where there is nothing possible unless we do an acute tracheostomy. So after a week, then the decannulation and a check scopy was done. So whenever they come with even stenosis, post-intubation, what we do is now we do balloon dilatation, laser excision, and this is the way out to it. I think, yeah. With a luminous or with a diode laser, we make a cut, and then we use a balloon dilatation to basically dilate the opening and then put in the bronchoscope to see that the dilatation is adequate or not. If it is too severe, we go in for an external approach where we put in the costal cartilage graft to open up. So another reason is we, for bronchoscopies, which I just wanted to show you, is we do tracheoesophageal repairs, endoscopic, for small ones, of course, where we do a bronchoscopy, identify the fistula on the left side posterior wall of the bronchus, then use a catheter, which is the urethral 4-number catheter French, and introduce tissue glue or tissue seal, and we close fistula. So endoscopic closure of tracheophageal fistulas, it avoids doing a thoracotomy or a major surgery for these children. This is, of course, our paper. So what I want to tell you is many of them come with foreign bodies which you cannot think of. I mean, this was a child again in Vatia where he was in the ICU for 1 week. It was not 1 minute. No, the lung was not opening up, complete consolidation, and we found pieces. I did not know what this piece is. So we sent it for examination, and we came to know this was chicken. I mean, pieces of chicken. He went to McDonald's, had a burger, had a very nice, sumptuous meal, and landed up with all this. So, you find anything around inside. Always ask for double x-rays, because what happens that in a foreign body, there is no history. The child is smarter than the parents, smarter than the caretakers. So there is always no history. The signs keep on changing. Initially, if you see the child will present or is labeled by the pediatricians as acute tracheobronchitis. After a week, he's labeled as pneumonia. After a month, he's labeled as asthma. After 3 months, he's labeled as tuberculosis. And after 6 months or 1 year, he's labeled as MDR. We have a lot of children who have been on MDR, multiple drug treatment, not responding, done a bronchoscopy after 1 year, 2 years, and found foreign bodies inside. So very nicely, diseases can be made at different stages, and unfortunately, the doctors also keep on changing. So with all this, what happens that it becomes very difficult. This is one of our, of course, big hospitals where I want to just insist that, of course, adult patient, she was an air hostess having respiratory issues. They did a bronchoscopy, found that there was something inside. It was a tablet, basically Gelusil tablet. But even after doing a good flexible bronchoscopy, you require a rigid bronchoscopy to remove it. So ultimately, rigid bronchoscopy is the thing. How much ever flexible we do, rigid bronchoscopy should be done to clear up all these conditions. So anything may be on an X-ray, you may find anything under the sun. Now these are the children who are taken for just lavage, and after taking them for lavage, the pediatrician wanted lavage to be taken, for antibiotics and all, and I found in a seed inside. So what happens that never go with the idea that I'm going down to do a lavage, I'm going down to do this, you may find anything inside. And other thing is you have to have a good anesthetist for this. We have encountered situations, I have got it twice, where my heart stopped because the saturation became 0. But the anesthetist told me, you continue, there is no Brady, you can still continue and remove the foreign body. So saturation from 0 has come down to 100 within 60 seconds. It is something like a Ferrari. So within 0 to 100, it comes up so fast at the same speed at which it goes down. So again, this was in Bhatia where, the children on AKT, chest physician treating on AKT, the lung not opening up, again taken for a gene expert. You do the test and we found a foreign body inside. So this is very commonly that happens. Again, 1 year old, not improving, and finally found a screw inside. And these foreign bodies just tell us that anything under the sun causes this, as well as at the same time, you may find all types of foreign bodies inside. We have got things like even pieces of the beer cap also inside, or pieces of teeth inside, and also on. In the last 6 months, we had 4 pins, scarf pins, and with these young adolescent girls put scarves, and these pins were there inside. So 4 of them we have done in the last 6 months. So you find anything, you could not remove it, so remove it piece by piece. The head of the pin, then the pin has broken through the trachea, so you can see the scarf pin inside. You find button cells and all, of course, which leak inside. You find bulbs inside. The children play with toys and these bulbs of different colors are inside. These are telescopic bronchoscopies where we find these tablets, of elderly people. They're taking tablets and the tablets are there inside the lung. So infant who has been intubated for 4 days in one of the tertiary hospitals, but turned out to be a foreign body inside. This was in Sion Hospital. You may find double foreign bodies. Now this is a bronchoscopy where we failed. We could not rigid and flexible bronchoscopies in Mumbai. Thank you for your attention. Not responding to antibiotics for more than a week, we do a bronchoscopy. Bronchoscopy is like an investigation. It is such a safe procedure. I'm telling you, like over 10,000 bronchoscopies done, there has been no issue, no problem. Now, for all of them, I do a rigid, but forget infant, forget newborn, preterm, 900 grams preterm children, also who the lung is not expanding, amniotic fluid aspiration, I do a rigid bronchoscopy, I pass a 2.5 mm scope for them. So rigid bronchoscopy does not damage even a newborn or a preterm. You can do it comfortably. The trachea is so strong that it is very difficult to tear the trachea. You require 2 hands and to push it through.
And under local
No.
nebulization,
Not. All these copies are done with spontaneous anesthesia. Yeah, it is on spontaneous anesthesia, and ventilating bronchoscope is used. It is very safe, but main complication in bronchoscopy is that the time period should be limited. Never do a bronchoscopy. Normally it takes 2 minutes, but more than 5 minutes, abandon the procedure, do it after a week. I told you, after a week, granulation cleared. Again after a week, still the granulation clears. Do it 2 times, 3 times. It is very safe. But when you do inside and struggle, the complications will start. So never to have a heroic decision, I am going to remove it. I will try.
Bleomycin is directly injected into the site?
Yes, directly injected into the sites.
So how often you may have to do it?
You may have to do it 2-3 sittings and the whole thing shrinks, because the cystics and all you cannot operate because they will call nerve paralysis, and even these hemangiomas we give propranolol for them, and so it shrinks. But for them we have to give it for over 3 to 6 months. It does not shrink immediately.
What is the dose of propranolol?
I do it as point. Yeah, I'll tell you. It is, we send it to the pediatrician, they give it, but it is 0.1 milligram per kg body weight. And then they have to remove the ECG, do the 2D, and they monitor the cardiac part, basically. That is what they do, but it is not done by us. Since you asked me, it is done by the pediatricians.
The ventricular cysts you were saying, is it that after marsupialization it will come back again?
No, it doesn't come back. Yeah, it doesn't come back because I think in the last year or so we have done 30, 2 years. I mean, they don't come back. We do check scopies, but it clears up. It doesn't recur. They are very benign, but thing is, you have to remove because they have respiratory issues, basically. And it keeps on growing otherwise. Sorry. Oh?
So suppose all the difficult airways you treated for children, how much would be approximate percentage of ventricular cysts?
See, ours is a tertiary referral center. So probably we get all those so-called laryngomalacias which don't respond, they come to us. So it may not give you the exact picture of all that, but amongst them the commonest will be valvular cysts.
And marsupialization
Is the key. And laser life becomes very comfortable. You can just open it up with laser, clear the roof, and we scrape the mucosa and leave it alone.
diode or CO2?
No, diode. I use diode. Yeah.
What about coabulator, sir?
I don't know. We have coabulator, but we don't use it for, because what happens in pediatrics, that VAD you may probably damage more. So laser is more specific. Yeah.
Yes, sir.
Thank you, sir.
Thank
Very
you,
nice
Sanjay.
presentation, sir. We have seen a few cases first time.
I would like to request Dr. Hitesh Patel, sir, to please felicitate Dr. Divya Prabhat, sir.
Sir is our teacher. We have read sir's book in UG, sir.
Thank you. Nice.
Do we have Dr. Om Prakash, sir, here with us? Do we have Dr. Ashraful Islam, sir, here with us?
Thank you.
Good afternoon, everyone. So it's a post-lunch session. So we're going to start. This is a complete new topic. So we are going to focus today on management of vascular complications in skull-base surgery, exploring new horizons with indocyanine green and the other things. So we have allotted only 15 minutes, and let me try my best to just have some idea about this new technology and how we have evolved and how we are doing in this next generation. So this is our hospital, Sam Ultimate Medicare. This is in Bhubaneswar. After shifting from Delhi, so I have been relocated here. And so coming to the vascular complications, the major hindrance, that is like skull-base surgery has evolved over several past decades with shift towards endoscopic surgery. Endoscopic nasal approaches in the recent decades have allowed for shorter hospital stay, decreased major complications and decreased mortality. And that was before like almost 50% mortality, it's reduced to now 5 to 10%. So it is always like that, if you are doing a skull-base surgery, the complication may come like this, but you should be prepared to handle that. So who is the main culprit? The main culprit is your carotid artery. That is the main artery which travels from your lateral skull base, comes to enter skull base and the entire brain. So with this, what happens? We took a lot of training and we do a lot of hard work just to save ourselves and how to prevent that carotid injury or anything like that if happens, then what to do.
So this is a three-dimensional view of the carotid artery. You can see here and how this artery travels in the petrous part of the carotid and moves towards your basically paracellular and cellular area. So these are all anatomical views just to orient you all. Now coming to the main slide, that is we all know this is functional endoscopic sinus surgery and another is your functional neurosurgery. But this concept is completely new, that is called functional skull-base surgery. So how we are evolved and how we are going to do that, that is like in routine cadaveric dissection we do a lot of cadaver and just to orient ourselves, but end of the day what it matters is your exposure. How much you do exposure in skull-base surgery that prevents further injury. So vascular complications are potential the most serious complications following skull-base surgery. The critical injury is your ICA, which usually happens during sphenoid sinus opening or specifically during tumor resection. Many times in our practice we have seen the artery is exposed and you can see it's like 71% of the carotid artery bulges into the sphenoid sinus as per the Rotten. And many times the artery was not covered with the bone properly. You can see this is one of our video where you can see the pulsation in the sphenoid sinus directly. This is the SCR, I can see that. Optic nerve is here and this is your carotid bulge. And in that carotid bulge, you can see the bone is like extremely thin, less than 1 mm, or maybe bone is not there. So there is a visible pulsation of the artery, you can see that. So these are the things, how to prevent and how to start all this practice. So you can see here, you can see this is a curved tube carotid Doppler you are using. This is the instrument which actually maps your carotid and it prevents the further injury in certain situation. So how to do that? Suppose this is a big tumor in your view, and you have no idea where is the carotid. Previously, what we are using is we are using the carotid Doppler, and that Doppler helps us to map the carotid. Now coming to your coming to the other scenarios, like most common causes of bleeding in our routine practice, what we see, this is like your anterior ethmoidal artery injury, which any basic surgeon, ENT surgeon should well versed with it. But if you encounter any vascular injury in your practice, you first have to keep some patience. Just don't rush your adrenaline or just jump into like it cannot be possible. But everything is possible with proper gadgets and proper handling. So even anterior ethmoidal artery bleeding takes only 30 seconds or 40 seconds to control. So it should be proper vision. It should be under your control and under your vision. Now many cases we found like your routine practice angiopharma, everybody does it, but many times the big gadgets like we're using your coagulation and all that, and coagulation sometimes create injury to these vessels in the surface level. But you can see this is a IMAX injury, but it is behaving like a carotid injury, and the bleeding rate is so fast. Within 30 or within a second, it fills up your entire maxillary sinus. So these are the things you may encounter anytime. I always say to my residents and all that, you should operate that case where you can create complication, but you should know how to manage that complication. If you don't know how to manage the complication, then things will be difficult. You don't operate that case. So the all training is not about learn what to do. It's more about to learn how to manage if you have done something wrong. So coming to the other part, now you can see it's a cavernous sinus bleeding, and in angiopharma surgery it bleeds like anything. So what we are doing here, again we are using this bipolar cautery in a controlled manner, and even you can use over the carotid artery and the cavernous sinus if you have a control hand and you have that patience to just fire. So after a small fire of this cautery, you have to just pour water and put some suggestion and all that. It goes like a magic. So these are the things. And many times what happens, there are some fibro-osseous tumors, and these tumors, as per the literature, this is the highest chance of carotid injury. So you can see the tumor is completely engulfing your carotid artery, and somehow it is not acceptable. You are not going to operate, but yes, you are going to operate. So what we will face? You can see what are the principle when we operate these cases. You can see this tumor is like a rubber. It is just hugging your artery, and you have no idea where the artery is. So we are using the true cut instrument. This is called seal cut, and we are cutting the tumor in pieces and looking at keeping the artery in the center. So these are the technology we used before, and you can see here. And this is your internal carotid artery in front of you, and the tumor is taken, and this is your median artery. So these are the difficult cases. Again, coming to a case where it is engulfing the entire clivus and your petrous apex and all that, and you can see the vascularity, how bad it is looking. And in a skull base, these cases are like you should not operate. But yes, with a proper gadget, we can operate it. And this case came out to be a metastatic tumor from the thyroid malignancy to clivus. And you don't believe us, within 10 minutes of surgery, it bled like 1.5 liter. But we cannot come out suddenly. So we have to at least do our job. And there are many things, sealants like fibroflocil and all that. You can use that, but you have to do your job. You cannot take a U-turn from a surgery. Now coming to what's new. After doing all these exercises, what we can see, there is a new technology called indocyanine green that was popularly given by the Castros people. And you can see here, in routine practice, we do this pituitary surgery, and many times we have no idea your heart flap will work or not. In this technology, we are just putting one dye into your vein, and that dye will go to that area, and it will enhance that part, and you have some idea whether your flap or whether your tissue is viable or not. To starting with our cases, how we have evolved. That was before, so we are doing in a routine way this skull base surgery. That this is a new phase. It is a revision case of pituitary macroadenoma. You can see the previous neurosurgeon has taken everything and also put a Hadar flap, and the tumor was as it is as before. Now the patient presented with severe headache and all this problem. So how to do it? See, in our routine pituitary surgery, we remove the basically sphenoid sinus mucosa, but neurosurgeons usually just avoid, they don't do all that in a routinely. So in this patient, even the patient developed mucocele around the tumor also. So you can see in this video, so when we are just exposing all this part, so we have seen a mucocele also there. So these are the hindrance of the surgery. When you operate a revision case, that's like a big problem for the patient and the surgeon too. So coming to the tumor, you can see we have exposed it. So what is new with this? After doing the exposure in a revision case, what we have done? So we have injected the dye. Now the dye has gone to your that area, and the blood will look your like green color here. And you can see the tumor here. The tumor was tumor is not taking that much enhancement. So tumor is looking little grayish, but the structures which are more enhanced, it is looking green. So this is a new technology. The carotid will say, I am carotid, don't touch me. The normal pituitary will say, okay, I am normal pituitary, don't touch me. So in that way, you can prevent a lot of collateral damage. What I say, ki functional skull base surgery. So this is the thing where we can imbibe or we can generate something called functional skull base surgery. So you can see the tumor is taken out. These are few new things I want to show. This is something called monochromatic or X-ray mode. Here, even in the depth, if there is vessel is there inside the tumor, even you can see that. I will show you in a coming video. And there is another mode which is basically intensity modifier mode. The intensity of this enhancement will increase. So coming to the next video, you can see in this video you can realize. See, this is the normal pituitary gland here. And this is the carotid artery. Even the carotid artery says, okay, I am carotid. So you don't have to be so much like in a revision case. There is no landmark, and just I have selected the revision case, not a routine case, to just orient okay, how it is helpful. The technology is definitely going to change in future days of our skull base surgery. So you don't have to suffer from DI. You don't have to injure your carotid, and in that way you can see the carotid, and the color is completely green here. So this is the way we handle, and this is the way we handle our tissue. And you can see these are the both side you can see both these carotids, and this is the normal pituitary gland there. And then coming to the another case, it's a case of Rathke's cleft cyst, and you can see here how we handle. So this is the routine drilling and all that we do in routine all our cases. We have just exposed this your tumor here, and we are cutting the dura, which our special dural knife from the Karl Stoss, and we are just exposing this normal pituitary gland here. But in this case, we have to pierce the normal pituitary gland with a scissor, but you have to do in a controlled way, because the main goal is to do the functional skull-base surgery. Functional skull-base surgery means we want to preserve, we want to make the patient morbid free. So this is something complete new concept how we are doing it here. After removal of the cystic contents from this ear, from your Rathke's cleft cyst, so we are using this your Indocyanine green mode, and in that way the normal pituitary gland takes a lot of enhancement, because pituitary is a highly vascular organ, and it takes a extreme high level of enhancement. So this looks something completely different, and definitely this is a landmark in our skull-base surgery in coming days. So coming to the other things, again I will show you. So in this case you can see here, so the vessels and the nerve, you can see the brainstem here. This can be completely different. You can see here the vessels and your sixth cranial nerve, and they are taking a different color. Even you can see in the depth. So this is the way, and this is your monochromatic, like it look like X-ray. So in the depth of the tumor, you can identify your vessels. So this is the new technology which can change the complete scenario. Now coming to common sources of bleeding, what we know exactly, your arterial or venous bleed, and the routine practice. We use all these common structures, like I have already shown in these videos. And coming to your most common thing we face during our carotid transposition or anything like that, there is carotid spasm. That can be also prevented by manipulation, stop manipulation and putting papaverine and all that, and proper hydration, maintain BP and all that. So carotid injury is one of the most devastating complications. So I will show you one video, and this is a complete new thing we have faced first time. You can see this is a case of carotid aneurysm, and the neurosurgeon has put the coils inside, and the coil came out to your sphenoid sinus. And this is completely out of the world and completely different thing, not shown everywhere before. And this is coming in one of our book also. It will be published in coming February. And you can see this is look like some matrix and all that. And this is extremely scary. This is the carotid aneurysm, and the coils are coming out, and patient presented us with bleeding, carotid artery rupture bleeding. So how we have handled it? So what we have done it, see, the things are like that. We cannot cut the coils. We cannot manipulate here. So what we can do is we can bypass the structure from the nose. So what we have done here, so we have taken glue. The glue was first kept over these coils, just to create coagulation or exchanging factor, just to orient that. So glue was kept here. So I'll take 2 more minutes because the other speakers are not there. So the glue was kept over this complex, you can see, and after that muscle patches are taken from the quadriceps area, because routinely when we see a carotid bleed, at that time they don't give us luxury. It is a different type of carotid bleed patient presented to us, but again it is not reported till now in any literature. So we are coming with a publication and a book both on this vascular injuries. So muscle was taken from your quadriceps muscle from the thigh, and it was taken from there, and it is kept just around that structure. You can see gradually we are just covering it. Gradually we are covering it, and multiple muscles are just kept there. And believe us, there is no luxury in this case. If you just disclose anything like your coil or anything, if it ruptures on spot, then even you can lose the patient on table, because there is no science describing how to handle all this, because these are something new. And in our center we have our all interventional radiologist and interventional neurosurgeon. We have our endoscopic suite and everything we have. But these are the few cases, despite of having everything with you, that shake your head how to handle. So again, we are putting glue over that, and gradually we are sealing it. It's not the end, and gradually more and more muscle patches are given over that, and after finally we are putting fat over that. And after that, what we are doing, we are just bypassing it from the nose. How we will do that? The best way to do that is, so we are just, we have preserved your middle turbinate and all that. We are creating some incisions in the septum and your turbinate to create a adhesion there, and a suture was kept between between your middle turbinate, all that. You can see that here. So suture was placed, and these are the surgery cells, and just to anchor it. So this is the way this case was handled, and this is extremely difficult, I think, and this is the view. Finally, I want to show, and this is your like your ICG view. We can see here, and these are the coils. It's coming out. So with this, I'll just wind up my talk. The main motto was here to just to orient you how we have evolved and what are the new things had come up, and in this way we are just able to focus to create the era of functional skull-base surgery. Usually it was always there that for skull-base surgery is a destructive process. We destroy the nose, we destroyed everything, but the era is changing again. So it's like functional endoscopic sinus surgery or functional brain surgery. So where with the concept of functional skull-base surgery. So I'm just ending my talk here. And in our center, we used to place a lot of patients throughout the world travel to us for these cases. And I just want to conclude. For any questions, please, you can ask. No, this is the pre-op. Post-op I have shown now. We have just sealed it, and your... No. The patient was followed like almost like 8 months now. The patient nose is completely bypassed from your sphenoid sinus, and this muscle and glue has just taken up in the graft, like a graft, and the patient is survived, like 23-year-old man, and he has no episodes. The last, if again something happens, the only thing is we have to just clip the carotid artery completely. But again, that is like it may lead to hemiparesis or something like that. Or even you cannot do a balloon occlusion test in these cases. If you do a balloon occlusion test, then it can rupture the aneurysm at that spot because your artery is also open with these coils. So, sir, any more questions? Thank you, sir. Yes, sir. Huh? Yes, sir. See, we are using a indocyanine green dye. I will just because there is no talks now. So, we have talk. Okay. Just closing. So we are putting one indocyanine green dye there. So you can see the dye is moving from the vein to your arterial system and venous system, and it will go there and it will stay there, but it will not stay there for long duration. So it should be fast. It will wash out again. So you have to put it in the climax. You cannot put it completely throughout the surgery. So it is like your navigation, and it will create a new generation. Like tomorrow we have a talk on thyroid also. In thyroid surgery also we are using. So it will differentiate nerve from the artery, so that many times we use nerve monitor. In coming days, we don't have to use it if you use this technology in a proper way. So again, this science is evolving. We'll come up with papers and all that. So I think, conclude my talk. Okay, thank you.
Thank you, sir.
Yes, sir. Next speaker is Dr. Manjunath sir, who will be presenting on ulcerative laryngitis.
Idiopathic ulcerative laryngitis, it's an uncommon disease. In fact, despite being a laryngologist, I was not aware of this condition just a couple of years back. And then of late, I'm doing research on this. So I'll be presenting this. It's uncommon disease. So you see a white patch here, and you see white patch on both sides. So And this is a leukoplakic lesion, whereas this is not a leukoplakic lesion. I mean, whatever white thing you're seeing is some of it is saliva and some of it is because of the ulceration. You can see the ulceration here. And you should be biopsying this one, the first one, this one, and you shouldn't be biopsying the second lesion, because this is a altogether different disease. This is known as idiopathic ulcerative laryngitis, the details of which we'll be seeing now. So, in the beginning of 2000, Raquel and Spiegel, in fact, published this paper. And they say, since the beginning of 1991, the senior authors, Suttlehoff, have recognized a clinical syndrome defined by prolonged hoarseness, laryngeal inflammation, and vocal cord ulceration. Patients are frequently young, non-smokers, non-drinkers, and who had an upper respiratory tract infection prior to or associated with the onset of laryngeal symptomatology. Patients may be affected for up to 1 year despite aggressive medical therapy. This was the thing they published in their landmark paper in 2000. And then from prolonged ulcerative laryngitis, the terminology was changed to idiopathic ulcerative laryngitis, and now this is the commonly used term. And it's an uncommon disease that's characterized by hoarseness, preceding upper respiratory tract infection, and with cough, and mid-membranous ulceration of the vocal cords. Demographics, Simpson et al. And all the other Western papers showed a strong middle-aged female preponderance in their multicentric studies. But the latest studies, including our own, refutes this. And in our experience, I mean, we have seen more of a male predominance than female. And so since it was a female predominance, earlier it was also thought it could be because of autoimmune disease, but now the theory has also been refuted. Prevalence, it's uncommon but not rare. It's rarely diagnosed rather than it is rare occurrence. There are very few research articles published on this. In fact, less than 10 research articles, including German and Spanish papers, and none from the Indian subcontinent so far. There was a study by Kim et al. From Michael John's group, and they in fact interviewed more than 100 laryngologists, academic laryngologists, to know to know if all the laryngologists are familiar with this and what is the prevalence of this. So, I mean, more than 20% of them responded with saying more than 20 of these cases in their lifetime. Etiology, it's basically unknown. It could be vocal abuse. I mean, that was one of the causative factors that was earlier thought of because of almost exclusive involvement as in nodules. But however, only 35% in our series gave history of vocal abuse. A small number of patients were also cultured for bacterial, viral, and fungal etiologies in Raquel series, but causative organism was not found in any of this. Although we presume the causative organism to be fungal, since first two patients had been using steroid inhalers for their cough and were treated with antifungals, the later patients showed similar response without antifungals, thereby refuting any fungal etiology. The best way to establish an infective etiology would be to perform a PCR for the suspected viral DNA by means of tissue biopsy. But again, this would mean tissue biopsy, which is not recommended in this disease, since it involves the mid-membranous vocal cord region. Cough seems to be the commonest denominator in all these cases, and now it is one of the criteria for the diagnosis. But however, this being the cause of this ulcer is questionable, because coughing is closely associated with post-vocal fold trauma, leading to ulceration and granulation of the vocal process and not over the mid-membranous region. Similarly, laryngopharyngeal reflex is also associated with post-glottic lesions than in the mid-membrane region and cannot be considered as an etiological factor. So, examination finding, these are the stroboscopic videos. This, when the patient presents to you in the course, like probably in the first or second week, you see complete hyperemia of the vocal cords, just like this, just like any other acute laryngitis case. And then when you see in the second or third week, they usually present with mucositis-like features prior to ulceration. So you can see whitish patch over the vocal cords. This is the second stage. And then the membrane breaks down, leading to ulceration. And then this is the complete ulceration seen later in the course of the disease and before the healing start. And one thing you should notice is you can see a good mucosal waves here, unlike a leukoplakia where the mucosal waves will be absent or reduced. Here the mucosal waves are present, but definitely the amplitude is reduced. And this is on eye scan technology from Pentax. You can see diminished vascularity, the midmembranous region. And then this is after treatment, there is complete resolution of the ulcers. And should we biopsy? Current literature suggests that these lesions should not be biopsied because this can lead to scar formation and a non-pliable vocal fold. And the Raquel series, which had 2 biopsies, showed an inflammatory reaction with no cellular atypia. And we biopsied one case because the patient was a smoker and there was, he was more than us, he was little skeptical, if it was a malignancy, so he was not ready to wait, so we had to biopsy based on his this thing. And then showed similar findings with no evidence of leukoplakia or malignancy. But if there is a strong suspicion of malignancy, or if the ulcers fail to heal, or if it progresses during treatment, or if the ulcer is unilateral, then we should biopsy. The biopsies can be done in the outpatient department. This is not an ulcerative laryngitis, this is just a leukoplakia, just to break the monotony of ulcerative laryngitis and show how it can be biopsied in the outpatient department. So the anesthesia is by laryngeal gargle technique, and then we're using the forceps passed through the instrument channel. We can biopsy. We can do excision biopsy, in fact, but make sure that you are not crossing across the superficial lamina propria. As long as you're superficial to the SLP layer, there will be less scarring and the vocal outcomes are good. There will be some amount of bleeding, couple of drops of blood trickling down the tracheobronchial tree is not a concern because as long as your airway is concerned, an awake patient is always your best friend because they can cough up whatever secretion, whatever blood they aspirate. So how do we come at a diagnosis? So this is the diagnostic criteria that has been put up now. So there is a preceding upper respiratory tract infection with cough, bilateral mid-membranous ulcerative lesions of the vocal cords, prolonged course of ulcer resolution more than 6 weeks, and lack of response to pharmacological management, no acute resolution with PPIs, corticosteroids, antibiotics, or antifungals. So this is the criteria for diagnosis that has been accepted in recent papers. So coming to the treatment, going back to KIM series led by Michael Johns, most people, advocated complete voice rest, oral steroids, behavioral cough suppression, modified voice rest, and so on. So these are the commonest. The voice rest, steroids, and PPIs were the commonest mode of management. Reeds et al. This is in fact a German paper. They had 12 patients in their series. They used an inhalation mixture containing panthenol, saline, with steroid added in the first week. And this inhalation was done for 4 to 6 weeks. In our experience, we treated around 20 patients in the last 6 years, of which 15 were males and 5 were females. Age ranged from 22 to 69 years. And we used PPI in all patients with limited vocal use for 3 to 6 weeks Two of our patients were treated with antifungal since the diagnosis was uncertain. I mean, this was early in the course of the series, and they were using steroid inhalers for cough. So that was the reason we thought it was a fungal laryngitis and treated accordingly. This is the summary of treatment advocated by others. Raquel, oral steroids, antibiotics, PPIs, voice rest, voice therapy, biopsy, and the time taken to heal was almost a year. SIO, observation, there was no specific therapy. Even then, most patients healed well with average time to heal being 9.4 weeks. Simpson, antifungals was used in 14 patients. PPIs in 13 patients, steroids 4, and antibiotics in 2 cases. And time to heal was around 2 to 10 months. Young et al., they have the largest series, about 23 cases. PPI was used in 85%, antibiotics in 22, steroids 52, antivirals 52, antimycotics 39, voice rest 65. And it was around 2.5 months. Reeds et al., like I said, panthenol in our series, it's PPIs for 6 weeks and limited voice use for 3 to 4 weeks. So you can see most of the papers show that the average time to heal is around 2 months, 8 to 9 weeks roughly. So, I mean, you need a lot of patience, both from the treating surgeon as well as from the patient, because these ulcers won't go off within 5 days or 1 week, as you see in acute laryngitis. Long-term sequelae, Kim series showed, dysphonia, vocal cord stiffness, vocal cord epithelial lesions, and subepithelial lesions to be the commonest long-term sequelae. And in their series, it was almost like around 80-85%. Final laryngovidostropes revealed no long ulcers in 78%, but 65% had persistently decreased mucosal waves. This was in Young series, which has the largest series. Multiple regression analysis revealed that younger age, shorter symptom duration, and anti-reflex treatment were significant predictors of decrease in VHI-10. Simpson reported vibratory abnormalities after complete resolution of ulcers in as many as 60%. Sinclair also described a granuloma developing over the healed ulcer but saw full resolution with conservative management. We did not see any permanent sequelae in any of our patients except one patient who had undergone biopsy. This patient continued to have difficulty in singing, but he doesn't have any problems with his speaking voice. Only his singing voice is affected, and on stroboscopy we saw there is a decrease in mucosal waves. All others showed full resolution of ulcers and symptom, as well as symptomatically without any long-term sequelae. So take-home message, IUL is diagnosed by dysphonia, preceding cough, and a finding of mucosal ulceration in the mid-membranous lesion, mid-membranous vocal cords. Biopsy is not indicated. Healing takes longer duration and needs patience both on the part of the surgeon and the patient, and resist all temptations to biopsy these lesions. Thank you for your attention.
Any questions?
Dr. Manjunath.
Abuse. They gave history of vocal abuse. Others, no. 65% of our patients did not give any history of vocal abuse. And questioning about their lifestyle also made me think that there's no vocal abuse.
Did you try voice therapy?
Voice therapy was not advocated, only voice rest.
Okay, because it is in the mid-membranous area. This is where the maximum trauma happens.
Yes, sir.
So I think there is a very good chance that it can be because of voice abuse, because it's happening on bilateral thing.
Yeah,
because the whole family of, we see that there are a lot of lesions which happen in the mid-membranous. Voice abuse is an important cause. And so it was just, because nodules, cyst, pseudocyst, mucosal swellings, all of these now, a literature is there that with voice therapy they heal.
Yeah, like I said, this was considered as the etiological factors in the commonest denominator in all these lesions was preceding cough. Like in our paper also, I mean, only 35% gave history of vocal abuse. The rest 65% did not have any history of vocal abuse at all.
Because, I mean, it's just okay, I mean, thing. So improper use, again, it's not a question of how long you use.
Yeah.
Even improper use of less time also can cause.
Yeah, that can cause, but obviously, I mean, but there is no occupational or any other predisposing factor.
Thank you. Thank you.
Thanks.
Manjunath, one question. See, have you injected steroids in any of them or Botox? Because see, if you are having a posterior glottic ulcer, you sometimes give rest to the cord by injecting Botox. Okay?
Yes.
Have you injected any of this? Is there any literature to support the use of these things intracaudally?
As far as I mean, the literature is concerned, there is no literature supporting the injection of steroid. Most of them, some few papers have given oral steroids, but none of them have tried Botox. But I mean, like you said, Botox could be because it gives forced voice rest, so that probably can be tried in patients who are not compliant. I mean, it's a good suggestion that I will take.
So if you are going to give Botox for voice rest, so it's assumed it is due to voice abuse. That is the thing.
Yeah, I mean, it may not be the cause, but voice rest definitely gives time for the ulcers to heal. It may not be the cause. The cause could be, I mean, we don't know, but definitely since it is in the mid-membranous region, it is definitely prudent enough to give voice rest.
This opportunity to present my work. I am going to present on cochlear implant made easy by Bhopal technique. As you know that cochlear implant started as a posterior tympanotomy technique. Then subsequently people search for some other technique because they face some problems, especially the difficulty in localizing the target area, or sometimes there is a fear to injury to the facial nerve. That is why all over the world people sought for some other technique, and people have tried transcanal technique in different ways, and ultimately the technique which got popularity is the Varia technique. But when the Varia technique was become very popular, there are certain objections raised to the Varia. I have tried to alleviate those objections as well as to remove the difficulty of the posterior tympanotomy. I devised new technique which is a modified Varia technique and which is known as Bhopal technique, by which we are getting good results and it is easy to perform. So I will share my experience with you. So this is, you all know, this is Graham Clark, who is the father of multi-channel cochlear implant, and he was there in Australia where the posterior tympanotomy technique has evolved. And this is the Professor Kirajidis Trifon, who has developed the Varia technique. He belongs to the place Varia, which is in Greece. So this is the video I have taken from Dr. Ravi Ramalingam, to whom I find that he is doing the posterior tympanotomy in a very elegant way. And what he does, as you can see in this video, that you can see the short process of the incus, and from the short process of incus he is using dental burr to make the facial recess, starting of the facial recess, because this is the widest area from where you are not going to injure the facial nerve, and you can make the facial recess and extend inferiorly to make the full-blown facial recess approach. Problem faced, visualization of the target area sometimes difficult for the novice surgeon. Who are experienced, definitely they can do in any case. And fear of the facial nerve injury, which is less than 2%, but still when novice surgeon do the cochlear implant and they go to the recovery room, they can see the facial paralysis is there. When the rotating burr has eroded the facial nerve, they cannot realize sometimes. And with cochlear rotation is there, then sometimes you have to break the posterior canal wall to see the target area. These are the problem faced in posterior tympanotomy. That is why people have sought to the other technique, and because of the non-visualization of the target area, you can see the electrode array has went into the nasopharynx, into the carotid canal, into the internal artery canal, and into the vestibule where it should not go. I am not telling that everybody does it, but it has happened with posterior tympanotomy. That is why people tried for the other technique. So this is the Varia technique, which you can see. It is basically a transcanal technique, and which is the most popular technique now, other than the posterior tympanotomy. And in India, more than 20,000 implants are being done with this technique, and this technique has proved with the time that it is a very reliable technique and giving good results. And this you can see in this video that very simply canal incision is given from 12 o'clock to 6 o'clock. Now the incision is taken up to the incisura terminalis, and oral incision is being given. This incision is being joined. Then subsequently plane is created above the temporalis fascia. Then you can see the bone is exposed and periosteum is elevated. And then now 4 suture technique are there, by which we are not using now any retractors. Tympanomeatal flap is raised. Canal is straightened, because the special instrument is called perforator, which is being used here. You can see they are making the suprameatal well. It's a shallow well because they don't want to disturb the mastoid air cell system. The idea is that, the advocation is that you should not disturb the nascent mastoid air cell system, though our posterior tympanotomy colleagues are doing it regularly and getting good results out of it. Now after bony work, we are entering into the middle ear. And you see, after entering into the middle ear, very panoramic view of the middle ear, we can see the round window niche very clearly. And even in rotated cochlea, you can find out where we have to do the things. Now we are doing the cochleostomy after making the transcanal tunnel and fixing the implant. This is the implant, which is a Neurolec implant, which was available through EDIP at that time. And after putting the ground electrode, we can guide through the transcanal tunnel into the cochlea very easily. So all the steps which are involved are very simple steps which every otologist is doing every day. But the main objection, you see, the implant is gone there very easily, and the access electrode is accommodated into the suprameatal valve, because this is a relatively short access electrode of Neurolec, so it can be very easily accommodated in this space, which is a very shallow space. We have not entered into the mastoid antrum even. After that, we will deposit the tympanomeatal flap, put the gel form there, dry gel form, so that it can swell up and keep the tympanomeatal flap in place. And after that, we will suture this wound into 3 layers. That is all in the Varia technique, which seems to be very simple. And the people who are afraid of facial nerve injury, who are not able to target, not able to visualize the target area very clearly, they find this method very easy and very easy to learn the cochlear implant surgery. But you can see the CT scan also. In this also you can see that the facial nerve is far away from the transcanal tunnel. This is a special instrument which is called perforator, by which you can make the transcanal tunnel. But the main objection which was raised by our posterior tympanotomy colleague, that it is a blind technique because you don't have any landmark from where you are going, and elevation of the tympanomeatal flap is a problem because they want that this is the sterile area, this is the nascent area, so you cannot raise the tympanomeatal flap. though we do raise the temporomandibular flap in stapes surgery, which I consider to be the more refined surgery than cochlear implant, and oral incision, and most of the European country people are using end oral incision for cochlear implant and all ear surgeries. So what we did because they are the pioneer and they have taught us the cochlear implant, so I tried to alleviate objection which we can alleviate by doing Bhopal technique. In this what we do the cortical mastoidectomy because they are doing cortical mastoidectomy since ages and there is no problem. So there is no problem in doing the cortical mastoidectomy. We see the short process of incus and fossa inquiris, and from where, like you see in the Ravi's video, from where he is making the facial recess, from that point, which is the safest point, we are doing the transcanal tunneling. As you can see in this video, fossa inquiris is there, short process of incus is also visible. Then we are using this perforator. It's a forward and backward motion with lot of, you can see the short process of incus, glimpse of short process of incus is there. So we are not doing the facial recess completely, but still it's a landmark based technique now, from where we are using the perforator to make the transcanal tunnel. The advantage of this technique also, as soon as you make the transcanal tunnel and you put your electrode there, it gets stabilized. And what we are doing in Bhopal technique, we are just covering this excess electrode with the gel form. Even if you have a metal electrode which has got the long excess electrode, this can be accommodated into the cortical mastoidectomy cavity. We cover it with the gel form and we put, in every case, temporalis fascia to protect the tympanic membrane perforation or to re-strengthen the tympanic membrane perforation. And we are using 4 suture techniques so that there should not be any use of retractor in small children. You can see we bring back the temporomandibular flap here and we are going to put the gel form again. So the main objection that it's a blind technique, we try to alleviate that objection, that because we are also doing the cortical mastoidectomy and we are seeing the short process of the incus, and just below the incus bar we are using the perforator, which is the safest area to avoid the facial nerve injury. To add upon this, now we are using the piezotome. Piezotome is an instrument which stops automatically if there is any nerve structure is there. So by which even we are alleviating the remote chances of facial nerve injury. So advantage of Bhopal technique, short process of incus taken as a landmark, cortical mastoidectomy to accommodate the excess electrode, even in excess electrode is very longer, temporalis fascia graft to re-strengthen the tympanic membrane, 4 suture technique to avoid the retractors, gel form covering over the mastoid cavity to protect excess electrode, it should not come into the suturing, and use of piezotome to avoid the remote chances of facial nerve injury. How we use the piezotome, I will show you in the video. Piezotome is a instrument which is not costing much. Your dental surgeons are using it very regularly. It costs only 1.5 lakh rupees. And we have tell them to make some probe which can be used in cochlear implant also, because their dental burrs are different than what we use in cochlear implant. It is like this. Again, you can see the short process of the incus. Just below the short process of the incus, what we are using the piezotome. It cuts bone with lots of irrigation. It takes a little more time, but the cutting is very smooth than burr. There is a very less chances of injury to the canal wall. Even in 1 or 2 stroke, you can very well make the transcanal tunnel. Ultimately, your aim is to put the implant into the cochlea. With transcanal approach, there are so many colleagues who are doing round window insertion also. Dr. Kranti Bhavana has presented more than 100 cases by which he is doing cochlear implant insertion with round window with the Viria technique only. So like this, we are making the transcanal tunnel. It's a very thick probe so that any thick electrode can enter through it. It takes a little more time than usual birth. Now you can see it is coming into the middle ear. So that you can make the transcanal tunnel very easily with piezotome. So our experience, we have done up till 2,000 cases in last 8 years. Last 1,000 I have done with Bhopal Technique. We have published a paper with Bhopal Technique, initial 200 cases. And in one of the centers where I mentor in Amritsar, they have also done 50 cases and they have published their paper. Even we have ultrasonic wave bone cutting technique, piezotome in cochlear implant surgery by Varia technique. These are the different centers where I mentor, and these are the different patients who have shown faith in me. So believe me, I am not against any technique, but you have to learn both the technique. But this technique I find that it is very easy to do because most of the ENT surgeons are raising tympanometrial flap every day. They are doing the cortical mastectomy also. They can able to expose the short process of the fossa incutis. From there, they are doing the facial recess, in which there are so much technicalities are involved because how, which kind of burr you are using. Sometimes facial recess is very narrow, and sometimes there is a risk of facial nerve injury. But by making the transcanal tunnel, you can avoid the facial nerve injury because it is very embarrassing that you do the cochlear implant and post-operatively you have the facial nerve paralysis to the patient. It is very difficult to counsel those patients. So I find this method very effective, and we are getting consistently good results with this. Thank you very much for your kind attention.
Thank you, Dubey sir, for your lucid presentation.
Speaker is Dr. Hetal Patel sir, who will be presenting on extended indications of cochlear implant. Ma'am. Dr. Hetal Patel ma'am, who will be presenting on extended indications of cochlear.
We all know that the cochlear implant was introduced to help all those patients who cannot be helped by hearing aid. So when multi-channel cochlear implant was introduced, in 1985, the first indication which was permitted for the cochlear implant was bilateral profound sensorineural hearing loss with no speech perception. As the time passed and seeing the result, how it was applied to the adult patient and with a good outcome, that means all postlingual patients which did pretty well, the whole technology was extended for pediatric group of patients. But here what differed was the post-operative therapy, because those patients were prelingual and there played the role of auditory verbal therapy. So in 1919, it was introduced for children, and it was 2 years and older children were offered cochlear implant, where the upper limit which was kept was about 6 years. In 1998, that 2 years age was, the lower age which was 2 years was brought down to 18 months of age with bilateral profound hearing loss. And as that in 2000, even not only the profound hearing loss, but even severe to profound hearing loss was included by FDA for the cochlear implant. At the same time, as far as the pediatric indication was concerned, 12 months was permitted with bilateral profound hearing loss, and even severe to profound hearing loss introduced for pediatric age group. If you see that the neuronal connections are best developed by the age of 2 years, and as the age advances, the neuronal connections become weaker, and hence it was more and more work was being done to do early implantation. And how early is early? And in 2020, 9 months and older with bilateral profound hearing loss was permitted by FDA. So if you see, in 2000 they allowed 12 months with bilateral. So from 1 year to come down to 9 months of age, it took a period of 20 years. And this 20 years, they realized that brain development occurs, 85% of brain development occur before the age of 2 years. So whenever we do cochlear implantation after the age of 2 years, we can do only 15% of modulation of brain to work. So because the patient not only has to hear but has to interpret at the brain level and then learn to speak. So hence the hearing loss was considered as neurological emergency, and more focus is being put on early identification of the children with hearing loss. So at our center, as we all agree that younger is the better, younger the child, the better is the outcome. What we consider is at least the child should be 10 months of age. It should be at least 10 kilos in weight, and hemoglobin should be at least 10 gram%. If you go by the limitations of the FDA criteria, because there were different criteria for adult patients versus different criteria for pediatric patients, and the entire developmental factor comes as far as the pediatric age group is considered, so the entire indications differed. And in whether it is adult or it is pediatric age group, it is the age or years of auditory deprivation is inversely proportional to the outcome. So if higher the age or more is the amount or period of auditory deprivation, the outcome will become poorer. By the Joint Committee of Infant Hearing, initially what was followed was the principle of 1-3-6. So by 1 month of age, the child should be, the hearing should be screened. By 3 months, if the patient has got a referral on OAE, should be completely investigated and the diagnosis should be taken into consideration. And by 6 months, the intervention should be taken. And that age, means 6 months for hearing aid fitting, has now moved to 1 to 3. So to get down the age of implantation, by 2 months one should know the definitive diagnosis by doing even BERA, and by 3 months the hearing aid should be fitted. Then comes the indications were further extended for obstructed cochlea and even the malformed cochlea, and in the patients who have got labyrinthitis ossification, maybe because of the bacterial meningitis, viral meningitis, chronic otitis media, or it may be because of otosclerosis or trauma. In these patients, the depth gauge was kept during OT so that to know whether the implant can go in or not. And all these patients, the C-arm had to be there, and those patients where very easily the depth doesn't go. Even the second cochleostomy was also attempted in the past when they had a double array electrode. CI was also introduced for patients with otosclerosis, and either in the early stages of otospongiosis or in an advanced case of otosclerosis, where the cochlea can be stimulated. Here the challenge lies that in otosclerosis you can have a halo sign where there is a softening of the tissue, and because of that one must choose a perimodular electrode. There is always a chance of stimulation of the facial nerve through this spongiotic bone. There could be possibility that there may be an incomplete insertion of the electrode, and there could be a faulty insertion into scala vestibuli. So whenever we are doing these cases of cochlear implant with otosclerosis, we try and use a depth gauge which is contour advanced depth gauge, so that you keep the stillet in place, take the C-arm picture whether you are in the right place or not. Because of the presence of this halo sign, you can absolutely go into the wrong plane, and the bone is very, very spongy. Then came the introduction to officially allowed cochlear implant into the anomalous cochlea, and places where there are increase in number of the consanguineous marriages, you see the higher incidence of anomalous cochlea, and the anomaly varies, but one has to choose the right electrode and the right anomaly. The worse the anomaly, the poorer the outcome, and all the patients with the anomalous cochlea may show you some initial improvement in the hearing, but they usually have a plateau. So usually the straight electrodes are preferred if the modulus is absent, and then the electrode may take the turn of cochlea. The complications which you can see in the abnormal cochlea is that the electrode may enter the wrong place. It can also enter the internal acoustic meatus, or electrode may bunch up, get kinked. There may be incomplete insertion, and there may be associated CSF leak. As far as the anomalous cochlea is concerned, severity of the anomaly decides the intra-op challenges. Initial benefits are seen, but then they may plateau. And anomalous cochlea, the cochlear implant must be considered in selected cases only after detailed counseling to help overall development of the child with limited expectations. Then the CI with other disabilities was also put forward. Like here we have Waardenburg syndrome, which can be type 1, 2, 3, 4. Type 4 is associated with imperforated anus. Post-rubella can have a cardiac disease, congenital cataract and bilateral profound hearing loss, while JLN syndrome will have a prolonged QT interval. Afterwards, then the extension was put to a bilateral cochlear implantation, and then in that we have two categories, whether you do it simultaneous bilateral cochlear or you could do a sequential bilateral. And with the bilateral stimulation, you can have sound localization, you can have eliminate the head shadow effect, there could be binaural squench and binaural summation of the hearing, spatial release from masking and improved speech recognition in noise. So either you do sequential, maybe if you do it within the gap of 3 months, you have same outcome as that of simultaneous bilateral, or you could do it simultaneously. Then came the principle of electroacoustic stimulation, where the bimodal hearing was introduced and where you could combine the principle of hearing aid with the cochlear implant. This was introduced in 2019, where electroacoustic stimulation normal to moderate in low frequency hearing loss and sloping to severe to profound hearing loss, and for the hybrid EAS device. So whenever you are talking about the electroacoustic, you get classical sloping curve, where low frequencies are maintained and the losses at the higher frequencies. And whenever you are dealing with the patients with moderate to severe hearing loss, where there's some residual hearing, electrode, one has to do the electrode, which is the right electrode, preferably the perimodular electrode, and you should insert through round window with very minimal intervention. If you are doing a cochleostomy, one must do a soft technique. There should be an absolutely slow insertion of the electrode, and advanced obstinate technique could be used, and one must use intraoperative corticosteroids to preserve the residual hearing. As far as the preservation of the residual hearing is concerned, the electrode designated to minimize insertional trauma and maximize hearing performance should be chosen, and mostly the perimodular electrode, which preserves the residual hearing, should be chosen. To preserve the hearing, soft surgery principles were put forward by Lendart in 1993, where one must avoid suctioning on the cochleostomy or the round window area. Round window approach is preferred. Careful manipulation around the cochleostomy or the round window should be done. Slow and delicate electrode insertion should be performed, and there should be a perfect sealing of the electrode around the electrode. Then came the principle of cochlear implantation for the unilateral hearing loss. That was introduced in 2019 for a single-sided deafness for adult, and for children who are less than 5 years of age, single-sided deafness could be used because there could be congenital sensorineural hearing loss on one side. So this approval was in 2019, and hearing deprivation less than 10 years should be preferred for the cochlear implant to give them the benefit of the binaural hearing. And all those who had deprivation, auditory deprivation, or a single-sided deafness over 10 years, we offer them the BAHA. The latest BAHA OSHA gives excellent hearing outcome as far as the single-sided deafness is concerned. So to recapitulate, when it started, the cochlear implant was started for adult patients, which were postlingual patients, unilaterally implantation of adult with bilateral profound sensorineural hearing loss. Then was introduced for the children with bilateral profound hearing loss. Then implanting the recipient with disability and anomalous cochlea. Then came the bilateral implanting the recipient. Then came the implanting recipient with a residual hearing, and lastly, the single-sided deafness. Thank you very much.
Thank you, Vittal Madam, for your good lecture on this. But one question is that nowadays the 3 months is also criterion abroad to operate, I think in Australia.
It is only under the trial. It is not yet FDA approved. What is last approved is 9 months. So it is only for the trial Australia Center, Sydney Center is doing. Even 4 months may be for the cochlear implant.
Good afternoon, everybody. Respected chairperson and the audience, I've been assigned to talk on cochlear implants in children with inner ear malformations. It's not a topic for 15-20 minutes. It's an exhaustive topic, but I'll try and concise and give you whatever information I can in the next 15 minutes or so. So I come from a city called Surat in Gujarat. It's in the west of India, and we started an implant program in April 2008. We've done more than 1,000 implants till date, and we are the only private center in the state to get accreditation from both the government of Gujarat and the ADIP health scheme. Now, if you know the literature, if you've seen the literature, cochlear malformation is not very uncommon. So you have reported literature review of 20% of children having cochlear malformations in children with SN loss, and these children present a challenge. Their surgical feasibility. There's obviously doubts about the performance expectations, and the expectations from auditory performance are less. That's mainly because there's substantially reduced population of the spinal ganglion cells. The surgical areas of concern for us as surgeons would be, most of these cases are usually associated with facial nerve anomalies. There's always usually CSF gusher, and obviously associated risk of meningitis in all these cases. Most of us follow only one classification to define these cases as a Senegal classification, which has defined anomalies into Michel's deformity, a cochlear aplasia, common cavities, cochlear hyperplasia, which are 3 types, incomplete partitions, which are the commonest types of anomalies, IP1, IP2, and IP3, and then we have the large vestibular aqueduct syndrome. Coming very quickly and summarizing each of them, labyrinthine aplasia would be something where you don't have a cochlear vestibule or the vestibular aqueduct. There is the interauditory canal, which only has the facial nerve. There will be cochlear aplasia, where you have an absent cochlea with a normal vestibular system. So that could be an absent cochlea with an enlarged vestibule or an absent cochlea with a normal vestibule. Common cavity is something which is very common. We see it very often. Is this where the cochlea and the vestibule are represented by a single chamber. It's a round or ovoid structure representing the cochlea and the vestibule. The incomplete partitions, as I say, are the most common of the anomalies that we encounter, and depending on the defect in the modulus and the interscalar septa, they are divided into 3. It's either an incomplete partition type 1, incomplete partition type 2, or an IP type 3, which we also know as X-linked deafness. So IP type 1 would be where the cochlea lacks the entire modulus and the interscalar septa. It's an empty cystic structure with a large dilated vestibule. There's always a defect between the interauditory canal and the cochlea. So obviously the area of concern is when you're putting in the electrode, there's a chance that you might enter the brain. The IP type 2 is by far the commonest of the 3 incomplete partitions. It's also known as Mondini's deformity, and is described by Carlos Mondini as a triad of a cystic cochlear apex, a minimally dilated vestibule, and a large vestibular aqueduct. What you have in this is that the confluence of the middle and the apical turns with the presence of only the basal part of the modulus. You have a basal turn, and the middle and the apical turns fuse to make an apex. The IP type 3 is very similar to IP type 1, except for the fact that in IP type 1 you don't have the modulus and the interscalar septum, but in the IP type 3 you will have the interscalar septum, but the modulus is absent. LVS is generally just the presence of an enlarged vestibular aqueduct, which is defined on scan as the midpoint between the posterior canal and the operculum, which should be more than 1.5 millimeters in the presence of a normal cochlea and vestibule. I won't go into cochlear hypoplasias too much because it doesn't warrant the time here, but it could be type 1, which is like a bud-like cochlea, a type 2, which is a cystic hypoplastic cochlea, often confused on CT scans with a common cavity or an IP type 1 because there is no modulus, there is no interscalar septa, there is always a connection with the interauditory canal, and gusher is always present. Or a type 3 where the cochlea is hypoplastic with less than 2 turns. Now, practically, if you look at these children, we all see children who come to us at 6 months, 9 months, 12 months, 2 years. We do our bearers. and we diagnose them with severe hearing loss or profound hearing loss. And when should we send them for imaging? Now, most of us don't send them for imaging unless we plan to do a cochlear implant, which in my view is a wrong thing to do. We should have a more scholastic approach to these children, because radiology does guide in the decision making for these children. So for example, if you have a patient with an IP type 2 or a large vestibular activate syndrome, the hearing level may be suitable for hearing aids. Now, in cases of certain anomalies, the decision to offer a cochlear implant can be taken much earlier. These are patients who are less likely to achieve benefit from hearing aids, such as a common cavity or IP type 1 or IP type 3. So let's say you have a patient with an IP type 1 with a severe hearing loss. If you have done the imaging at that time with the audiological reports, you might save time on giving them a hearing and rather shift them towards a cochlear implant. And in then cases of patients who have labyrinthine aplasia or cochlear aplasia, there's no point giving a hearing aid trial, because they can then be counseled and shifted towards an auditory brainstem implant. Now, electrode choice for each of these and what to expect. Obviously, labyrinth, cochlear aplasia, cochlear implants are contraindicated. Auditory brainstem implants are the only option that you have. Common cavity, what you want is a straight electrode. Full banded outcomes are usually reasonable. And when you operate these children with common cavity, it's just a common cavity. So what you're trying to do is just make an opening in the vestibule and cochlear common cavity. The steps of surgery are a little different, because what we are trying to do when you put in the electrode is that all the spiral ganglions are going to be in the outer wall. So you're trying to go and curve the electrode like this inside, so that all the bands of the electrodes are covered on the outer wall, which gives you maximum stimulation. So the insertion choice becomes different. Also, what you want is a straight electrode. You want a perimodular electrode or a pre-curved electrode, because that won't go in here properly, and you will have the electrode bands curling inside, which you don't want. IP type 1, as I say, it's always a wide connection with the intra-auditory canal. There's always a gusher. Again, what you want is a straight electrode, preferably a compressed electrode. Outcomes with these patients are usually variable. Some do great, most don't do very well. And most of these patients who have an IP type 1 or IP type 3 would have other anomalies. So you'll generally find anterior sigmoid sinus, you'll have facial nerve anomalies, you'll have contracted mastoid. The surgery for them becomes generally difficult. So this is a patient with a very high jugular bulb, a very high anterior sigmoid. Go quick. But when you're expecting a CSF leak, what you don't want to do is have a round window insertion. What you want is a wider cochleostomy so that you can plug the CSF. Ideally, you have a specific electrode from a company called Medel, a Form 19 electrode, which helps seal the defect, but we are government tender-driven implant programs now. We don't have a choice of which implants to use, so you should have your backup as surgeons ready. Have a wide cochleostomy, put in the electrode, and then seal it properly with fat in fascia. And usually, there's never a problem with these cases in the end. The IP type 2, commonest of all, issues of gushers are always there, not as bad. You could use the electrode of your choice, or as per your tender, outcomes are most favorable. This is a patient with a very contracted mastoid. I'll just go through quickly. A very dehiscent and anterior facial nerve, if you can see there. You couldn't really see the round window too well. This is a case which was a private case for us, so we had the option of choosing the implant of our choice, and that's where we used the Form 19 electrode from Medel, which has been devised by Professor Levent himself. And I'll just show, so that's the electrode, and that has something known as a cog here. So this goes and effectively plugs up your cochleostomy so to prevent any CSF coming out. So that's the most desirable electrode, or the most favorable electrode to use in cases where you expect a CSF gusher. Similar case, I'll skip through that. And IP type 3, also excellent, very similar to IP type 1. Again, the only difference between the two, interscalars septum is present, the modulus is absent. Shorter electrode is preferable because of the wide connection with the intra-auditory canal, and the outcomes are usually variable. So just to summarize, aplasia, as I said, auditory brainstem implant, outcomes poor. Common cavity, IP type 2 are cases where you get good outcomes. For a common cavity, preferably use a straight electrode. For an IP type 2, use electrode of your choice. Large vestibular activate syndrome, no issue at all, very good outcomes. IP type 1, IP type 3, there are a lot of variable factors. These patients usually have other multiple handicaps. Some have IQ issues, some have mental retardation, so the outcomes vary from patient to patient. So with this in mind, we did do a study in our place to report surgical aspects and assess the auditory outcomes after surgery for children with anomalous inner ear cavities. And so it was a retrospective case review. We reviewed about 164 patients between April 2008 and September 2021 who underwent surgery at our place. All of these patients were classified according to the Sadler-Kluwer-Stadtke classification. And you have various anomalies, as I discussed, but the most common was the IP type 2. Thankfully, most of our patients lay in the less than 3-year age group, which definitely does affect your outcomes eventually. We use a standard transmastoid facial resistance approach in all our cases. We never had to change our approach till date. I've been doing implants for 15 years. I have not had to really go and design a new approach for my patients. These patients were then followed up for a year, and at 1 year, their category auditory perception and their speech interval rating were assessed. And you look at the result, surgically we found the facial nerve to be anomalous in 23 cases, which was seen on the radiological scans before assessed. CSF gusher was seen in 52 cases. Thankfully, we could get a complete electrode insertion in all of these cases. And because the audiological outcomes, patients with IP type 2, the LVA were great. 8 is understanding speech with normal, understanding conversation with an unknown speaker. The common cavities also did well, but if you look at IP type 1 and IP type 3, they were poor compared to what the other patients were. The speech scores, similar pattern followed, common cavity, IP type 2, LVS were fine, IP type 1 and IP type 3 lagged behind. So to summarize, at 1 year, all our candidates did show improved auditory and expressive performance. However, the patients with IP type 1 and type 3 level poorly. For this particular study, we excluded patients who also had hypoplastic nerves, because that also has a very big indicative criteria towards the outcome that you're going to get with these patients. So inner ear malformations do constitute a unique subgroup of candidates. And although surgery can be challenging in certain cases of gusher and facial nerve abnormalities, if you have done a proper radiological evaluation, if you've seen the scans well, and you have a good surgical technique, you shouldn't really have any complications. As I said, we should be ready to make modifications in our minds, in our surgical approach if necessary, and should always keep in mind the possibility of a CSF gusher. So, to conclude, the results of our study suggest that the presence of an anomalous cochlear vestibule anatomy, with the exception of a hypoplastic cochlea or a hypoplastic or an aplastic cochlear nerve, should not be a deterrent to a good outcome. They really do well. Knowledge of anatomy, as I said, is very, very important. Read your scans yourself. Don't rely on the radiologist. Don't see the reports. Study your scans. I don't think any radiologist can tell you with precision what you are going to encounter. So study your scans yourself. The cochlear nerve may be absent in some cases of these malformations, and this should be investigated. And failure to recognize that by us would result in unnecessary operation. Thank you so much.
Thank you, sir. One question, all these patients are self-funded, or whether you will get something from your Gujarat government even though in such anomalous cochlea?
So no, sir. This is a mix. The review that we did was a mix of patients, both private and funded. For the funded, ADIP has its own guidelines, ADIP has its own criteria. The Gujarat government till about 2 years back never had any guidelines. They would, if I would recommend a surgery, they would give the permission. Now they have started following the ADIP protocols. But in our study, which we did right now, or which I showed, we have not taken any patient who had an hypoplastic cochlear nerve. So we had patients who had an IP type 1 or IP type 3 with a query hypoplastic cochlear nerve or an aplastic nerve. Those patients we didn't take in the study.
Okay. And for ABI, where you refer the cases then for ABI?
Sir, I do it to my mentor, that's Dr. Mohan Commission.
Okay, okay. So,
we've never had the chance till it, so we have an independent study of about 37 patients with hypoplastic nerves where we've done a cochlear implant, and about 26 of them are doing very well with the cochlear implant. So there are 11 who are not doing well, who we have counseled for an ABI, but the cost or the fundings remain an issue, but 26 of them are doing reasonably well.
Okay, nice take-home message.
Thank you. Thank you.
Okay.
Shall I start, sir?
Please proceed.
Yeah. Good afternoon, all. So, I'll be speaking about medical innovations in a post-lunch session, and I hope I'll be able to keep all of you awake by this. So, I am working at AIIMS Jodhpur, one of the new AIIMS, which was established in 2012. And basically, I am also a practicing surgeon. So why I am saying this? Because all the speakers, Dr. Kumaresh, Dr. Srinivas, all of them who are working in this field, they are actually practicing surgeons. So it's not that we have left practice and we have ventured into this new domain, which is conventionally uncomfortable for doctors. But we have chosen to, explore it, and we found it quite exciting. So, incidentally, I am fortunately I am looking after the surgical device development module for Masters in Medical Technology course, which is offered by combinedly by AIIMS Jodhpur and IIT Jodhpur. And I am looking after the Intellectual Property Management Committee of AIIMS Jodhpur also. And all this development is just last few years only. So just like any other practicing surgeons, we just see patients, we operate, we face problems, but we never talk about them. And even if we want to do something, we think about that, we don't know whom to find, whom to talk, where to go, what to do. All these things are sort of entirely alien things, alien word for us. And 2007, when I was in Shillong before AIIMS Jodhpur in 2011, since that time, some tracheostomy tube problem was there in mind. I approached few people also. Luckily, in 2017, one workshop was held in AIIMS Jodhpur. I was a faculty there. I'm a faculty there. So that workshop combined engineers, students, doctors. They made random teams, combined teams, and one competition was organized. And everybody was given a problem, not necessarily their own field, any medical problem, and come out with a solution. So we were able to do a decent job, and we won that competition also. And that time was actually a kick start for an entirely new journey for me. So, and after that, when joint conclave with the IIT also took place, and we were exposed to many engineers also, and that's how this all story began. So we all know, I think there is nothing new about we all know as a doctors, this is the most complex, beautifully engineered machine of the world, where all the laid down concepts of physics, chemistry, biology, everything we can find it here, including architect also. You can compare our human body with the home also or anything. So all the concepts of science, they apply in our human body. So we look from different perspective, but we know what engineering is all about, a perfect level of engineering. And innovations have been there since this innovative mind of human beings that's existing since, Stone Ages probably. So we keep on thinking, keep on trying to solve our problems by some way or other. And this journey is still continuing. And this, I think, the Indian Jugaad, everybody must have experienced somewhere or other in their neighborhood, in their own home, or maybe, their workplace. So whatever is available, we just try to use that for our own to solve some particular problem. That's the key word in all this journey. So the problem and the solution, these are the key words. So today, I'll be just briefly touching upon what actually innovation is and why should we do it. Then some story, interesting story of a very landmark innovation in medical history. Then what future has to offer to us. And a little bit, means some of my own experience at AIIMS Jodhpur. So Sushruta and Charaka, they were the pioneers, medical practitioners. Hippocrates, he was also, one of the leading medical person, and we all know their contributions. They were doing surgeries in those ages also where all these sophisticated gadgets were not there. And the all development took place, we all know about that. So what is basically innovation? So innovation is actually nothing but process to obtain something new. So it addresses a specific scientific problem. So we should have a problem, and we should be able to come out with a solution which can be utilized practically. That solution should be utilizable. That is also important. So do we have a problem? We explore solutions. Existing solutions also we explore, and then we come out with a new solution. So that's what is innovation, and we start using that. So what innovation is not? Innovation is not artistic creativity. Taj Mahal, it's not innovation, it's artistic creativity. A painting by Van Gogh of a person with bipolar disorder, this is also not innovation, it's artistic creativity. So it's far away from innovation. A bright idea, you have something bright idea, maybe sci-fi movies you see, or some like this man who is resurrecting a dead man, that is also not innovation. It has to be practically used. Again, scientific discoveries. Penicillin was discovered. The thing which was already existing in nature, somebody discovered it. Marie Curie, she discovered radioactivity. Or the photosynthesis process. The HIV virus, it was lying in the nature, already existing. Just 5 cases of pneumocystis carinii coming within a short span of time, getting admitted. And the treating physician, he just explored why such a rapid rise of pneumocystis carinii within a short period. And then that's how they actually discovered the HIV. So that thinking process of why, how, all these things, but these are all discoveries, not innovations. Again, these are inventions, path breaking, a wheel, fire, we all know. So when we observe, we come out with problems and we come out with solutions. So these are innovations. Wheel was there, making a car, it needs innovative mind. Or a matchbox. These are again, same wheel, a different use, or the same wheel, a different modification for a different purpose. So all these are innovative uses or innovations which are actually, which can be thought and implemented, utilized. That is again important. So a discovery can happen by chance. Like Marie Curie, she was just passing by a factory and the chocolate melted in her pocket. So then she thought, okay, why? So it can be by chance also. But innovation never occurs by chance. It is the end result of a very brainstormed session with lot of thinking. So research, development, innovations, they are very closely related, but they all encompass a different concept. So why it is needed? Now this cycle is important. You innovate, you make money. You apply for intellectual property protection, you make money, you pump that money into research. You do research, you gain more knowledge. And that knowledge again you use to innovate. If we see the development of any medical gadget, we can easily imagine this cycle. You make something new, you earn money, you do more research, gain more knowledge, and then apply that knowledge to innovate the next version of that machine, which is more sophisticated, more useful. So this is important, that money is also important, and here comes the role of intellectual property. And 60s, 70s movies, usually the big man of the city was a person having factories, machines. But nowadays, just 1 or 2 room office, having lot of patents with their company. They are big people, having lot of intellectual property. So they don't require big lands, big machines to be rich and successful. So the entire industry shift that has shifted from tangible machines to intangible intellectual properties. Pieces of papers having patents in their names, and they are making huge money. So similarly, for everywhere we can see this shift in our, and that there is a role of intellectual property. So this story I would like to share, the Laennec, he was a physician, and he always used to feel very uncomfortable while listening to the heartbeats of especially female patients or very obese patients, because at that time they had to put their ear on the back of the patient or chest of the patient to hear them. So he always, used to feel very uncomfortable. So one day he was passing by and he saw a few children who were listening at the two opposite ends of a wooden pipe. So he just thought, it clicked in his mind, why can't I use this? Why can't I try this? So he just created initially a plain wooden pipe, then hollow, then at one end. So different designs, and he came up with the Lennox stethoscope. It solved the problem. Just simple observation. He had a problem, he thought about it, he came out with a solution which was very much practical and usable. This was the journey of a stethoscope. After so many modifications by different brains, it came out to finally this shape. But it has not stopped here. What about classroom teaching? So this was innovated. One stethoscope and many people can listen. AIIMS Delhi, they went one step ahead. They removed all the tubes, just one chest piece and so many Bluetooth, and the entire class can hear the heart sounds in one go. So the journey has never stopped. It is rather, we also did our small bit for this stethoscope purpose only during COVID times. And what we tried was just a routine stethoscope, a routine mobile with this microphone, and we were able to hear the heart sounds a person sitting in a rural area. So that consultation for use for teleconsultation, a very low resource, whatever is available. So that was also published on PubMed, and that's what we could try and do during those things. One fear is there that we can be, like AI has a big fear, that GPT chatbot people are talking about. That person may become dumb after that, but I believe differently. This will open more avenues to do some other work in some other areas with the use of technology. So that's what might be there in future. Again, Jugaad, you can see how beautifully they are simple available things, and they are using their mind to make their work easier. If Three Idiots movie, Amir Khan's statement, if you can remember, anything which helps is a machine. So whatever is available to you, I tell you a very interesting story. After my PG, I was posted in a periphery. Anesthetist was there. I was doing my first thyroid. Romovac was not available. Now, big center, Romovac is a very easily available thing. So I told what to do now. So I was planning to put a routine corrugated, but he thought, okay, wait. Just a simple syringe, a tubing, he attached, and he pulled the syringe after closure of the thing, and just that needle cover, he just stuck it on the plunger. So that created negative suction. So that was a replacement of Romovac at that time, and it worked well. So simple things, and that was also an innovation. It solved my problem. So that's how things can be thought and gone ahead. Now let me do some self-patting. Whatever we could do in last few years, I'll just briefly go about all these things, and then maybe. So this was our COVID time thing, and the initial idea, if my cursor is visible, the cursor is not visible here. Anyway, this on left side, this was the first thing we thought, that intubation boxes were there, but we put a negative suction, we created a negative suction environment, and with sealable ports, and we did intubation. And this is actually one of my ex-senior resident. He came up one day with this. He himself made this box. Well, sir, I want to make some box like this for tracheostomy. So we were already in the process of making this. So this, both the things, the same concept, and one for intubation, one for tracheostomy we could make. So the patents are applied, but the main thing is these were made, executed, and sold also. Though COVID very rapidly vanished after that, but at least we tried and we could do something. So that was the thing. So this is a small video. Sound. So this is our intubation box, and we could easily use it. At our center, we used it quite routinely for intubation. Then again, this is box for tracheostomy. The same concept, but a little bit modifications with all the instruments inside, negative suction environment, and one anesthetist and one surgeon and one assistant could put their hands in, and they were able to do. Now, this is percutaneous tracheostomy through the same box. So this also was possible. So then this tracheostomy tube, this also patent has been applied. So for pediatric patients, always there is a problem of suprastomal granulations. So since long back, I was thinking something. So what we could come about, a simple thing, instead of a cuff, just a cup-shaped soft thing, and with a suction here, the channel here. So you can deliver the drugs also, steroid or whatever you want, and you can suck it out also. And again, everywhere people are thinking in the same way. I had two of my very good ideas. I won't say my, but at least I thought of those ideas. One for facial paralysis, one for vocal cord paralysis. So entire design was there in my mind. But before going ahead, you have to do patent searching, because if somebody else has applied for patent, then there is no point of going ahead. And surprisingly, both the ideas exactly same. They have been applied by somebody else also. It's not that only we are thinking, or people are thinking and doing that job. So this also, this September I went to US. So Carl Schneiderman, this, by the way, this the next thing which I will talk about, that was one of the top 20 selected innovations to display at AO HNS conference Philadelphia this September. So I was on my booth. Carl Schneiderman was just opposite my booth. So he was having one tube, endotracheal tube sort of. So the design was not exactly, but almost similar. So I told him, we have also applied. So he was like, when? The date of patent application, because that is important. If we have applied first, then his idea is gone. If he has applied first, we are beaten. So it goes like that. But at least I was happy to see that, okay, we are thinking, we are trying to do something. So that was a big motivation for us. So this also won Indo-Sweden Healthcare Innovation Challenge, and the next one also won. So 2 awards we could gather. So this was the main talking gloves, which has, the patent has been granted. This is the first patent to our institute, first patent to IIT Jodhpur, the joint patent. And this also won the Indo-Sweden Healthcare Challenge. The idea started that we see a lot of laryngectomy patients, and the prosthesis esophageal speech or electrolarynx, they are suboptimal. The voice quality is not great, and patient has to learn a lot, and some problem or other is always there. So, like sound is not there. Anyway, so these are the kind of sounds which can be, which are produced by these. So we were helping one engineering student for his thesis on facial electromyographic signals to, assess the speech. Means those signals he was planning to feed in AI system, and then which can be reproducible. The thesis was completed, he got PhD award, and after that he did not do anything. Then we were connected to IIT people. So this problem was already there, which was intriguing us and wanted to do something. So during discussion with the same, my ex-senior resident, who is an assistant professor in AIIMS Guwahati right now, in OT during discussion, suddenly something reminded me. I'll just tell you what. So what is this? All of you speak in your local language. Mango, whatever, right? But if I want to write it, I can write it in Devanagari script, right? In any language. So that same concept, it clicked, and we thought, why don't we use this thing? Whatever language you will speak it only, right? So this our Devanagari script is very rich in phonetics. So we extrapolated these phonetics into our gloves. And I'll just show you how it worked. Yeah. So what we imagined that it should be easy to use, wearable, complete freedom. It should be language agnostic. One simple training and it should be able to be used in any language. If I learned that language like typing, after that I can speak in any language. I don't need to, learn again and again for different languages. Then minimal training, affordable and no maintenance. Now the problem, we speak different language, engineers speak different language. There's an entire disconnect, and this Srinivas will talk in detail about that thing. Means how, sometimes you feel like they have different perspective of life than us. So this problem was there. Anyway, right team we could get, lot of brainstorming sessions and hit and try. Then these gestures became.
जॉइंट पे उंगली बेंड करो तो तुम्हारी एक 90 से कम हो रही है, 90 तक और एक 90 से ज्यादा जिसमें पूरी उंगली बेंड हो रही है.
10 fingers we have. So we made use of wrist and 10 fingers, and we could extrapolate the entire Barakhadi into those gestures, right? And again, engineers still the gap is less. With IP firm, there's a huge gap. When we went to apply patent, the first draft which he gave, we were entirely, are you talking about our idea? What is this? So they have different, they are legal person. So really means this was my question to him. This is our draft or somebody else's draft? So, but then he explained why it is our draft only. So anyway, it's a huge gap, and gradually after doing so many courses in IP, I could understand what actually they mean, why they are doing like this. So we need to find an honest IP firm with competence and very clear goals. Your goals, we think by heart and they think by brains when we talk. So that bridge has to be, fulfilled. It's a long process of IP filing, patent filing. We have gone through this entire process, and after that, we could finally get the patent. And this was, the processing is slow because it's just locally available things processor we have made. So any language you can speak.
No. Mo. Sure. Adha.
He is an engineering student, just first prototype.
Namaste.
So you can speak in English and Chinese also. It was there in the video in the end, Chinese, Bengali. So different things we tried with the same gloves and same. So it was well appreciated also in the media, and the Vice President Naidu, he actually took interest. But it's a long journey, and in different types of medias it was widely covered. So finally we have to go for marketable prototype, and all these things, they will still take a couple of years for, and we really want it to be in the market. So the challenges are funding and all those things, and the biggest challenge is like to find a right engineering team, first step, to find a right IP firm, second step, to find a right marketing person or funder, that's a huge job. Here, this is the step where we all get stuck, hugely stuck. So I don't know what will be the fate, but we are still trying to different methods, and these are some future, my team is working on all those things, different projects. Hopefully something good should come out of them. So again, it's a jugaad, and it can make our life much easier. Simple things. So whatever available, we can really do things, and it doesn't need anything big always. Very small things can be, path breaking. So nothing is small, and don't always aim for the big things only. You can start with the smaller things. Clear vision, brainstorming is necessary, right team and perseverance. And you will feel high and low also. There were periods when we thought of just leaving this project. Okay, it won't work, it won't happen. But finally, we could get it. And media attention, that lasts very short. Finally, it has to come to the market. So our target is not media. Our target is market, and finally to the patients. And whenever you find any problem, it always comes with a solution. You just need to have to look at both rather than only one. So, and I am deeply inspired by few people in the entire journey. One is sitting here, Srinivas, then Anita Mandhari ma'am, then Kumaresh, Jagdish. At least these are people whom I know who are working, Vishal Rao. So these people are really working, and they are way ahead than us. And despite being in a government sector, we were able to do something, and it's just baby steps. Hopefully, we should come up with something really useful and marketable in future. Thank you for your attention.
Hello. Presentation, and as you said correctly, everybody of us may not be able to do great thing, but everybody of us can do small thing greatly. So you are doing small thing, but you are doing it greatly and thinking out of the box. So really, sir, congratulations to you, and keep on these innovations and help our community, ENT community. Thank you so much.
Thank you.
Work that you have been doing. Congratulations to you. Okay. So, in the last 8 years have been dedicated to making equipment, and I thought that the experiences of interacting with the engineering team is what I will share with you, so that it will be beneficial for people who really want to make products. There are a lot of people whom I come across who want to make products, who have ideas. Okay, there are ideas from making surgical instruments to making complex electronic equipment to things, softwares, all different kinds of ideas that people have. Okay. So when I come across engineers in the last 8 years, there are 3 motivations. We need to understand what are the motivations these engineers have. One motivation is the impact that they are going to make. Okay. The reason why they would want to be associating with you is the kind of impact that your work is going to do to them. The second kind of motivation that I see among engineers is they have a certain particular skill set, and they have a joy in seeing their skill set come to action. Like if somebody is making a certain product, whatever design, one mechanical design, they love to see that end product. They are least bothered about what final impact, what it is going to happen, whatever it is. I have a certain skill set to design this thing, and when it comes out the way that they want it, they are happy. That is the third kind of people. The third motivation is that month's money, to earn that month's money. If the primary motivation is the third one, avoid that person. Okay, that is clear cut. If the primary motivation is the first one, where they want to associate with you for the impact that your work is going to do on the society, that person is your long-term partner. If the primary motivation is joy in doing that, they are very good partners for turnkey projects. Like for one thing, for one device, for one particular thing, they are going to be very good products. So we need to understand the kind of motivation and then do. There are different ways. When you talk to a mason, there are different ways in which they look at it. There is a particular journalist who was talking to people. The same mason who is doing a building can tell what are you doing when you are putting a brick. The one person can tell I am putting a brick. The other person will tell I am contributing to building one of the largest cancer hospitals. Okay, this is what one I saw in an interview. So that is what tells us that difference in looking at them tells whether they are a 9-to-5 person or a person who will not sleep till the problem is solved. So this is the first thing. The next thing that I want to tell you is about where that first giant leap happened. Okay. When the device that we have made, the first device that we made is a video nystagmogram, VNG system. Why did I first think of doing a video nystagmogram, the video nystagmography device? Because I was actually one of the users of video nystagmography system long ago. Okay, and then I thought, okay, if the vestibular science has to progress, with huge cost of monocular equipment which used to import those days, with that kind of a thing, in a nascent science where things is still not very clear those days, people would not be willing to invest that amount of money and the science will not progress. If the science has to progress and if our people have to be benefited, the cost has to be a little optimized, was the first motivation to get into making the VNG system. And with that idea in mind, for more than 3 years, I used to talk to many engineers to tell, we want to make a VNG system. What is it based on? There is one camera that looks into the eye, and then from that we get a graph. This kind of language I used to use again and again and again, talk to many number of engineers, and then it never went beyond that. They seem to understand, they seem to do, but whatever, it never understood. Those were days when there was the BlackBerry had come up with its playbook. Okay, what playbook did is, it put, for those days, okay, where it made internet browsing possible in the bed, okay, where I could sit in whatever position and then do. During one of these sessions, again and again hitting VNG, hitting video nystagmography, I finally found the one word that made the difference and which was the bridge between me and the engineer, and that word was not VNG. Engineers don't understand what is VNG. It was eye tracking. I said I wanted an eye tracking device. The moment I said eye tracking device, next day my co-founder Niranjan was there, me and him, both of us were having, we were partnering on another event, and then he was just going home. It started drizzling. When it started drizzling, we thought, okay, let us have a tea and then go after the drizzle stops. And at that time I told, I am looking for an eye tracking device. The moment I said eye tracking device, I know somebody who was trying to sell his eye tracking device for the last 5 years to me. Okay, and then who is this? And then at that moment we decide, we call him up and we go there. But finally that person we could not partner with, but I knew the terminology. So the most important thing is to get the terminology right. The moment you get the terminology right, you know, like you can communicate with them. You know that the moment that is there for them, it is easy to communicate. The next thing that I want to tell is the power of PowerPoint. Okay, the power of PowerPoint. We use PowerPoint as a tool to make presentations, but PowerPoint is a tool much more than presentation. It's an excellent drawing tool. Okay, PowerPoint is an excellent drawing tool. The moment we think of drawing, we think of a program like Paint and these kind of things, but PowerPoint has much more capabilities than being just a drawing tool. When you want to make softwares, interactive softwares which progress from, you click this button, it goes to the next screen, it goes to the next screen, what do you want to show, what do you want to show, what do you want to show? That UI and UX, okay, UI is user interface, UX is user experience. Interface is what you see there. The experience is, once you click on that, what happens next, how it is, how seamless things go on, for whatever. To design this UI and UX, there is no better tool than a PowerPoint, and the moment you put every screen that you want on your software on a PowerPoint and then take it to your engineering team, they will understand your flow much, much better. And also for designing equipment, designing things, there are a lot of things. You can put squares, you can put circles, you can put lines, you can design icons. All these things are possible with learning the power of PowerPoint. This is the thing. The third point that I want to tell is, just like doctors, engineers also highly specialized. You can't go to a dermatologist with your headache problem. We can't. Though our people think, if a dermatologist prescribes a cream, if his neurosurgeon friend is there, they think that in the hierarchy, neurosurgeon comes top, neurologist comes next, cardiologist comes next, God comes next, ENT surgeon comes next. This is the hierarchy according to people. So if the dermatologist gives a prescription for a particular cream, what they will do is they will take the neurosurgeon friend's opinion, not even knowing anything that that person has never treated even his own acne. Okay. But that is the unfortunate. But coming back to this, engineers again are different. Don't think all engineers are the same. So don't go to a software engineer and talk to him about your mechanical construct. When you make a software like Balance-I, which is the one with which I have come, this has a hardware feel, and look, there is a camera, there are cameras, world's only in-frame cameras, okay, world's only in-frame cameras. Then we have a single wire, okay, there are so many things. Camera is a different technology. The lens arrangement within that camera which suits the purpose of Balance-I is a totally different technology. Making that work with one single wire instead of two wires which every VNG system uses is something else. That has something to do with electrical interference and these kind of things. So, and then we have computer vision algorithms which will pick up from the video where exactly is the pupil. And then we have a user interface and a user experience and all these things. And then something of this to be optimized to run on a system very fast. So these are different components. If you have a super talented person who can handle a lot of things in this super, I have been blessed with such a partner who is Ajit, okay, who understands a lot of these things. But we should understand that each of these things is different. When it comes to actual feel of the device, it's a mechanical design. There are aesthetic mechanical design. There are separate designers for that particular thing. So you need to go to that particular mechanical designer to make the design construct. When you talk about design, then there are multiple stages that we go through. The first through design stage of a mechanical construct, which you should on your own be able to do. That is called as a proof of concept. Okay, after just the mechanical design, the proof of concept, that it works something like this. We need to understand this difference. Proof of concept means this as a concept works. Proof of a concept does not mean it is supposed to be viable in the field. See, what happens is when you say that this thing works, soldered wire, twisted wires, whatever, ultimately it works. It does that job only there. It tells that the product is viable, this idea is viable, you will be able to do this. From the proof of concept to a minimal viable product is a huge leap. If you make a proof of concept with 1 lakh, by the time you make a minimum viable product, it will be another 25 lakhs of expenditure. So that is the kind of design, that is the kind of thing that happens before you go ahead with the proof of concept. And proof of concept to the minimum viable product. And there is something called a perfect product. Let me tell all of you, never ever think that you will ever reach a perfect product. A perfect product is not possible. Okay, is not possible. This you have to understand very much when you are talking to the engineering team. Okay, a perfect product in the sense that by the time my today's demands are met by the team, already my requirements or my desires have already increased. I would want it much lighter, I would want it without wire, I would want it like this, all these things. So these are the things that we need to see. Then another point that I want to tell, and the very important point is, it's a combined, it's a two-part point. One part is, don't ever be afraid of sounding like a fool. When you are a doctor, and you are talking to an engineering team, you don't know their terminologies, you don't know their concepts, you probably don't know how things work underneath the hood when it comes to software design, when it comes to mechanical design, whatever it is. But what is going on in your mind, please speak out. Please speak out without the fear of actually sounding like a fool. That is very important. Otherwise, at that stage only the thought is cut off. That is the part 2 of this concept when you talk to an engineer. Is just like in vertigo. Okay, how are we successful in vertigo? What is the one barrier that we fought? The barrier that we have come across is we never hesitated to cross boundaries. There is a boundary. This is a neurosurgeon's field. This is a neurologist's field. This is a physician's field. We crossed that boundary. We took that step and then started doing that evaluation, started reading that chapter, and because of that only our patient. There is that no man's land And there is a no man's land in between. There used to be a no man's land in skull-base surgery. There is a no man's land in vertigo. And into that no man's land, we should step in. Don't think that you are going to step onto somebody else's field. So don't ever be afraid that you are sounding like a fool. Second thing is, please, okay, don't hesitate to step into something else which supposed to be. That sometimes can go to an extreme, like in my case. Okay, so what I have done, after this has been 8 years into making devices. There was one particular point of time I thought I should be doing data science, so that I can analyze the data on my own. I can do time series analysis, all the signal processing, everything, and then understand that, identify nystagmus patterns, identify these things, and whatever it is. So what I did, I went ahead and did a complete 1-year course in data science. And I will tell you, being a doctor, this point is very, very important for all of you. There are 100 people in this particular batch. They come from different streams. Okay, some of them are actually already engineers, already other things. And of the 100 people in the batch, this is a University of Texas with Indian University course, I topped the batch. At the end of the ranking, I got the first rank in that full batch, which means there is no barrier actually. You can be there, you can step onto that, and the one chosen thing that you have to do, you can do it. So finally, motivations are very important. You should know who are the people whom you are going to partner with. The best long-term partners are people who see the impact that you want to create on the society through the work that you are doing. These are the long-term best partners. Short-term turnkey partners are people, engineers who take pride in that particular thing that they are doing. They are not interested in anything else, but what they do, they will always do well. Never associate with somebody who wants to be there for that month's money. People who want to think that from 9 to 5 and then 5 o'clock off. Okay, they are not going to do much. So with that, I think I have shared some of the key points that have come up as lessons for me in the last 8 years of this journey. Thank you all.
Wow, sir, it was a great talk. Without using a single slide, without using a single paper, you were so flawless and so spontaneous that everyone was at apt attention. So hats off to you. Very good. Good advice for all those you want to go for innovations and develop some new technology or new instruments. Thank you so much. Hello, where is the organizers? Team from organizer, anybody? No, I don't know. Somebody from the team, organizing team? That one boy was there?
Please, ma'am. This is yours only. Sir, please. Wait. Please, sir. Thank you.
Good afternoon, Madam, Dr. Bharati Madam, Chairperson Rahuliwala, and dear friends. Actually, this topic is designed for the junior colleagues and postgraduates. Maybe so one of the most sensitive surgery in the surgical arena, one can say it's a stapes surgery, because matter of 0.25 millimeters this side, that side will make the results up and down. So before keeping the patient on the table, we have to assess the hearing, confirm this conductive loss, and confirm the thickness of the foot plate if possible with the CT scan, and surgical approach. So what are the simple points to be observed during stapes surgery is, what is required is correct position of the patient and hemostasis and curved field, then we'll get a maximum results without any difficulty. The patient should be head up position 15 degree of the table, head is extended, tilted towards the surgeon. That is our concerned area is posterior-superior quadrant area. To reach that axis, this is the ideal position. The incision, coming to the incision, narrow canals, and some of the patients, they have a very narrow space between the malleus and the scutum. In those cases, better to take a lengthy incision, that is about 8 millimeters to 1 centimeter from the annulus. Because you are bound to do more curettage in those cases where the malleus is crowded near to the scutum. The infiltration should be given at least 10-15 minutes before surgery, and it should have a Aoicon and adrenaline and Sensarcan we mix for the routine cases. And after elevation of the annulus, the next important structure to preserve the chorda, always I use gel foam instead of cotton ball to avoid foreign body, and especially in middle ear surgery where you use drill, the cotton balls, I had a better experience of plucking out the stapes. So if you use gel foam, even if you use a drill over the gel foam area, it will not produce complications, especially around the sensitive areas like stapes surgery. So the same situation here. How to avoid injury to the chorda? So the field is very restricted. Then release from the undersurface of the malleus. That's one way of lengthening of the chorda. And the second way is to curate the bony or the chorda canal. That gives a lengthening of the extent of the chorda. In the field, what is required is, for a good outcome is, that's very, very important. Once you open it and chorda is coming to this portion. So what is the ideal field? What is the structure should be in the field of surgery for good outcome is 2 windows, that is round window and oval window, and the 2 bones, that is stapes and the incus, and the 2 nerves, the horizontal portion of the facial and the chorda. If these 6 structures in your field, you will get optimum space for maneuverability of the fistula placement, perforation of the foot plate. All this is very, very important. So once you open the window, open the foot plate, then better to avoid contamination of the bone dust or a gel foam or a adrenal contamination. So for field should be, these 6 structures are the ideal position of the field. While coming to the curating, so if the bone is very thick, make the bone first thin, then edge over to the scutum edge. Don't straight away take out the big chunks of the bone, because if you want to take out the big block of the bone, it may slip and land in the stapes and SL loss and facial nerve injuries sometimes. So curettage must be controlled curettage. It's no fulcrum, only scooping effect. So after middle ear, this is space what we get, 2 bones, 2 nerves and 2 windows. And base pyramid should be visible. This is the ideal place, and the field should never have a vision of the malleus. If the malleus is visible, your field of perforation and insertion will be difficult. So what is the purpose of middle ear wash? If you leave a bone chip, that will attract fibrosis and adhesions. And I had one similar case, after 6 months, patient developed tinnitus and SL loss, mild SL loss. When I explored it, the bone chip is forming a band between the incus and the promontory. That is, it is pulling the fistula into the vestibule. So, not only the bone dust, the other point is what we inject is Aoicon with adrenaline. This adrenaline with intact in the cup leg owl window. When you perforate, this ethanol will infuse into the vestibule and can produce SN loss. So, minimum wash with normal saline is to avoid SN loss. Sometimes we come across successful outcome and the patient is having SN loss or a not good response. Maybe these are the factors. So assessment of the vascular mobility, so routinely we do. The vertical axis of the stapes movement should be done, and whether the incudomallear is mobile or not. Sometimes the malleus can be fixed to the attic. In those cases, successful outcome, surgery is successful, but the results will not be good. Anterior mallear ligament fixation should be excluded with the mobility of the malleus. In European countries, it's very common anterior mallear ligament ossification. When I had been to France in 1999, this Casa clinic, they used to tell about this anterior mallear ligament fixation. They used to give incision up to the 1 o'clock. We usually stop at 12 o'clock. They used to give up to 1 o'clock. The reason is to see the anterior mallear ligament, if necessary. So that is we have to keep in mind. The other point is, so once the mobility is established, is fixed, then the next important point is opening the vestibule. That is with perforation. So clean foot plate and clear visibility and clean access. These are 3 targets achieved. Next, measuring of the length of the fistula. What I do is I put a measuring rod as usual. The other version is take a dummy fistula out of the already sterilized fistula and placing the fistula into the vestibule area and measuring the length of the fistula. That gives it's like a mock drill. Whether after opening the vestibule, your field is sufficient to put the fistula under vision. That's our target. So, the holding of the fistula is not perpendicular. It should be angle 140 degree. That will not hamper your visibility of the field. So, that's very, very important while placing the fistula. The perforating foot plate. The basic principle of this step is the perforator must be perpendicular to the long process of the incus, always perpendicular. And when you are operating right stapes surgery, you have to go to the right of the patient, right side. You have to tilt your chair to the right side. Then it will give good access to the foot plate area, visibility. And the other point is, most of these surgeons we do under local anesthesia. So you should hold the head of the patient, or you ask your assistant to hold the head of the patient, not to perforate the foot plate. The patient may get. So there are incidents where the foot plate has come out and SN loss. So once you are perforating it, the patient should be stable and your head should be under your control. So coming to the foot plate, thin foot plate and thick foot plate, how you manage for the perforation in conventional technique. For thin foot plate, you just place the instrument and rotate it. Never use any force. Never use any force. The weight of the instrument is sufficient to produce perforation. And it should be always sharp. You should have this blacksmiths, they use that stones and papers for sharpening of their instruments. Similar instrument you have to keep in your toolkit, and always when the surgery is over, you will make a sharp of the instruments. So, and the sharpness should not be too much because it may break. The tip of the perforators, especially 0, 1 size, is very delicate and it may break. So never use your force. Only instrument weight is sufficient to perforate it. Coming to the thick foot plate, if you come across thick foot plate, dealing with the thick foot plate is take a 0.8 mm perforator first, 0.6, 0.4, 0.2, 0.1. So that's like it will be like this. Then again reverse, 0.2, 0.4, 0.6, it will become like a cylindrical. This, especially in thick foot plate, just imagine the fistula movement should be perpendicular and free. If it is angled, your perforation, if it is angled in a thick foot plate, it hampers the movement. So that's how you lose the hearing. The gain will not be good. So these are the simple points, but it makes the results always better. So coming to you have to have a good quality pistons. It's lifetime piston. So some of the pistons what I have observed is they are breaking at the junction of the loop and the shaft. Especially when you are doing a loop widening. Some people keep in the fingers and use forceps to widen the loop. It's always not advisable. For a junior colleagues, keep in the jig and pass a probe and just wait for 3 minutes. The memory. If you keep the shaft of into the loop like open, 180 degree must be open. 180. More than that is not necessary. If you try to produce more than that, it will break sometimes. So 180 is, then it is like this. So hold with the forceps 140 degree. That means this is 140. This is a forceps and the piston will be like this. So it will not obliterate your field of surgery. So you can place the piston in the vestibule under vision in the lower magnification. This particular step must be under lower magnification. If you go for higher, it is difficult to handle this step. See, this 140 degree angle. It's clear visible. And if you can hold the loop, the instrument should hold the only shaft, that is 0.5 mm thick shaft, not into the loop. Suppose your instrument is into the half of the loop, it will object or it will block the insertion of the piston onto the incus. So it should hold the edge of the piston with good forceps. Piston crimping is very, very important. But what we usually think that if you make crimping too tight, it will produce hampering of the blood supply and necrosis. It's not. Usually the necrosis because of the either loose pistons and some improperly done perforation. Suppose there is friction. So the incus has to resist, it will get a resistance for the movement of the piston. That produces long run vascular necrosis of the long process of the incus. It's not the crimping force. And crimping is not too tight. Just apply it and wait for at least 30 seconds. It's not good. And the loop, this is a special instrument for that. It has got two limbs, only the anterior limb will move, not the posterior one. Suppose if you use posterior one, it will take out from the vestibule. So after this crimping, assess whether the length is sufficient or not. The bending test and hanging test can be done, but don't do too much handling. And don't try to look at the round window reflex. There is no doubt it is in the whole window. Unless you are dealing a congenital anomaly problem where the whole window is not defined, where you are drilled and identified it. That is a different situation. Don't try to elicit the round window reflex. The reason is it can't produce that much of fluid unless it is sealed, unless the surrounding gap is there. So if you try to elicit the round window reflex, the pressure what you are putting, the air is coming out from this same pocket area. It will not be transferred to the round window area. So these are the this is a crimping. Just wait. That is sufficient. Pressure in the crura. Next step is initially I should do both the removal of the crura and fracturing towards the promontory and take out the. Then those days we used to have mystery bits or so we used to feel so tense. The reason is this foot plate dislocation or subluxation can happen with the force. So what we now after up from 3.5 years, 4 years, I'm taking out the neck and head of the stapes. Because what is needed is here the bypass. It's not the stapedectomy, it's not a diseased stapes. Our aim is to movement of the incus and along the fistula, not the stapes removal. So if you even you leave the crura, that will not hamper in your conduction of the sound. So it makes the job easy. Only crura, yes, 2 minutes. Crura and leave the crura and tendon, and just above the tendon, neck cut and head remove it. That is around 1.5 millimeters. So the movement of the fistula movement is required. Maximum is 0.5 mm. That means it doesn't require 1.5. So it will not touch the stapes. So that's how we achieve our bypass. This is called like a bypass surgery. Next, coming to the sealing of the perforated surrounding, we can put a gel foam because this is not formalin preserved. And those days, olden days, they used to have formalin. We can put a gel foam or a soft tissue from the pinna area, and it should not have gelatin and adrenaline. So the site of incision should not have infiltration of the gelatin. Because we give a block here, but the area of pricking the tissue is not the infiltrated area. Because take care of that contamination of gelatin and adrenaline along with the soft tissue. So these are the few points. And repositioning the flap. Usually we give adrenaline that produces vasoconstriction, less bleeding, comfortable, field is clear. But after 1 or 2 days, a patient may have fullness and there is a collection of blood. Because these edges of the skin will bleed. To avoid that, make a gel foam, wet gel foam of the decatron and press against the meatal wall, like a microembolization of the cutting edge of the meatal skin. That reduces. So I had one case of blood collection and re-exploration. So since then I have started using gel foam, pressing against the 2 edges, and it is almost obliterate any lumen of the small vessels. That's how we can avoid that. Yeah, this is about a few points. Gel foam, take care of the adrenaline. So about wash, middle ear wash, and bone dust should be clearly cleared, and middle ear wash. Uses of antibiotic drops in the middle ear, I don't advise, I don't do for any surgery. We use only decatron gel foam. If at all, if you want to place wet gel foam in the middle ear, it's a decatron gel foam. Because nowadays we are all giving injections, steroid injections for tinnitus, vertigo, or SLRs, hoping that this will get absorbed through the round wind and give the results. The same thing has happened with the ototoxic antibiotic drops. So we can avoid it. It's not a must. And glove powder also. The point is glove powder and the gauze pieces, from the industry they come with the thick, starchy gauze pieces. These gauze pieces are most of the reasons for meningitis. intact eardrum, weeping eardrum with intact and hearing is good, but there is a weeping. It is most of the times it may be this starch. And normal saline should use instead of ringer lactate. Thank you very much.
Very nice presentation.
Teflon, good. How do we know about the quality? Because there are so many brands available, so many local people also.
So the Medtronics is good. Okay.
Which one?
Medtronics and
Acha, Metro. Any other?
Neon company, some Neon company. Indian Audio Center. Indian Audio Center.
Are they still making?
Yeah, I don't think Indian Audio Center, I don't have.
See, that is the oldest one in India, Chandigarh based.
I know, we used to send money orders and all.
But I don't think they are, I am not aware of whether they are
Chandigarh
there.
based company. No, I don't.
But
Medtronics people are having, sir. It's around 6,000. If you purchase in a bulk order, they will be in the price.
Any other Indian company?
Neon.
You know, many doctors, even the ENT people and the other general practitioners, when the patient goes with a hearing impairment, they always try to say to go for a valsalva maneuver, to blow out the nose. So, over a period of time, the TM becomes thin.
Yes.
See, this is not uncommon. This is not uncommon. Because
overstretched. Overstretched. It's
yes.
not physiological. We are producing forcible.
That's right. Right. So I have seen in few of the patients. Post-operatively, one of my patients, his hearing was absolutely fine, and after
TAP surgery.
Yes. And the
unless you do something like vein graft technique, we don't advise Valsalva for those other people. Only those people need Valsalva for one or 2 days.
Not post-operative.
Not too much.
Not post-operative.
Not even after tympanoplasty also. No.
Yes.
No forceful blowing.
Not at all after TAP surgery should not be done. What I am saying is, have you ever needed to reinforce the tympanic membrane? I have been doing
only the situation where initially I used to give small incisions and a lot of curettes. Then I used to put something for it to prevent retraction. Otherwise, thank you.
Thank you. आप यहाँ रहो.
For this talk. So I'm a pediatric ENT and I worked many years in Lady Harding Medical College, then had my fellowship in pediatric ENT from Cincinnati Children's. And this topic is very close to my heart because it's one of the leaping futuristic treatments which have come up recently. And when we were doing our residency, there were only two things: either it's a cystic hygroma or a hemangioma, or a venous hemangioma, arterial or venous hemangioma or capillary hemangioma. And we were taught to think in these lines. So if you look at this, a lot of people would answer that it's a hemangioma of the tongue, and this will be a cystic hygroma of the neck, and this will be a capillary hemangioma of the nose. But the truth is, unless you do an MR angiography, you don't know what exactly it is. Because this can be a lymphatic malformation, this can be a AV malformation, and this is a venous malformation, and this is a hemangioma. So don't go by the looks or the volume or the site. Unless you have a radiological imaging, the diagnosis is not clear. And it's very important to have the correct diagnosis because the treatment is dependent on that. And you know what to expect, and natural course of the disease is entirely different for all the different entities. So this was a child who was referred to me for surgery for cystic hygroma, and it looked almost all right. The child had an ultrasound and a CT scan which reported it as a cystic hygroma, and the only thing which was disturbing me was the reddishness in the ears, which they labeled it as otitis externa. But if you look at very closely, it has some ulceration and few other satellite lesions. And this is giving a big hint that it's a hemangioma rather than a cystic hygroma. I'm glad I did not operate the kid. We did an MR and it was confirmed with flow characteristics that it's a mixed lymphovenous hemangioma, which has hemangioma with some lymphatic involvement. And just with propranolol therapy and steroid therapy in 14 months, the lesion completely disappeared. And it would have been a disaster if you would have operated this lesion. So Virchow had, first insight into the different types of lesions. And then finally it was 2014 when all the definitions were taken away and they came up with only one standard treatment. Either you're looking at a tumor which is called a vascular tumor or it's a malformation. And everything has been put into one blanket diagnosis as vascular anomalies. So if you look at this, so first thing first, when you see a vascular lesion, a vascular anomaly, you have to put in one of these two baskets, which is a vascular tumor or a vascular malformation. The basic difference here is, in vascular tumors, it's an endothelial problem. There is endothelial proliferation. In vascular malformation, the number of blood vessels increase, but the endothelium is exactly, endothelial cells are more or less normal. And then with these classification, the things which we see now are relabeled as capillary malformation, lymphatic malformation, venous malformation, AV malformation, and that's the code they use for the CVM, CLM, LVM. And if it's a tumor site, these are the different tumors which you have in the ISPA classification. There's a 2018 version and a revised 2022 which is coming up. But broadly they are the same. Same kid, next time it was much easy. However, this kid did not respond to propranolol because it was a congenital hemangioma. So there's a difference between infantile hemangioma, which typically starts after 15 days of birth or 3 weeks of birth, and there's one which is present at birth, and they lack what we call as GLUT1 receptors are absent in the congenital hemangiomas, but they well respond to oral steroids, vincristine or interferon therapy. So this is a case which came to us, a 2-year-old boy with stridor, and he was admitted on the pediatric side. Stridor did not improve. Pardon me for the video, but it was taken through a cell phone attached to a flexible laryngoscope. But you can see there is a subglottic mass sort of a lesion. Why I wanted to put this lesion is subglottic hemangiomas are never always bright red. They always come in a very confusing manner, and you can't always do an MRI or CT because the child is very sick. You may just miss it. They look like more like edematous, little reddish tissue, but they're never like a bright red hemangiomas what you see on the skin. But the miracle is propranolol here. If you give propranolol in 72 hours, the whole problem completely reverses. So much of that this patient refused to do a check laryngoscopy. He said, my child is all right, why do you want to trouble him with a general anesthesia procedure or a laryngoscopy? But there are other lesions, and these are the different subclasses of hemangiomas which are called, which have different components. Like this hemangioma, which was in subglottic area, had a lot of lymphatic component. And the way we do it is by narrowband imaging, where the blood vasculature can be seen. And it's like more like a mucosal edema rather than actually a classical hemangioma. And this patient did not respond to the medical treatment. And in the end, what we had to do was open up, submucosally remove the whole lesion, and after that we had to put a Ehler graft, and that's how it looks. So even though the hemangiomas respond to propranolol and steroids, some of them may not, so be prepared. If there is no response, be ready to operate them open. Now there are only 3 treatments for hemangiomas. Either you give steroids, a surgical excision, has the highest success rate. Failure is only less than 5%, and propranolol. The only problem with us is we use propranolol much higher age. At the age of 15 years, 20 years, 25 years, it doesn't work. In infantile hemangiomas, it only works up to 5 years, 6 years at the max. And when you look at the infantile hemangiomas, they always are more or less absent at birth. Some spots are visible at 2 weeks or 3 weeks, and over the time they grow up into a big size. By 1 year, they're fully grown up, and by 3 years, 4 years, they gradually grow more, and then they start regressing. And these are the new tests which are advisable, GLUT1 receptors. So even though it's a vascular lesion, we recommend taking biopsies of hemangiomas, because if it's GLUT1 receptor positive, they are going to respond to propranolol. If they are not negative, they are not going to respond to propranolol. And the duration of treatment is about 14 months to 2 years. So it has a significant toxicity. So these are the different types of hemangiomas, and you have to deal with what is called as a look for faces syndrome. MR is the most diagnostic, and you can see these voids in the blood vessels, which is basically of a proliferating hemangioma. Intense blush is taken by hemangiomas, and this is what is called a serpiginous vessel, which is diagnostic of a hemangioma pattern. You also have to operate if there is a function loss, if the hemangioma is coming on the eye or can cause potential heavy bleeding, then it is better to operate than go for a medical treatment. Now, propranolol, systemic corticosteroids, interferon, vincristine, they are the main treatments. Nobody knows how propranolol works. There's a complex mechanism, but it has something to do with nitrous oxide, VEGF, but exact mechanism is still not known. And we don't even know why it does not work in certain patients. But if you are a GLUT1 positive patient, which is glucose receptor, uptake receptor, the chances of success are much more. In our series, we had this unknown, previously reported unknown complication of alopecia. So 2 of our kids developed alopecia after 1 month of propranolol. So be careful to consult the patient about alopecia when you're giving. The serious side effects are hypoglycemia, heart failure, bronchospasm, and worsening of asthma can occur. So it is always done in conjunction with a pediatric cardiologist who will take and escalate the dose. Because after 3 months, the dose will almost go up to 20 milligram for a 4 kg child, which is almost like an adult dose. So it has to be slowly escalated to that dose. So this is what I was trying to say. Congenital hemangiomas are different. Now these are some other cases which look like hemangioma of tongue, but they are not. This is a case of a lymphovenous malformation. But he underwent sclerotherapy elsewhere because they saw it on my prescription, and when I told them the cost of the treatment, they thought we can get the injection much cheaper. They went at someplace else, and the boy landed up with severe macroglossia, unable to breathe. So these sclerotherapy injections have potential serious side effects, which you have to be very mindful of. And the exact way of giving the injection is to divide it into quadrants and divide the dose into every single quadrant. And the quadrants which have the maximum lesions are given the higher doses, and the quadrants which are better are not touched. Like the base of the tongue here is not touched because there was no lesion in the MRI. So this helps to reduce the complications. So after a few days of conservative management, again that kid was taken off sclerotherapy. Few ulcers came in, but overall the kid did well. You can also have a predominantly venous malformation, which come like pockets in the tongue, and they do extremely well with sclerotherapy. All you have to do it is inject submucosally, not inside the lesion, just in the submucosal plane, bleomycin, and even in a single sitting, you can see these lesions will disappear. This was a tough, challenging case. Patient had severe stridor, couldn't eat, and suddenly his venous malformation had capillary component, it had a lymphatic component, it had a venous component. So there were phleboliths inside the tongue, and it was completely engrossing all of the tongue. Now this would have definitely gone for a tracheostomy and few other things. But what we did was, along with the sclerotherapy treatment, we also started him on a drug called sirolimus. Sirolimus does act, but it does act very slowly. It takes about a month for it to respond. And as his lesion was shrinking, sirolimus made sure that he didn't have any potential airway effects. And this patient was managed conservatively without any tracheostomy. The other drugs are OK432, sodium decasulfate, tetracycline. I do not use them because of OK432 is difficult to procure. The others have their own side effects. But you must remember there's a lifetime dose. How many injections you need to give the patient has to be decided before you start sclerotherapy, because if you're reaching 400 milligram, pulmonary fibrosis will happen. So your planning should be accordingly. So this is a video just to show that how you divide into quadrants. It doesn't matter if it's in the neck, face, or anywhere in the body. You divide in the quadrant and give him either submucosally or you can give subcutaneously. You do not generally try to go inside the vessel and give it. That's just a bad idea because it will fibrose the muscle and the tongue will become woody hard and patient will have problem with speaking and chewing food later. The more difficult part is managing these patients post-operatively. So this was the lesion which we started before the injection. Day 1, swelling, blackening of the tongue. Day 2, the child can't move the tongue at all. And the tongue starts sloughing here. Day 3, you see severe pain. And what we used is a off-label drug called lanolin, which is available on Amazon, which is basically was for broken nipples in nurturing mothers. And over a time, in 2 weeks, generally this sloughing and everything settles. And then the movement comes in. So the rashes are very common things. Other things are gastritis, tinnitus, which is common. They can be lymphovenous malformations in different areas, in larynx, tongue, other places. And you might have to go and deal them there. So sclerotherapy is extremely effective. So these lesions were all dealt off. So now there is a tracheostomy, sclerotherapy, biological, and there is an observation. This is a study which kind of shows that observation also gives good results. It's okay not to do anything in a lot of these patients. Like this patient went for active observation. We did not do anything. In 1.5 to 2 years, it kind of resolved spontaneously. So now there's a whole philosophy of new drugs called mTOR inhibitors and PK1 inhibitors, which can almost solve all these. I'll just take 30 seconds more, sir. Without surgically operating these lymphangiomas, lymphovenous malformations, capillary malformations, and these are the new drugs. So this is another kid who had, hemangiomas everywhere, and we took like 4 hours to operate. His base tongue laser was done, epiglotopexy was done, so many things. But once we started him on one of these drugs called sirolimus, the lesions kind of settle down and they are much better off. You can actually identify larynx and trachea. In the previous video, none of these structures, even the tongue, the palate, nothing was visible, and this child is now decannulated now. And 5 years back, without the medical treatment, this would have been an impossible task because you cannot give sclerotherapy to such an extensive area. Sometimes, collagen disorders can also manifest. Like this case had aortic dilation causing complete narrowing of the trachea. And the child had a Marfan syndrome actually. So if you just see the trachea, down near the carina and bronchus, these vascular enlargement can cause blockage of the trachea. So we took this kid for a surgery called slide tracheoplasty, which was halving the trachea and sliding it across. And after the procedure, the troublesome part was dealt off. But the other things which were also needed to be done was iotopexy. So this surgery is usually done by an ENT and a cardiac surgeon together, where you remove the thymus and readjust the aorta anteriorly so the tracheal compression can go away. So this is the last most important. These are the drugs you should have in your mind. Alpelisib, miransisib, sirolimus and aspirin. They are the ones which can make these vascular lesions disappear, and 5 years from now I'm pretty confident surgery will be a thing of past for these lesions. It would be mostly medical treatment. Even for the notorious AV malformations, there's a new drug which has come up called tremitinib. There's a whole lot of big syndromes which can be treated by mTOR and PIK-RA inhibitors on this side, and there's a whole lot of lesions which can be treated here by steroids and tremitinib on this side. It will take 2 to 3 years, but we will get there. Thank you so much for your time.
Thank you very much for that excellent exposition of your experience. It's a really rich experience and all of us will gain from it. Thank you, sir.
One and all present here, respected chairpersons and the AOI, for giving me this opportunity to present my experience in dealing with vertigo presentation in children. So my topic for today is study the diseased child. So as all of you, the august audience present here, you might be very familiar with dealing with vertigo, dizziness as ENT surgeons in adults. My name is Dr. Anusha. I'm experienced with vertigo in children. So as you see in this video, we have an infant aged about 6 months old, which presented to my OPD with this paroxysmal events, which was initially suspected as seizures. Okay, here you see infant is having some staring, it is looking in one direction. So it's most commonly easily confused as seizures. So, but you can also see when the mother is trying to feed the baby is able to take the feed. That means there's an awareness present, there is no impaired awareness. And as the video progresses, you can see that the baby intermittently will have lateral movement of the neck, something like a cervical torticollis. There is recurrent episodes like this. So every now and then the child used to have this paroxysmal movement with torticollis of the neck, which was initially confused as partial seizures or with impaired awareness. So when this child came to our OPD, because we evaluated further, there was no impaired consciousness. It looked unlikely to be a seizure, something like a seizure mimic we thought. And then on further evaluation and more detailed history, we came up with the diagnosis of benign paroxysmal torticollis of infancy. These children present with recurrent head tilt secondary to cervical dystonia. These can often be accompanied by vomiting, pallor, and some kind of ataxia. They present, the duration will be for hours to days, and some kind of tortipelvis, that is like excessive arching of the torso, retrocollis in the neck, excessive neck extension due to neck muscle contraction can be associated. So when you evaluate such children further, you will find a family history of migraine and as you are familiar with, familiar hemiplegic migraine genes like CACNA1A, PRRT2, ATP1A2 can be there. And it usually occurs in the first year of life, and it's a self-limiting and resolves by the time the child is 5 years. So why I started in this case is to bring an awareness that vertigo is not something which you see adolescent onwards. It can manifest as early as an infancy. So this benign paroxysmal torticollis of infancy, it may be self-limiting, but it can further evolve into either benign paroxysmal vertigo of childhood, vestibular migraine, or other typical migraines as the child grows older. So as we all know, vertigo is an illusion of motion. It's mainly a space sensitivity, and it presents like an illusion of motion to the patient or regarding the environment. But very often in our OPD practice, we interchange the words vertigo and dizziness. Dizziness is a different sensation. It is an altered spatial perception without any false sense of motion. So basically, vertigo is something objective with related to the external motion, and dizziness is subjective, like the patient experience himself. It's a subjective sense of instability. So it is very important to know the difference between the two. So the signs of poor vestibular function can present in the starting from the early infancy. We need to have an eye for what to look for, like low muscle tone, delayed loss of the primitive reflexes, delayed gross motor milestones, developmental delay, and they can have associated seizures, nystagmus, and torticollis. So coming to the difference between children and adult in vertigo. So a very common saying which you would have heard, children are not miniature adults. Okay. So what we experience with these children who have experienced with vertigo is like they have difficulty in describing the symptoms. So as the doctor, we have to elicit that history from the parents, and with your own observational assessment, you have to come to a diagnosis. And the nystagmus also in the children may be difficult to appreciate when in the early cases of vertigo. And children are more likely to have than the classical vertigo, vertigo-related migraine presenting like headaches are more commonly seen. And in adults, as BPPV and Meniere's are very commonly seen, these are not the most common etiologies seen in children. I'll be detailedly telling about the different etiologies, what we commonly see. And the vascular etiology also very less common as compared to the adult population. So in the children, what do we commonly see? We commonly see benign paroxysmal vertigo of the childhood, we call it as BPVC, and vestibular migraine. So BPVC, we see up to 3% of the childhood population, and brief attacks of vertigo is there, which can have vomiting, pallor, and increased perspiration, some imbalance, plus or minus nystagmus. And it begins before the child is 4 to 5 years of age, and resolves by the time child is 10 years of age. So, but BPVC is not BPPV. Okay, BPVC is not related to the specific positions of the head, and it's not so. Hence, it's different from BPPV, and it's not associated with loss of consciousness. It's different from seizures. So. And another common entity what we see is vestibular migraine, and the exact prevalence is not very well established, and mostly these two, VC and vestibular migraine, have an overlapping presentation, and most likely they can be a part of the same spectrum. So what is the new update which came out in 2021 in the Journal of Vestibular Disorders is that the International Society of Vestibular Disorders and the Barani Society, along with the International Headache Society, came up with explanation that BPVC, benign paroxysmal vertigo of childhood, is a term which is a little confusing and we no longer need to use. So they came up with the 3 different terms, that vestibular migraine of childhood, probable vestibular migraine of childhood, and they gave a new term named as recurrent vertigo of childhood. So RVC, recurrent vertigo of childhood, is the new replaced term for benign paroxysmal vertigo of childhood. So there is a role of migraine component in all these 3. So in vestibular migraine of childhood, there is definitely a migraine history and the migraine-like presentation. In probable VMC, there is a probable migrainous features, and in RVC, it's mostly absent. The migrainous features are absent. So what is the vestibular? I'll go in detail quickly about each one. Vestibular migraine of childhood. This is the diagnostic criteria published in 2021. So at least 5 episodes of vestibular symptoms of moderate to severe intensity lasting between 5 minutes to 72 hours need to be there. So what are the vestibular symptoms according to them which we need to elicit in children? Are spontaneous vertigo, like false sensation of self-motion, external vertigo, sensation of spinning or flowing of the visions around you, and position-related, head position-related vertigo, and triggered by specific visual stimuli, and other kinds of, and it may be associated with nausea and vomiting and other symptoms. And what is, they also told it is of moderate to severe intensity. Moderate intensity means it interferes with the child's daily life, but it does not obstruct or prevent it. So severe intensity means it obstructs the severity. And the other rest of the criteria is past history of migraine should be there, and at least one of the 3 migraine features, headache with unilateral and pulsatile quality, moderate to severe pain, aggravated by exertion, photophonophobia, and visual aura. And the age, of course, less than 18 years, and we were not able to put any other cause to it. Then coming to the diagnostic criteria of probable vestibular migraine of childhood, at least we need to have 3 episodes. There I told 5, here it is 3 episodes of moderate to severe intensity. The duration is the same, 5 minutes to 72 hours. And only one of the criteria, B or C of the previously what I mentioned, need to be there. Both are not required. So coming to the new term, what I just told you, recurrent vertigo of childhood. So here, the diagnostic criteria means 3 episodes of vestibular symptoms lasting 1 minute to 72 hours. There, in the VMC, we told from 5 minutes to 72 hours. Here, as less as even 1 minute can be taken as diagnostic. And none of the criteria B and C, which I told you of vestibular migraine, is there. And age less than 18 years. So there are studies going on regarding the subtypes of RVC, like only some present with migraine features, and some without any migraine feature. They can present like a pure vertigo, pure episodic vertigo, and these episodes of vertigo just occur for less than 5 minutes and disappear. And another subgroup where there are only some ocular vergence movements are there. So these will be, with further studies, will be explained better. As of now, they're just like a theoretical going on. Coming to the treatment, we consider prophylaxis in these cases when the attacks are more than 3 per month, and if the symptoms are very severe, affecting the daily life. And the medications are quite similar to what we use in the migraine in children. And we use like flunarizine, ciproheptadine, and triptans, and some antidepressant like amitriptyline can be used, and as a prophylaxis to reduce the vestibular symptoms. And see, there are no specific RCTs or guidelines regarding this. Basically, you need to, it is a joint decision. You have to talk to the parents, explain the side effects, and then you have to take a call. The other causes, which I'm sure like recurrent episodes of serous otitis media, what I need to tell is if there is a child with recurrent vertigo coming to you, otoscopy of course has to be done, and you need to see if there is any otitis media which has progressed to the serous otitis media affecting the inner ear, and which is causing vertigo. And in these cases, as procedures as simple as a ventilation tube, or like when you give a course of antibiotics and treat the otitis media, it's more easily solvable. Then coming to the other things like labyrinthitis, vestibular neuronitis. So labyrinthitis we can see with viral infections, and mumps especially has deafness also associated with it. And serological tests help us in the diagnosis. Vestibular neuronitis. So these vascular or viral causes can be this thing. It is mostly described with the herpes simplex virus, adenovirus, and enterovirus. And coming to the treatment, see, adults, there is systematic review, like they've shown the evidence of using steroids. But in children, they have tried, but you can try a course of steroids for a week, but then it is still, it is a decision you need to make, because as there are no RCTs, and other drugs used are dimenhydrinate. And so coming to the other causes, sensory neural hearing loss due to cochleovestibular anomalies. And so these typically present with disequilibrium and motor developmental delay, not your typical attacks of vertigo. Okay, and they have this is why vertigo will not occur, because most children, they present with profound vestibular impairment or areflexia, and like from the childhood, and this is not like a sudden stepwise progressive loss. So so you won't get your typical history of attacks of vertigo in these. And the regular, like the cochlear-vestibular anomalies which you see are the vestibular aqueduct which is enlarged, and also you can see this with the congenital CMV cases. Then another different entity, functional and psychiatric causes for dizziness. Okay, so which we see most commonly in the adolescents, which you need to keep in mind when you have an adolescent with coming with something like dizziness or vertigo. And so they have baseline episodic like psychiatric disorders if you evaluate further, and like there will be exacerbation episodes, and there is an entity which has been defined as persistent postural perceptual dizziness, PPPD. It is a functional neurological disorders associated with non-vertiginous dizziness, and they have a sense of imbalance which is exacerbated by positional change, and always they'll have some baseline dizziness at a constant low level. Only when they go to a certain places and a certain visual flow when they have, these perceptions are exacerbated. So careful history is very important, because what place or what event or what interactions trigger these episodes, that is a very clenching history which you need to take. Then accordingly, then you can screen for the underlying psychiatric disorders, and treatment in this case will vary as cognitive behavioral therapy, physical therapy, and use of SSRIs like fluoxetine and escitalopram we have tried in these children. Then hemodynamic orthostatic dizziness is another thing which we see. 5 episodes are present during the upright position. This is the diagnostic criteria, which subside on sitting or lying down. It is like seen with orthostatic hypotension, and which is defined as at least 20 mm reduction in the SBP and DBP reduction by 10 mm Hg in 3 minutes of standing, and postural tachycardia syndrome, which can see steady raise in the heartbeat at least 30 beats per minute, or a heart rate of 120 beats per minute or more within 10 minutes of standing. So these conditions we just need to keep in mind when we are evaluating, more so in the adolescent period. And the common cause in adults, which we also see in children but less commonly, is BPPV. And so it can be differentiated by your recurrent vertigo of childhood, which I just now told, because in this, there only specific head movements will cause the vertigo, and there is a like positive diagnostic with Dick Halpike test and the Sermon maneuver. Triggers as such can be very challenging in children, because they always, children will be playing up, down, and like, they keep their head in hanging positions. So it's very difficult to clench this diagnosis. Okay. So BPPV treatment, okay. Short, I'll just take another 5 minutes. So vestibular paroxysmia, it is similar vertigo episodes which last less than 1 minute, and they show very good response to sodium channel blockers. Meniere's disease is also possible in children, but it's a very rare entity. I will not go into much details. And I would like to tell also vestibular epilepsy, which will present in lesions in temporoparietal junction or insular cortex. And these are epileptic phenomena. It's like a partial seizures, and which have some aura staring episodes along with the feeling of dizziness. And the EEG will of course help us in the diagnosis. The neurovascular disorders like arteriovenous malformation which causes compression to the vestibular nerve or the brainstem nuclei. Then posterior circulation stroke due to cervicocerebral artery dissection can also be seen in children. And other vasculitis in systemic causes like SLE, GRA can also cause impaired vertebrobasal circulation leading to vertigo. Moya disease also, we have seen one case with only presenting like vertigo on standing. So other thing is episodic ataxia, which we see, and type 2 is very common. They, along with the vertigo episodes, they have other history of ataxia, dizziness, which is triggered specifically by exercise and stress. And more than 90% of the patient in between the attacks, they'll have other symptoms like headache, diplopia, dysarthria, nystagmus, which is mostly downbeat and gaze evoked. And between the episode, these are there and are more exacerbated during the attacks. Gene CACNA1 gene is the gene implicated, and carbonic anhydrase inhibitor like astazolamide plays an excellent role in this case. And posterior fossa tumors, of course, and other lesions can also lead to vertigo. Then rare causes like ocular and idiopathic heterogenic. And these are all until now I told you non-life-threatening, like of course in life-threatening cause like trauma due to skull fractures, cardiac arrhythmias, CNS tumors, demyelinating, these are also other causes for vertigo. And demyelinating in that, you can have like an acute, we have seen cases of demyelination where there is acute presenting like acute vestibular syndrome, and this is also a possibility. So imaging will help us in the diagnosis in these cases. And these are some assessment tools: Vanderbilt Dizziness Handicap Inventory for patient caregivers, which will help in quantifying the impact of dizziness in children between 5 to 12 years from the caregiver's point. So we can take the help of parents in using this. And Pediatric Vestibular Symptom Questionnaire, PVSQ, will help us discriminate various vestibular pathologies in children with almost like 95% sensitivity. These are my references which I've used for my article. And thank you. Thank you, everyone.
That was an excellent synopsis, and it started with a wonderful case presentation of showing a child with benign paroxysmal torticollis of infancy. So thank you for that beautiful presentation, and you made all our experiences rich. Thank you so much.
Thank you, sir.
Our next talk is by Dr. Kailash Pujari, sir, who will be speaking on aging versus ageless surgeon.
Whoever is still waiting here are all your fans, so they will not mind. You carry on.
They're forced. Okay, thank you, respected chairpersons and dear colleagues. I'll be talking on a slightly offbeat topic. This is, I think, will be looked at a little bit of skepticism, maybe, and a little bit of amusement by some. There's some of the article that was written some time back by a surgeon who at the age of 60 and at the age of 67 looked at his practice, and he said that the technical know-how was intact, but the movement and sequence took a little bit longer, and at times there was omission of a step, which is unexpectedly scary, especially when you're operating. So the key to this, he said, was to lead a healthy and fulfilling retirement is to stop operating, right? When you actually feel that way. When the other extreme is also there. This is by a 91-year-old so-called surgeon who said, I do not being operated on a surgeon of 91 years old. So these are the extreme of it. If you look at the lifespan of people, it's increasing now. We have an aging population, which includes doctors, whether physicians or surgeons. And in the UK, you see at the age of 65, you stop operating, for the NHS that is, right? And at 70, you stop practicing. You're not allowed to practice, right? These are the rules as per the UK system. In institutions, there are no objective methods that how to check the cognitive assessment of the person or even the manual competence of the person. Most institutions do not have it. Some institutions in the US do have a system in place, but it's difficult and can be challenged in court. So the things that can be looked at, one is personal. That is by the head of the department. Again, that becomes difficult, especially if the person you're assessing is your mentor. Yeah, you cannot tell him that this guy was bad. He taught you, right? So even by the residents, you can give an informal this one by the residents, right? And also by the paramedical staff and the nursing staff, and visualized outcomes. This guy is taking too long for surgery, right? He is omitting certain steps. The complications are more. The lawsuits are more. So these are some things we actually look at. One is the cognitive function of a person, the clinical performance, the quality of care, whether it's standardized and it's maintained over the years, it is diminishing or is actually improving. It can happen where actually with age, people get better and better and find things that the younger people cannot. The smaller complications, the smaller steps that are missed. And of course the litigations. So what they propose in some places, if you look at literature, there are almost 70 to 80 articles on the aging surgeon, right? Whether what tests to be done, when should they stop practicing, and they also say that this is actually just our opinion, and these tests cannot be confirmatory. So what they look at, the manual dexterity, the frailty of the person, vision and hearing, muscular movements and nerve conduction. And again, in some places they propose that simulators should be used, right, to see whether the person is actually good enough to continue practicing. And of course, an audit. Audit means based on the complications and also the lawsuits, mainly what they look at in hospitals. Well, whether there should be a mandatory retirement, most of us will not be happy with it. But then if you look at pilots, they have mandatory retirement, and most of the professions have. And of course, in most institutions, even in government practice here in India, there is mandatory retirement. Okay. Why do you resist retirement? One is they feel that the person, after practicing so many years, bossing over your juniors, terrorizing the residents, well, they develop a lack of self-esteem, the fear of death, that I have nothing else to do in life. And next thing is resistance to change, that I can do something different in my life. If you're prepared for it, well, you've accepted your retirement. And also something better, probably more better in life. If you look at what most people do, is there's a performance slowdown, right? What you can do is develop new skills. Yeah, but that is sometimes difficult after a certain age, right? Unless you are mentally prepared for it. I see my professor here. You see, every time he is at a conference, he wants to learn new things. Yeah, he wants to do something different. Every time he goes and comes back, and he tries something so that's for the betterment of the patient. Reduced motivity and creativity that occurs with age. You're slowing down. You said, okay, I've done enough in life. I just want to practice. Yeah, those things slowly creep into your mind unless you're really active. The ability to cope with stress and change, that again is sometimes difficult at an older age. You may look at the one thing, that is of course experience. There are various studies that have been done. One is when they sent a circular at this one, the age, yeah, in 40% at the age of 40, they said that between 40 and 50 said they had no retirement plan. And between the age of 40 to 50, they said only 3 of them said we have actually decided what we're going to do after we retire. As you go older, that is, then they decide that probably there's something else we need to do after a certain age. One of the things is the decline in the workload, right? You restrict your practice. The other thing is, of course, you look at is your peer review of what they tell you, your peers tell you about your ability. Sometimes you take it seriously, sometimes you don't. Depends how you like the person or not. The personal and institutional problems with continuity, like when you're stepping on somebody's toes, becomes difficult. And also in institutions, when they need somebody younger, it becomes a problem to continue with certain people. These are all certain problems that are there in most places, not only in India, but abroad also. There's Greenfield to look at the physiology of aging. He said there's definite performance slowing down, decreased ability to learn skills, decline in motivation and creativity. But this is not universal. Yeah, it is not with everybody. There are some people who still have that motivation and like to do something new, right? They continue to do so. They keep reinventing themselves. He also said with age, this is physiological, there's reduced strength and dexterity, the lumbar spine motion is reduced, the nerve conduction is reduced, and the lactate diffusion after strenuous exercise also is less. So based on this, he said the performance of the person will be slightly impaired, right? You see pilots, most often we compare ourselves with pilots because even when you look at what is called as distracted doctoring, another topic which I used to talk on, in pilots again, so that they don't miss certain critical points, they have a checklist. And there are critical phases when they take off, landing, which is very important, and during their landing. So these are very important parts in a pilot. At the same time, when you're looking at retirement and other things, they look at even a pilot's life. Yeah, so every 6 months they are assessed. is right from the early age itself, unlike in doctors. And they do random blood and urine analysis, especially for substance abuse. They check for certain things where a person cannot fly after that. If they have insulin-dependent diabetes mellitus, angina, coronary artery disease, myocardial infarction, heart valve replacement, pacemaker, and heart transplant. All this is not so common in most places, especially in doctors. And they have annual simulator tests and unannounced checks also. See, the competency and volume, performance and outcomes, they can be assessed in various ways. One is the reaction time, the time to take a decision. They look at the cognitive decline over time, the decline in the psychomotor skills, dysfunctional antisocial behavior with age, substance abuse and the failure to keep learning. These are some things where a person will not do by themselves. This has to be assessed by somebody else, right? Questionnaire filled out by somebody else who's the probably immediate supervisor or the administrator. I'll just skip these slides. Most of them are the same. Another survey where they checked with 238 retired surgeons. 75% enjoyed retirement. 49 said life was better after the retirement. 7% were unhappy because there was reduced intellectual stimulation, reduced outcome, and the last thing, I'm not sure whether some people will agree, missing colleagues. Right? It's not universal, but some people do miss their colleagues. And of course, there are some things where you have the post-retirement activities outside medicine and in medicine, which is non-surgical activity. Yeah. So they also noted that it varies with person to person in this study. Right? There are some who are happy with it, some are not. The other problem is, of course, as you age, the changes and progress in the field and the protocols, whether diagnostic and therapeutic, you don't keep up with them. Some of them, not all of us. But the other extreme is the shortage of experienced health professionals. That's why we need some people to continue the practice either part-time or with a restricted practice. So some of the suggestions that were made was to remediate, restrict, or retire. Remediate means change your practice from what you're actually doing to something which is better, which is more modern, right? Whether it's diagnostic or therapeutic. Restrict your practice so that you're able to focus more on some patients, right? Well, there's nothing, as per Deepak Chopra's book, there's nothing inevitable about aging, but you do not have to grow old, that is mentally. Keep working as long as we can, right? Well, you keep yourself mentally active. If you look at the dictionary, you'll find ageless, never appearing to grow old or looking old. The other one is lasting for a long time or forever, what we call India as evergreen. Well, retirement or retirement. Retirement is rethreading the tires, the next phase in life. Yeah. You can do something different or continue in a better way. This is by William Osler. A teacher's life should have 3 periods. Study until the age of 25, investigate until 40, professional at the age of 60. At which age I've highlighted that because I'm hoping during my lifetime that happens. I would have him retired on double salary. Right? Strive through intellectual stimulation. That's why you continue working, yeah, because you're mentally more active, you're still active. Yeah, otherwise you become dull. If you're not doing anything, you're sitting at home watching Netflix, which sometimes I do, but then that way you tend to become more dull with that, right? You're not doing something more when you need to think. Then next thing is, of course, a sense of gratitude. That's why they tend to continue working, so that they want to contribute back to the profession where they have gained a lot. What are the roles they can play? One is the educational role, teaching, yeah, undergraduates, post-graduation, medical education, development of curriculum, create teaching modules, monitor etiquette. Like if you look at the current crop, if you how they behave in front of patients is not so polite. Yeah, when they talk of something different while when they are with the patient, and it becomes quite uncomfortable for the patient. Distracted doctoring, yeah, doing things like looking at the mobile when they're talking to the phone, talking to somebody else while operating. Yeah, these are all things which can be monitored by somebody who's seasoned and knows the importance of the critical steps that are required. In clinical, of course, you need to reduce practice, imparting skills in the hospital and the laboratory, management creating guidelines in the hospital, whatever it may be safety guidelines, checklists in your profession or in your field, and of course, research, contributing towards research, guiding in research. Knowledge and experience last for a lifetime. Yeah, that is actually a well-known fact. The only thing is, with age, what reduces one by one, initially the strength, then the eyesight, the dexterity, and then the cognition. So that's why in US they have recertification. In the UK also they have recertification of your degree, which is mandatory. We do have it, but it's not so, it's not so streamlined in our country. So the other things you can do is, right, hobbies, friends, stay healthy, save a bit, plan a bit, spend a lot of time with your family, right? So to conclude, we may grow old, but that is inevitable. Who and what decides when it is time to quit? Whether we do it ourselves, we have to be really strong-minded and think objectively to do that. Whether peers or the management or of course the courts. Can we remain active? Yes, you can in a lot of ways and give back to your profession. Reinvent yourself, do something different, right? Though in a small way, it can contribute again to your profession. Doing it at one's own pace. You don't have to be as fast as the younger crowd. Yeah, you can do it at your own pace and still do a good job. Yeah, and of course, have a checklist that as you grow older, that you don't miss certain steps. This is quite a few people in the US have a checklist which they have for every surgery, so that they don't miss a step, whether they're young or old. Okay, these are some of my references. I said there are a lot of references of this in the articles in the can I take, if there are any questions? Okay, I'll just go quickly through this. This is my free paper. I was supposed to present it yesterday. I'll just go through these slides. Yeah, this is on seborrheic keratosis of the pinna, resection and reconstruction. This is a benign tumor of the lesion of the skin, right? Mainly in the head and trunk. Involvement of the pinna is not common. The various factors which have been mentioned, ultraviolet exposure, human papillomavirus, right? It more commonly affects the elderly, right? You can see it's more of a cosmetic problem, but there are other things also which I'll come to later. Yeah. So this is what we have done for this lesion. We have resected and used a post-auricular skin flap, rotation flap to recover this, to cover that defect. You can see the initial part where it is rotated and kept, then the release, and the final thing after 3 months. There's another lady who had a lesion in the concha, resected, and we used a skin graft. Yeah. The main thing about these grafts, you have to remove the subcutaneous, the fat and the soft tissue, yeah, so that it doesn't, the graft take-up is better, right? So this histology. The importance of the histology is you have to take multiple serial cuts, because in some of these patients they have been reported to have squamous cell carcinoma, melanoma, yeah, or basal cell carcinoma, right? It's seen in advancing age, right? And the differential diagnosis again, more important than of course will be basal cell carcinoma, squamous cell carcinoma, because these have been reported in literature, which to coexist with the seborrheic keratosis. Treatment, there are multiple treatment options, complete excision, but still the recurrence rate is high. Yeah, you remove it, one because of aesthetic reasons or social stigma because lesion the pinna. The other thing is possibility of malignancy in that. So to conclude, yeah, there's a rare lesion of the pinna, resection to rule out malignancy, and also for social and aesthetic reasons, recurrence rate is relatively high, and of course you need to reconstruct that area. Okay, right. Thank you.
Please, sir. Wait.